Dan Matthew at Gmail like the thought niligiran.
पशुभिः च एवं वेदम् ॐ महादेवी च विद्महे विष्णुपत्नी च धीमहि तन्नो लक्ष्मी प्रचोदयात्। ॐ महादेवी च विद्महे विष्णुपत्नी च धीमहि तन्नो लक्ष्मी प्रचोदयात्। श्रीवासस्य मायुष्यमारोग्यते भजन्ति सद्योधः मालती प्रयायां पश्यति एवं वेदम् लक्ष्मी प्रचोदयात्।
नौ तो बजे देवेभ्यो आमे ग्रहणे ग्रामदेवी गृहदेवी गृहे सत्तादिदृष्टान्तरं सदा महायुद्धे महामारी दुष्टसंहाररूपिणी रक्षस्वरूपाष्टानां पूजानस्तंजमादिनां च सर्वदा रूपा उत्पत्ताना तस्मादस्विना विचारितां च बुद्धिर्बुद्धिर्मुक्तिसदाम् एकस्वरूपावताम् आज्ञापतापरूपा रविष्णं वाणिज्यरूपिणी सृष्टिस्वरूपात्मे अन्ते त्वां हमारी विश्वसपूजिते भारती महाराष्ट्रमोहिनी विद्यायामे माया यां योगित्वाक्षमोक्षमार्गं पश्यति काले Krishna Vishnu Mahashuru Mahajai Mahashame Satyora Samsade Uttare Pada Sahasame Pandana Mukirve Adyatvare Shmashani Kadhari Stale Starjatu Supe Svahamutade Adyatvare Shmashani Kadhari Stale Starjatu Supe Svahamutade Prasadahanti Kadavati This is Vivite Open Mama Lena Navadena Prasmu Kadare Kadavati Constantly Mama Lena Navadena Prasmu Father Church for Baby Kavana Lena Prasmu Mama Baby Kavana Dharmana Shiva Lena Prasmu Ishi Krishna Sata Om Brahma Vedanta Kami Shukam Master Krishnamrata Sata Om Sata Om Swaha Om Sapam Jajamahe Kami Shukam Master Krishnamrata Sata Om Om Swaha Om Pakam Jamahe Pustivartanam Marukam Shapantanat
I request everybody to mute yourselves.
Om Juhu Sah Om
Good morning, everyone. Welcome to the scientific session Triple Conclave. I welcome all the judges and delegates to this session. Today's scientific session will be paper presentation by faculty, session 1. I'd like to welcome our judges of the session, Dr. Anula Leela Matthew, Associate Professor, Pushpagiri College of General Sciences, Dr. Liza Elizabeth Jacob, Assistant Professor, Pushpagiri College of General Sciences. Welcome, dear judges. We are beginning our session. Judges, please note, the first presentation is faculty paper number 3. Paper number 1 and paper number 2 is absent. So faculty paper number 3.
Yeah. Good morning, everyone. My screen is visible.
Yes.
Yeah. Good morning, everyone. The topic of presentation is cognitive behavioral therapy, CBT, in the management of psychosomatic disorders and oral mucosal lesions in oral medicine. Psychosomatic disorders are characterized by physical symptoms from the mental and emotional causes. They involve the body and mind. There is a psychological component and physical symptoms of pain, anxiety, and fatigue. These include the pain-related disorders like TMJ pain, myofascial pain. They can be due to altered sensation like burning out syndrome, idiopathic dysgeusia, or xerostomia, or they can be stress-related or mucosal lesions like lichen planus, aphthous ulcerations, and they also include cancerophobia. As per global epidemiology, headache is counting for 52%, followed by aphthous ulceration 5 to 66%. Then we have myofascial pain 12% and TMJ pain 5% in the population. Chronic pain is a major challenge for both patient and the clinician. Patient is under anxiety, stress, depression. Multiple areas in the brain are activated, and patient will be under somatic arousal. There will be somatic overfocus. Patient will be preoccupied by the automatic negative thoughts, which arise suddenly or automatically without any medical explanation. Like, I'm having this jaw pain, it is never going away. So various treatment modalities are there to treat these disorders. We have medications, injections, surgeries, dance therapy, physical therapies, herbal remedies, and we have the preventive measures. But they also need the psychological and behavioral therapies and multidisciplinary efforts to manage the psychosomatic problem. Cognitive behavioral therapy is an emerging psycho-intervention which identifies the behavior and emotional aspects of patient problem. It is based on the biopsychosocial model of the health, and it is given by various techniques like we have the validity of beliefs and thoughts. Patient is asked to maintain the diary, aversive conditioning, and reinforcement. Usually 4 to 8 sessions are given. This is a chart of 4 sessions in which session 1 is psychoeducation. Session 2 is identification of automatic thoughts in a negative situation, in a painful situation. Session 3 is practice evaluating of automatic thoughts. And session 4 is replacement of these catastrophic thoughts with a more constructive behavior. All the studies have addressed the effectiveness of CBT in the psychiatric diseases, TMJ pain, but limited studies have focused on other psychosomatic problems like burning out syndrome, headache, and cancerophobia. With this aim, we searched the literature of the last 10 years by various databases. Initially, 124 articles were screened and searched, and they were excluded because they were review articles, case reports. They were not primarily focused on CBT, and there was lack of adequate data. So we are left with 6 articles. 2 studies are on the TMJ patient, and CBT was found to be very effective in reduction in the frequency of pain and reduction of emotional distress. More et al. Found that there was improvement in the pain coping skills of the patient, and also patients were satisfied with the treatment, but there was no significant differences in the nocturnal muscle activity. So this requires further studies on the TMJ patient of the CBT application. Then we have migraine. Migraine is a chronic neurological disorder. So the patient is under the stress and due to the cortical excitability, inflammation, abnormal pain processing. And chronic migraine is a major problem because it is occurring 15 days per month, and it is more common in the females and very disabling. CBT has been tried by Cousins et al. In one study and with the relaxation treatment. And they was found that there was improvement in the number of headache days, migraine disability, anxiety, and depression after 5 CBT sessions and 4-month follow-up. But it requires further evaluation again because very limited studies. Burning mouth syndrome is a burning sensation with no signs of inflammation. We just have to reassure the patient dietary modification, avoid hot and spicy foods, and pharmacological therapies. The CBT needs to be tried, and one study was done by Komayama et al. 6 CBT sessions were given 6 months apart. And pain and tension anxiety scores were decreased after the second session. So it was found to be helpful. Cancerophobia, the word cancer, is a pathological type of fear. So 70% CBT, 70% phobia patients seek the treatment. 20% CPT population only seek the treatment, but these patients needs a cognitive behavioral therapy psycho intervention. Patterson only tried the CBT in the cancer patient, and there was improvement in swelling scores, diet, and fatigue of the patient, but there was no change in the anxiety scores. They concluded that these patients were not open to this psychological intervention, and they were not attending the appointments. So they need the more of the psychological support, more of the palliative care and patient education, and more of the trials. Neuralgia is a controversial whether it's a psychosomatic problem or not, or whether stress is the cause of neuralgia, but this is very disabling and may cause anxiety. So Danny et al. Tried the CPT, 6-session CPT was given in 15 adults with neuralgia. I was 1 month and 9 month follow-up, and there was improvement in the confidence of the patients. Patient was do the task in the neuralgia symptoms, but this has to be implemented on a larger scale. Risk of bias assessment was done. All the studies were found to have a low risk of bias, except the Komayama et al., where there was high risk in terms of blinding of the participants and the observer. I may conclude the discussion like somatic quoting is a step-by-step process. CPT was effective in reducing the kinosphobia, improvement of the symptoms, and improvement of anxiety and depression. But more studies on the stress-related lesions like repentance and ulceration, and this needs more trials, more follow-up, more CPT training programs, and strong communication skills. Patient should be, the clinician should be good listener, and it can be given with a standard treatment of the psychosomatic problems.
Excuse me,
References. Thank you. And yeah. CMT can be given along with the standard treatment of psychosomatic problems, and clinicians should be good listener of patient symptoms and problems, and more of the training program for the dentist. They can collaborate with the psychiatrist or psychologist. And these are my set of references. Thank you. Ma'am, I'm finished with the presentation.
So over to the judges for the question session.
Thank you. This is very good presentation.
Thank you, ma'am.
Am I audible?
Yes, ma'am. Yes, ma'am. You are audible, ma'am.
In general, can you just tell me how stress affects oral health?
Yes, ma'am. Stress and the psychosomatic problems, they are affecting the patient's quality of life and well-being of the patients. Studies on CBT are there in TMJ. Trials are going on in the various institutions, but still burning mouse syndrome, that had a chronic migraine, CBT needs to be tested in, also applied in the cancerophobia patients especially. They are under more stress. So it is just a future prospects that it has to be applied. Because one study was there by my search on other psychosomatic problems.
Thank you very much.
Thank you, ma'am. Thank you, ma'am. I will just, ma'am, stop the screen sharing, ma'am.
Yes.
Thank you.
All the participants, please note a warning bell will be there at the 4th minute, and the final bell will be there at the 5th minute. Judges, kindly note. Next is faculty paper presentation number 4. Faculty paper presentation number 4.
Hello, good morning. Am I audible?
Yes, you're on.
is visible or not? Hello.
It's visible. The screen is visible.
Okay. Good morning to all of you. My topic is thermometer, a newer diagnostic assessment in tool in dentistry. Coming to the introduction, the mother touch is the first sensational for the newborn child, and it is preferred as that heat has the profound congenital impact on him. Coming to the metabolism of our body, the body heat is generated by the metabolism of muscular activities, and the normal temperature we have, that is 37 degrees Celsius. Thermography is the study and application of biothermal process to assess health and disease and the world. The thermography employs imaging of visual evolution of the thermal changes from the object to detect, display, and record the thermal pattern across the surface of the object. Thermography is a tool process for beneficial in the device of the diagnosis in the medical department. In Ayurveda, our body is made up of 5 elements, that is space, air, fire, water, and earth. The fire that we have is Agni. The body temperature is a medical science. And in 1592, thermoscope was invented by Galileo. In 1611, thermometer was invented. Then thermography in thermometry in 1931. In 1986, neuromuscular thermography published basic guideline for the conducting facial thermographic examination. Coming to the principles, thermography principle and amount of blood circulation at the different layer of the skin varies. The temperature also change accordingly. Consequently, disorders that affect the blood flow to result in abnormalities in temperature distribution, and this when evaluate will provide valid diagnostic information. Coming to the type of thermography, there are 2 types according to the contact, semi-quantitative contact and infrared detecting contact, non-contact method. Liquid crystal thermography is semi-conductive contact method, and infrared thermography, dynamic telethermography, and facial thermography is categorized as infrared non-contact method of thermography. Coming to LCT, that is liquid crystal thermography, it is having temperature and chronic that is color. The heat surface the treated is response with the color. Infrared telethermography is the telethermometric, electric thermography, or digital infrared telethermographic imaging, non-contact method of temperature measure. Coming to the dynamic area, that is quantitative assessment of temperature changes over the non-uniform temperature area is measured. It is recorded the temporal thermal behavior. A series of thermal imaging is taken as area. Facial thermography. Heat emission from the human face have been shown to be psychological indicator of the underlying health and disease. The pattern of radiating heat displayed over the human body is normal symmetric. Man has found 25 atomic zone greater than the woman because of more basal metabolic activities. Coming to the clinical examination, clinical application of thermography in dentistry. That is, first, it is former method, it is called static thermography, and later is dynamic thermography. In chronic orofacial pain, Gott and his colleague in 1996 developed a classification system using a telethermograph for the patient of chronic pain. They have classified them. Sorry. Sorry. Hello.
You can conclude your presentation.
Okay. They have classified them as a normal selection atomic area of delta T value range from 0.0 to 0.25 degrees Celsius. Hot when it is less than more than 0.35 degrees Celsius, and cold where that is less than 0.35 degrees Celsius. Coming to TMJ disorder, normal TMJ disorder value is 0.1 degrees Celsius. TMJ arthritis shows 0.4 degrees Celsius. Then orthodontic patient shows 0.2 degrees
Can you
Celsius.
please go to the conclusion?
Okay. It is used in the tissue reaction, diagnosis of bone fractures, arthritis, muscular pain, then chronic and acute periodontitis, neuralgia, cancer in maxillofacial territory, and maxillary sinus disease. Advantage, it is non-invasive, and also it is used as a diagnostic tool in faster time. And coming to the conclusion, that is after it is used as a novel equipment and the state of the art facilities. Thermography is the near failure when certainly regains the unique research in the dentistry. These are all my references.
Thank you. Over to the judges.
Thank you for your presentation. Is thermography widely available? I'm not able to hear you. Ma'am, I'm not able to hear you. Can you please repeat your answer? Am I audible?
Hello.
Yeah, can you hear me?
Yes, ma'am.
Okay. Is thermography widely available, or where is it available?
Sorry. Actually, I am traveling right now. The voice is cutting.
Okay, okay, fine. No problem. Thank you for your presentation.
Hello. Hello.
Yes. And moving on to the next section. Judges kindly note, faculty paper number 5. Judges please note, faculty paper number 5.
Good morning, all of you. Today's my presentation is on artificial intelligence and transforming the dentistry today. So based on this presentation, we have to keep ourselves updated uh, according to the newer technology. So what is artificial intelligence? Now, as we all know that it is a defined as study of intelligent agents and any device that perceive its environment and take action that maximize its chance of successfully achieving its goal. The application of this intelligent already using in non-medical field like gaming, language processing, robotics, and image recognition. So how does it work? So machine get the algorithm and it set the different variable according to that algorithm. When such dependency is observed, it can predict the future output by identifying the target function that base describe their behavior governing the input and output patterns. So CDSS, Clinical Decision Support System, is a network between an extensive dynamic that medical knowledge database and interfacing output mechanism that are set of algorithms derived from evidence-based medical practice implemented through medical logic modules. Artificial neural network is a network. These are the mathematical computing models that stimulate the functioning of human brain. This neural network expert system may be trained with clinical data, and this can be used in clinical situation of diagnostic dilemmas to improve clinical strategy of healthcare system. So now we're coming on to the application of artificial intelligence in various fields of dentistry. So first of all, general dentistry. So by using this, we can we don't need to do any paperwork, or we can directly book our patient's appointment, and we can plan the treatment. Especially in dental emergency, when the practitioner is unavailable, the patient has an option of emergency teleassistant, which would benefit the patient. In oral medicine, so by using this, we can easily diagnosis and plan the treatment. We can easily screening and classify the altered mucosa or pre-malignant malignant lesions. This by using of neural system in diagnosis subtype of temporomandibular jaw disorder has been studied by Bas B et al. In radiology, we can interpret the X-ray, various X-ray through the telediagnosis, and we can do the reporting, implant planning, and interpret any bony lesions through artificial intelligence. So, and coming on to the oral and maxillofacial surgery, it helps in planning surgeries with reduced operation time, thereby perceiving a vital structure around the smallest detail prior to actual surgery with higher intraoperative accuracy. One more fruitful clinical application is image guided surgery. In orthodontist, we can use artificial intelligence nowadays we can use a digital camera to take a patient's impression, and we have to put all the data into AI software, and it helps in predict the tooth movement and final outcome of treatment. Latest technology combined with customized aligner based orthodontics can improve case acceptance. In prosthodontics, we don't need to measure any facial measurement or anthropological calculation, ethnicity, and patient. The AI do all these things and play a major role in identify the type of bone density, cortical thickness for making precise surgical guide for placing implant. By using of CAD/CAM technology, which create the 2D and 3D model, has replaced with the time and laborious process of conventional casting, thereby reducing the human error. VRS technology can be used to stimulate the facial profile post-treatment. And most importantly, in forensic odontology, age estimation is an important aspect of forensic odontology. And by using of AI, we can easily estimate the age, accurate age, based on sequence of tooth formation in eruption time. The radiographic method of age estimation is commonly used due to availability of pre and post-treatment record and also ease of availability of data that can be retrieved anytime. With the evidence of artificial intelligence, there are several programming neural networks can train the computer to automatically estimate the age. And dental education system. So we can easily educate the patient through this by showing them virtual videos. And here I'm concluding this paper. And I just want to say one thing, that AI can only assist the clinician in performing the task efficiently, but no way replace the intellect of human knowledge, skill, and treatment planning. Thank you.
Thank you. Over to the judges.
Thank you so much for your presentation.
Yeah.
Am I audible?
Sorry?
Can you hear me?
Yeah.
Can you please elaborate a bit more on how artificial intelligence can be used in the diagnosis of oral potentially medical disorders?
Sorry, ma'am. Can you repeat, please?
Can you please elaborate a bit more how artificial intelligence can be used in the diagnosis of oral potentially medical disorders?
Okay. So by we can easily by actually not we cannot easily diagnose this, but we can consult the patient through virtual networks. And by telediagnosis, we are now using a telecommunication telediagnosis, so we can retrieve the data, x-rays, and we can easily sorry.
We may continue.
Sorry, I can hear you.
Ma'am, you're audible, ma'am.
Yeah.
Thank you. We're moving on. Next, judges, please note next faculty paper number 6. Judges, kindly note faculty paper number 6.
Hello. Am I audible? Hello. Hello.
Yes, you're audible.
Am I audible?
Yes, you're audible.
Yeah, thank you. Shall I start the presentation?
Yes, you may start.
Good morning, respected judges, senior faculty members, and my dear friends. Can you see the screen?
No, your screen is not visible.
I have shared the screen. Can you see the screen?
Yes.
Hello.
Hello, sir. Your presentation is visible, sir.
So your presentation is visible, so we can see your screen.
I'm sorry, I couldn't hear. Can you see the screen?
Yes, sir. Yes, sir.
Yeah. Okay. Thank you, respected judges and senior faculty members and my friends. Today I'm here. Very warm good morning. Today I'm here to present a paper titled "Assessment of Vascular Channels in the Mandible a computerized tomographic imaging study. So as we all know, dental implant treatment is an upcoming management modality for missing tooth, as they maintain and strengthen the bony structure. So major complication that usually occur while doing this treatment is the involvement of just in vital structures. In case of mandible, mainly inferior alveolar canal is the main nerve supply in the mandible, and usually dentists encounter. So nowadays, dentists usually do a pre-surgical evaluation to ensure uh, um, the position of this canal. And still, in spite of this, in spite of this, this iatrogenic errors are on a high rise, because we suspect some other structures other than inferior alveolar canals are present within the mandible that can be an important cause for hemorrhage. So those kind of structures are known as vascular channels, which I'm going to explain in this topic. So these are nothing but a furrow or a groove-like passageway through which something flows in a solid structure. So I have found that these vascular channels are those canals that enter the mandible from outside, especially on the lingual aspect. So which carries the blood vessel, so which can be important cause for hemorrhage and during implant placement. So here in this study, I have utilized MT computer tomography, multi-detector computer tomography to evaluate these minor structures. And my main aim of my study is to examine the prevalence, presence, and location of these channels among patients selected for dental implants, and to compare percentage distribution among genders. So out of my 30 sample size, patients were divided into 3 groups of 10. We did a scanning with multi-detector computer tomography with a slice collimation of 0.6 millimeter and a width of 10 mm.
Still on the first slide.
Hello?
Can you hear me? Your presentation is still on the first slide.
Ma'am, couldn't hear.
So can you start the full screen presentation? Can you start the slideshow, sir? It is not in the slideshow mode. And we are able to see only the first slide of your presentation, sir.
I've already shared.
We can see your screen, sir, but it is not in full screen mode, sir. That is, you've not started the presentation mode. Yes, sir. If you click there to come to full screen.
Is it visible now, ma'am?
What is the full screen presentation, sir?
I can see the full share in my full screen in my laptop.
Okay, sir. Then maybe there's some technical error.
Okay.
Could you press F5 on your system, sir?
Ma'am, sorry?
Can you select F5? Can you press the key F5?
Okay.
F5.
Yes.
Sir, can you close the full screen and again make it full screen, sir? Because we're not able to see the full screen presentation.
Sorry, I'm really sorry, some technical error.
No issues.
Actually, I can view the full screen. One second. Ma'am, shall I stop the sharing and again can
Yes,
I share
sir.
the screen?
Yes, sir. Yes, sir. We can see your presentation now, sir. It is full screen.
Sorry for the. So out of this 30 sample size, patients were divided into 3 groups of 10. A multi-detector CT scanning was done with a slice collimation of 0.6 millimeter and a width of 10 mm. And people under 20 years of age and people with developmental anomalies and jaw pathologies, and those not selected for implant were excluded from the study. So the investigation part, we have taken CT imaging. This is a sagittal section in the premolar region showing the entry of this canal from the lingual aspect of the mandible. You can see the canal morphology over here of the lingual aspect, how it entered. And this is the actual view. This is a small video demonstration showing the entry of multiple channels through the lingual aspect of the mandible. So here we can assess, we can see that multiple canals enter to the lingual aspect of the mandible from the lingual aspect. So this is the enlarged view of the same vascular channels, one in the median aspect and two on the lateral aspect. And this is one patient we have scanned, showed multiple vascular channels in the mandible. So here, as I said, patients were the results. Patients were divided into three groups, and these are the mean ages. And out of these 30 cases, 19 showed the presence of this vascular channel that approximated around 63%. And among the gender distribution, both males and females showed the presence of these channels, where in which males showed a higher proportion than females. And out of the present cases, 16 cases, the majority of them showed a single entry of this vascular channel, whereas only three cases showed multiple channels. The image has been showed there. And the most common region in my study, which were found to be premolar region. 19 of them were 19 of vascular channels were entered through the premolar area, and 4 were in the incisor region. So in the discussion part, so these are the structures other than infra-alveolar canal, which needs to be considered, because this might be an important cause of hemorrhage while placing implant. So few studies have been reported stating that there are these vascular channels in the mandible that occur within the interforaminal area. So in my study, most of the cases were the interforaminal area, and few other studies were done by Longoni et al., mainly in vitro studies in dry skull mandibles. In that study also, majority of them showed the presence of a single vascular channels. And other studies conducted, they showed premolar region as the most preferred location for the entry of these vascular channels. And majority of them were found in this region. And in the present study also, majority of the vascular channels entered the mandible through the lingual aspect in the premolar area. So as I have already said, two-dimensional imaging has a limitation in detecting these minor structures.
Sir, I'm sorry to interrupt. The time is over. Would you please kindly conclude your session?
Yeah, last. So we use a software to display these structures. So as a concluding note, I would like to say that three-dimensional imaging, like CT scan, has a multiple advantage that they are not sensitive to beam orientation. So it is very important to assess these structures in addition to infra-alveolar canal for a better treatment outcome. Thank you.
Thank you, sir. Over to judges.
Yes, thank you.
Thank you, sir, for your presentation. So was
Thank
your
you, ma'am.
study retrospective?
Ma'am,
Was your study retrospective, sir?
Yeah, cross-sectional study we did. Ma'am, we did a Fisher's exact test to do a statistical significance.
Okay, sir. And so I believe the same thing can also be seen on CBC treatment, sir. What are the advantages of CBT in this study? Apart from beam alignment?
Actually, CBCT only have a bone window. When we assess, CT has an additional advantage of using both the windows as soft tissue as well as bony window, so that we can assess minor structures comparatively. So CBCT has a small dull in regard to this, because multiple soft tissue assessment cannot be done. So we cannot compare bony as well as soft tissue in CBCT.
Okay, sir. Thank you for your presentation.
Thank you so much, ma'am. Thank you.
Judges, please note. Next, we have faculty paper number 7. Judges, kindly note. Next, faculty paper number 7.
Good morning, ma'am. Am I audible, ma'am?
Yes, you're audible now.
Ma'am, can I share my screen?
Yes, you can share your screen.
Yeah, thank you. A very good morning to one and all present here. Can I start my presentation, ma'am?
Yes, ma'am, you can start your presentation.
So my topic of today is designing of a smart dental chair to overcome the challenges in the existing chair-side discussion method. So problem-based learning. Problem-based learning is a teaching method in which complex real-world problems are used as a vehicle to promote student learning and of the concepts and principles as opposed to that of the direct presentations. So in fact, when we say case-based learning is one of the successful method of problem-based learning. So it employs active learning, involves self-discovery and of both the student as well as teacher. It makes a communication platform. So what is this? Why this study is required? Chair-side clinical discussion is an active learning process in which is the most widely accepted teaching method. But this also faces few challenges like prolonged patient waiting time, and it is not possible for all the students to get exposure to all the cases that are coming to a department at one particular duration of posting period. So hence, the study is aimed to design a technologically equipped dental chair to enhance teaching and learning better in chair-side discussion. So what are the challenges that are faced in the present-day chair-side discussion method? The first thing is 100% exposure is not possible. Second thing is variations in cases. For example, lichen planus, which has 6 types, which cannot be shown to one patient. With one patient, we cannot explain about all the other 5 types. Hence, we need some record-based galleries, which will be easy to explain. Then inability to have a proper view. When some intraoral procedures are done, any demos are given, it is very difficult for people to see inside. The vicinity is difficult. Then prolonged patient time during the discussion. Lesser chances to go back home and recollect those points that are told by the staff members. Inability to discuss various differential diagnosis and treatment options. The aim of the study is to design a modified chair-side discussion method using a smart dental chair and to implement the technique with the students. The objectives are to provide chair-side discussion with technological support, to encourage the clinical orientation, diagnostic and treatment planning, and to create opportunity to discuss various differential diagnosis and treatment scenarios, to integrate the culture of revising and recollecting even for clinical cases via institutional learning management platform. So the study is designed with a smaller idea and by making a foundation for solution, then coming up with solution, implementing, evaluating, and then reflecting. So the inclusion criteria here is we took patients from 20 to 40 years to avoid inconveniences. Then pre-diagnosed patients with mucosal lesions were included in the study. Undergraduate students from our own department who are posted in our department were only selected, and we used a clinical case gallery which we created priorly and stored it in our cloud storage. Exclusion criteria: postgraduate students were not included and no dental procedures were done during this study. An informed consent will be obtained from every patient who are participating in this study. The methodology applied is student posted in our department was taken. We divided the case discussion with 2 cases. 2 cases were taken. The first with the conventional chair-side discussion and the second with the modified chair-side discussion. We actually made the experienced staff, the highly experienced staff, to take these classes. In the conventional chair-side technique, what we do usually is we take case history, we give a brief discussion, and we also have a Q&A session for the students. In the modified chair-side technique, what we are doing is we are taking the case history along with the help of technological support. That is an intraoral camera, a smart screen, and then Arduino, a voice recognition module. This Arduino has a capacity of recognizing our voice and recording it. And further, when they go home and see the video, that will be in a standard voice. That is like how this phone call we answer, the busy tone, ringtone, such kind of voices will be there. So strategic plan here is
we actually introduced about case-based learning, the challenge-based learning to the faculty member. We described in detail and divided the students with 2 cases. First, one case, the same group of students will attend the conventional chassis. Yes, ma'am. Is a conventional chassis technique, and then they will be subjected to the modified chassis technique. Then the technology was used, and the teacher also had a good platform to have an interaction. So I will skip with the video. Yes. So the flow chart includes case history and the assessment. Then we had a scanner, student participation was allowed, and an appreciative talk was conducted. So here the challenges are missing of cases. Clinical case gallery was there to complement it. Variations in case, we used intraoral camera to record all the cases. Prolonged patient waiting time, we scanned the data. So the patient need not be there in the chair till the entire discussion gets completed. So inability to discuss the various differential diagnosis. Again, the case gallery will support us. Lesser chances to recollect and revise. That problem is completely avoided with the having cloud storage. So the phases here we employed as a teacher's phase, student phase, and then a comparative, both combination phase we use. The assessment form was based on, as a Google form, which had on a student's perspective, attitude, desire of knowledge, and knowledge application. Yes, ma'am. Teachers. Yes, ma'am. Yes, ma'am. Method and teaching quality was taken. Patient time, anxiety, and ethical issues were taken. So we did the Google form. We got a positive response, and it was statistically different from that of the any other studies. There was no studies such modified chassis technique used till now. So the future outcome will be like the student-teacher interaction, and the revising is a good option here. And future challenges will be the storage and the copyright protection issues for the college. These are my references. And I acknowledge Dr. Anuradha ma'am, Dr. Kannan sir, and Kritika ma'am for being there for me. And thank you so much for this opportunity.
Thank you. Over to the judges.
Thank you, ma'am, for your interesting presentation.
Thank you.
Are you currently using this in your department, or was this just for study purpose?
No, ma'am. After my study, we have started to do this. We are trying to connect it to the learning management system of our institution, ma'am.
It's a very innovative presentation. Thank you.
Thank you, ma'am.
Please note, next we have faculty paper number 8. That is kindly note. Next we have faculty paper number 8. Hello, ma'am. You can present. Ma'am, can you please share your screen?
Excuse me, ma'am.
Yes. Yes, ma'am.
Ma'am, is it my presentation 0008?
No, your presentation is not visible. Can you share your screen, ma'am?
It's not audible, ma'am.
Can you share your screen, ma'am? We cannot see your presentation.
Okay, sure. Ma'am, is the screen visible?
Yes, ma'am. The screen is visible, ma'am.
Am I audible?
Yes, ma'am. You're audible, ma'am.
Okay, can I start the presentation, ma'am?
Sure, ma'am. Please start your presentation.
A warm good morning to one and all. Good morning, judges. Today, my topic for presentation is diversities in radiographic appearance of maxillary sinus pathologies, a case series. Pathologies of maxillary sinus may present with non-specific symptoms and varied clinical and radiographic features. The complex anatomy and non-specific clinical features makes a diagnosis of maxillary sinus diseases challenging. Diagnostic imaging plays a key role in evaluating maxillary sinus lesions and formulating a differential diagnosis. Herewith, today I am presenting before you a case series with diversities in radiographic appearance of maxillary sinus pathologies. Now, this is the first case I would like to present before you. It's a 63-year-old male patient who presented with pain and swelling in the left posterior palate. He also presented with an erythema on the posterior palate of 1 year duration. He had a history of extraction of 27 and 28 2 years before, and he presented with numbness on the left side of the face. An IOPA was taken, and we could clearly see that there was an irregular destruction of the alveolar bone distal to 2.6. And this was confirmed by taking an occlusal topographic view also, where you can see the irregular destruction of the alveolar bone. A CBCT was taken for this patient, and it was clearly evident that the left maxillary sinus was opacified with a soft tissue density, and there was destruction of the floor, anterolateral wall, and the medial wall of the maxillary sinus, with extension of the lesion into the nasal cavity and involvement of the inferior and middle nasal concave. The sagittal view shows extensive destruction of the maxillary alveolar bone in relation to 2.7 and 2.8 region, and the floor of the maxillary sinus was also disrupted. The posterior wall was also disrupted, and there was root resorption of 2.6. Now, the axial view shows destruction of the anterior wall, posterolateral wall, and the medial wall of the maxillary sinus, and there was an extensive destruction of the maxillary bone in the left anterior maxilla, which was visualized in the reconstructed three-dimensional view. And based on the clinical and radiographic features, to sum up, that is a numbness on the left side of the face, extensive destruction of the alveolar bone in IUPA, and destruction of the entire walls of the maxillary sinus noted in CBCT, we came to a diagnosis of carcinoma involving the maxillary sinus. And we also gave a differential diagnosis of salivary gland malignancy, considering the location of the lesion and the peculiar clinical features. Moving on to the second case, it was a 57-year-old female patient who presented with a non-healing extraction socket in relation to 1.6 and 1.7 region of a duration of 4 months. She had a history of breast cancer and bone metastasis 5 years before, and for which she had undergone surgery, radiotherapy, and chemotherapy, and she was a diabetic patient on medication. We took a panoramic view which showed an irregular, ill-defined radiolucency in relation to 1.6 and 1.7 region. A CBCT was taken, which showed a homogeneous opacification of the entire right maxillary sinus with the disruption of the floor of the maxillary sinus, and the sagittal view showed an irregular, ill-defined radiolucency in the alveolar bone in relation to 1.6, 1.7 region, and there was a discrete radiopacity. When you see the axial view, the entire maxillary sinus was opacified, and a discrete radiopacity was seen within the sinus, which could be a sequestrum formation or a calcified fungal hyphae. And you can notice that all the walls of the maxillary sinus are intact except for the floor of the maxillary sinus. Now, the patient had brought a bone scintigraphy picture also, and a PET CT which was taken 1 year before, and it was clearly evident that there was a hot spot in the right maxillary sinus. Now, the diagnostic criteria for this case was dental infection associated with pain and swelling, then opacification of the maxillary sinus, a possible sequestrum formation which was depicted as a well-defined radiopacity within the sinus, and moreover the predisposing factor of diabetes mellitus. We came to the diagnosis that it could be a maxillary sinus osteomyelitis. Now, we had a diagnostic dilemma in this case because this patient had a history of breast cancer and bone metastasis, for which she had undergone surgery, radiotherapy, and chemotherapy. And moreover, her scintigraphy showed a hotspot in the right maxillary sinus. So we also gave a differential diagnosis of carcinoma involving the maxillary sinus, or it could be a deep fungal infection or a maxillary sinusitis. Now, the literature says that 68% of the cases of maxillary osteomyelitis are related to diabetes mellitus, and hyperglycemia weakens immune system by altering the blood flow to the maxilla. Now, moving on to the third case in this series, a 27-year-old male patient presented to our department with a progressive enlargement on the right side of the face. He had a bony heart swelling of duration 10 years duration. There was a well-defined radio opacity, which is noted filling the entire maxillary sinus. The CBCT picture showed a groundless appearance of the right maxillary sinus with extension into the orbital floor, lateral wall of the nasal cavity, and floor of the maxillary sinus. And it should be noted that the radio opacity actually blends with the adjacent normal bone. And the sagittal view shows the extension of the lesion into the pterygoid plates and extension into the floor of the maxillary sinus and loss of lamina dura at the apex of the posterior teeth. Now, here you can see that there is an internally mixed loose and radio opaque lesion with a well-defined hyperdense radio opacity inside. And it should be noted that even though the lesion was extensive, there was a well-defined smooth cortex with a cortical thinning. So the diagnostic criteria was progressive enlargement with a ground-glass appearance, and the lesion blends with the adjacent normal bone and the well-defined smooth cortex. We gave a diagnosis of fibrous dysplasia involving the maxilla, particularly the maxillary sinus, and the differential diagnosis of Page's disease was also given. Now, literature says that diagnosis of fibrous dysplasia is mainly based on clinical and typical radiographic features. And if we have a characteristic radiographic feature, we need not go for a histopathology for diagnosis. Now, to conclude and to sum up, I have presented here 3 cases. The first case was a carcinoma of the maxillary sinus. That is, bony changes may be seen in inflammatory and malignant sinus lesions, but the bony erosions which we have seen here is highly suspicious of malignancy. In the second case, the maxillary sinus osteomyelitis, which we have diagnosed, may be related to the altered immune system in diabetes and dental infection, and the hotspot seen in bone scan could be a sign of infection or a malignancy. In the third case, the diagnosis of fibrous dysplasia, which we had done, is mainly based on the clinical and typical radiographic features. So to conclude, I would like to say that dental practitioners should identify the diverse radiographic presentations in diagnosing lesions of the maxillary sinus. Thank you.
Thank you, ma'am. Over to the judges.
Well, thank you very much, ma'am, for enlightening us with your informative presentation and for sharing your experience and knowledge with us, ma'am. Thank you so much.
Okay.
Judges, please note, next we have faculty paper number 9. Judges, kindly note, next we have faculty paper number 9.
Hello.
Yes, sir, you're audible.
Yes. Yeah. Shall I share the screen?
Yes, you may share the screen, sir.
Okay. Thank you, ma'am. Okay. Shall I start, ma'am? Hello.
Yes, sir, you may start the presentation.
A very good morning to one and all present. So I would like to start my presentation today with a quote. Successful warrior is the average man with a laser-like focus. With that quote, I would like to begin my presentation for today, which is low-level laser therapy, a blitzkrieg therapy for chemo-radiation-induced oral mucositis. So as we know, the fascination with the properties of light, humankind's fascination with the properties of light and its application in medicine can be traced back to the ancient times. right when the developments in physics at the beginning of 20th century with the laser theory, which was postulated by Sir Albert Einstein, there were many developments in the area of laser, especially with the first introduction of low-level laser therapy by Sir Andre Masterson in the year 1967. So this low-level laser therapy basically works on the principle of photosynthesis in plant. The mechanism is somewhat analogous to the photosynthesis in plants, where the light in the window of 660 to 910 nanometer acts at the light level of cytochrome C oxidase enzyme, and where it stimulates the ATP release, modulates reactive oxygen species and nitrous oxide, thereby leading to increased cell proliferation, repair, and healing. So chemoradiation-induced oral mucositis, as we know, is one of the most common adverse effects of chemoradiotherapy. Patients often discontinue the treatment because of the reduced quality of life during the treatment. The treatment of chemoradiation-induced oral mucositis is still palliative, and there is no consensus on any agent for prophylactic therapeutic use. Even though different agents like amifostine has been available in the market, it is quite uncertain. With this background, we had experimented the use of triple LT as an alternative treatment modality for chemoradiation-induced oral mucositis, especially because of its absence of in vivo toxicity, economical and improved patient compliance. The aim of the study was to evaluate the efficacy of triple LT in the treatment of chemoradiation-induced oral mucositis. A non-randomized single-arm clinical study was conducted at a cancer center over a period of 1 year. Inclusion criteria was histopathologically confirmed head and neck cancer patients undergoing chemoradiotherapy and patients with oral mucositis grading of 1 to 4 in the WHO scale of 2004. 25 patients fulfilled the inclusion criteria, amongst which 7 patients were excluded because of the because they discontinued the treatment because of oral mucositis and medical illness. Remaining 18 patients were grouped into 2 groups of chemoradiotherapy group where they received concomitant dosage of chemotherapy and radiotherapy, and group 2 where it was just radiotherapy. The patients were graded based on the WHO grading scale of mucositis of 2004 on a scale of 0 to 4, with 0 being no lesion and 4 being severe lesions. Objective assessment was done based on WHO grading scale of mucositis, and these were the statistics of patients in the respective groups and respective stagings. Subjective assessment was done based on the visual analog scale score, where patients were asked to grade the severity of pain depending upon the visual analog scale. This was the laser which was used in the study, which is a partially collimated diode laser, aluminum Indian phosphide laser at a nanometer of 660 nanometer and 50 milliwatt, and a dose of 4 joules per centimeter square. The exposure was done in a scanning motion over a duration of 80 seconds, excluding the site of the tumor. On analyzing the results, it was seen that the subjective assessment, as it has been highlighted in green, we were able to downgrade the VAS score in almost all the patients in chemoradiotherapy group as well as the radiotherapy group. And on objective assessment based on the WHO grading scale of mucositis, as we can see the values, there was significant downgradation of the grades of mucositis from grade 2 to grade 1 and grade 3 to grade 2. Worth mentioning, there was significant 100% of the patients of grade 3 mucositis patients were completely downgraded to grade 2. As we know, picture speaks a million words. We wanted to further go and quantitatively and qualitatively analyze these changes. So for the sake of convenience, we considered the intraoral pictures of 2 patients over the course of 3 days of triple LT. And we went ahead to perform a image analysis in which the following steps have been mentioned over the course of 5 days. And it has been seen that quantitatively, it has been seen that there is significant reduction in the size of the lesion over 5 days. And qualitative analysis, as you can see, the RGB spectrum over 5 days, there was significant reduction in the size of the lesion, which has been represented by 3-dimensional intensity scale. For the 18 patients were followed up, out of which 11 patients we were able to follow up, 7 patients were lost to follow up, and they were analyzed based on the European Organization for Research and Treatment of Cancer Quality of Life questionnaire. And we had asked the following questions. Depending upon the questionnaire, it was seen that almost all the 11 patients had improved quality of life on 1 year of follow-up. As we know, oral mucositis is a debilitating condition for head and neck cancer patients, and various approaches are made constantly to intercept them. In this study, we used LT for management of chemoradiation-induced oral mucositis patient, which was found to be beneficial for all 18 patients in both the groups, as it accelerated the healing process and pain alleviation significantly, improving the quality of life of patient and ensuring their uninterrupted treatment. The 1-year follow-up of the patients revealed that the patients benefited from LT sessions that helped to significantly improve their quality of life during and after chemoradiotherapy sessions. To conclude, LT was found to increase the patient compliance for successful execution of the treatment plan by the oncologist. We, as oral medicine specialists, here are able to play a vital role in supportive cancer therapy, taking a step ahead from oral cancer diagnosis alone. LT is also undergoing clinical trials for the treatment of mild and moderately ill COVID-19 patients, offering enormous potential as a strong treatment modality in the years to come by. However, future studies will be required to further evaluate the efficacy of LT on a larger scale with the use of more standardized revealed parameters and more number of patients. We believe that LT will steadily progress to be better accepted by both the medical professions and general public at large in the upcoming years. These are my references. Success is a sum of small efforts repeated day in and day out. I would like to end my presentation with this quote. Thank you.
Thank you, sir. Over to the judges.
Thank you, sir, for your presentation.
Thank you, ma'am.
Sir, are there any contraindications for low-level therapy for the treatment of mucositis?
Contraindications, ma'am.
Yes, sir.
As in for the treatment of mucus, ma'am.
Yes, sir.
Yes, ma'am. Like you, as in, ma'am, you're telling about.
So your voice is breaking, sir.
Hello.
Yes, sir.
Okay, ma'am. Yes, ma'am. As such, we had seen few cases where the tumor was pretty big, like especially in the left buccal mucosa, right buccal mucosa, following radiotherapy, ma'am. So we had like those tumor sites we had avoided, ma'am, because there has been some literature that suggests that there will be maybe a neoproliferation, a proliferation of growth also. So keeping that in mind, those areas alone we had avoided. So we had made sure that at least 2 mm of margin was maintained around the lesion, ma'am. So that is one of the contraindication, the increased size of the lesion, ma'am.
And so what software have we used for image analysis?
ImageJ software we had used, ma'am. ImageJ.
Okay, thank you so much, sir.
Yeah. Thank you, ma'am. Thank you so much.
Next we have judges, please note faculty paper number 10. Judges, kindly note faculty paper number 10.
Shall I start, ma'am?
Yes, ma'am. You should start it.
Okay. Good morning to all respected judges. The topic for today's presentation is sex determination from morphometric analysis of maxillary sinus using Conclave computed tomography. The study of anthropometric characteristics is very important in identification of remnants of skeletal and decomposing parts of human remains. Forensic odontology deals with dental identification procedure mainly through comparative and reconstructive identification. And sexual dimorphism is one of the integral parts in the reconstructive dental profiling. As most bone used for sex determination like skull, pelvis, and long bones are often recovered in incomplete state, it has been important to use denser bones that are often recovered intact, for example, the maxillary sinus. The latest imaging modality, CBCT, provides three-dimensional imaging with multiplanar sectioning. So the aim of the study was to evaluate whether sexual dimorphism using height, width, and length of maxillary sinus can be determined using the CBCT imaging modality. And the rationale, maxillary sinus remains intact when skull and other bones are disfigured in victims who are incinerated. Shape and size of maxillary sinus varies amongst individuals between gender and in various populations. And most of the studies on sexual dimorphism of maxillary sinus have been done yet on CT scan images. However, CBCT, being a latest imaging modality, has not been studied extensively. Hence, a study is proposed to evaluate whether sexual dimorphism using height, width, and length of maxillary sinus can be determined using CBCT imaging modality. Objectives: to measure the height of maxillary sinus using CBCT, to measure the width of maxillary sinus using CBCT, to measure the length of maxillary sinus, and to evaluate whether sexual dimorphism using height, width, and length can be determined using CBCT imaging modality. The methodology part: bilateral maxillary sinus, 30 scans were taken, total 60 maxillary sinuses, using Dentry-C CBCT and HDX Will machine with variable FOVs. Voxel size was 0.2, exposure time was 8 to 24 seconds, KVP was up to 110 kV, and milliampere for up to 10 mA. The linear measures were recorded twice by the same radiologist with the help of the on-demand software in 2 different measurement sessions at an interval of 1 week to minimize memory bias. So this was a height. It was measured away from the inner surface of the anterior border of maxillary sinus and was measured as the longest distance from the lowest point of the sinus floor to the highest point of the sinus roof in coronal section. And the width, it was the longest distance perpendicular from the medial wall of the sinus to the most lateral wall of the lateral process of the maxillary sinus in axial view. And the length, the longest distance from the most anterior point to the posterior point of the medial wall in axial view. The statistical part was done by discriminant analysis, that is multivariate, to find out the dimorphism of sex. Descriptive analysis was also done, and data was expressed as mean, standard deviation, median, and interquartile range. Data was entered using Microsoft Excel and was analyzed using SPSS software. The average values of the measurements were compared between males and females, and the percentage of dimorphism was calculated. So the comparison using descriptive analysis, using all the parameters, and the p-value was found to be statistically significant in case of left height and right height. But even though right height was in borderline, left height was given a statistically significant value. And the percentage of dimorphism, all the percentage compared with males and females were positive. That means all the values were higher in males compared to females. But again, seeing the p-value, the statistically significant was left height and right height. So the discriminant analysis, 73.3% of males and 80% of females were correctly classified by discriminant function. The overall prediction by discriminant function of gender was 76.7. Cross-validation by discriminant function showed that 66.7% of the cross-validated group were correctly classified. So the overall values of the parameters were greater in males as compared to females, but only right and left height were statistically significant. Coming to the discussion, Teke et al. In 2007 found that gender can be determined with an accuracy of 100% if entire skeleton is available, and only 90 to 95% from both the skull and long bones, and 80 to 90% if long bones was only available. Jehan et al. In 2014, he did the study based on bizygomatic distance and maxillary sinus using CT scan, and concluded that CT measurements may be useful to support gender discrimination forensic medicine when other methods stays inconclusive. Tampuwala et al. In 2016 found that female group had significant lower values for both right and left maxillary sinus in relation to length, height, and width dimension. Urug et al. In 2017 evaluated the size and volume of maxillary sinus and found that left side maxillary sinus can be used to determine gender with an overall accuracy of 60%. In our study, the overall values of all the parameters were greater in males as compared to females, but right and left heights were only significant. Hence, maxillary sinus height may be considered as the most reliable discriminant parameter that can be used for the purpose of sex determination. Limitations of the study was it was a small sample size and no statistical formula was used to determine the sample size of the study. To conclude, the morphometric analysis of maxillary sinus can be effectively employed in studying sexual dimorphism using CBCT imaging modality. Further studies involving larger sample size using statistical formula is recommended so that a population-specific equation can be formulated. Thank you.
Thank you, ma'am. Over to the judges.
Thank you, ma'am, for the presentation.
Thank you, ma'am.
Ma'am, did you evaluate for any age-related changes as well, or did you evaluate the gender changes?
Ma'am, I cannot get you, ma'am.
Did you evaluate for any age-related changes in the sinus or only for the gender?
Age-related changes, ma'am.
Yes.
No, ma'am. Actually, ma'am, we excluded such cases, ma'am. We didn't take such cases, ma'am. There were cases that came reported to the OP, and we had seen in the CBCT also, ma'am. But we didn't include that case in our study, ma'am.
Okay. Can you please elaborate on your exclusion criteria?
Exclusion means, ma'am, below 20 years of age, ma'am. And all the cases that have lesions, ma'am, including even if there is a small trabecular nematization, we didn't include, ma'am. And all type of lesions were also excluded, ma'am. And also we take only in non-edentulous cases, we didn't include. We didn't take that.
And what about patients who've undergone procedures like sinus lift? Were they excluded?
Which case, ma'am?
Patients who've undergone sinus lift procedures, have they been excluded?
No, ma'am, we didn't include, ma'am. We didn't include that cases.
All right. Thank you very much.
Thank you, ma'am. Thank you.
Thank you. Judges, please note. Next, faculty, paper number 11. Judges, kindly note. Faculty, paper number 11.
Good morning, everyone.
Please share your screen.
Am I audible?
Yes, ma'am, you're audible.
Okay. Shall I start my presentation?
Yes, ma'am, you shall start your presentation.
Okay. Very good morning to everyone. The topic of my presentation is low-level laser therapy, an elixir of life for oral health workers. Low-level laser therapy is the application of light delivered via a low-power laser to promote tissue repair, reduce inflammation, or induce analgesia. There is no evident temperature rise in the treated tissue. They are basically class 3 medical devices and fall in the category of therapeutic lasers. They are known by various terms such as low power laser therapy, low intensity laser therapy, soft laser, cold laser, photobiomodulation, and photobiostimulation. The first laser was developed in 1960 by Theodore Maiman in Los Angeles. The triple LT was discovered by Dr. Endre Mester in Budapest, Hungary in 1967. He initiated studies on the possible carcinogenic effects of the low-power ruby and helium neon lasers and observed faster rate of hair growth in the treated mice. He called this effect as laser biostimulation. The clinical applications of triple LT began in 1980s when low-level lasers gained popularity. The more recently FDA-approved treatment of carpal tunnel syndrome and minor chronic neck and shoulder pain of musculoskeletal origin have proved to have a positive effect on the development of therapeutic laser therapy. The first working laser was a ruby laser. Amongst its successors were the helium neon laser, the diode laser, that is gallium arsenide, then gallium aluminum arsenide, indium gallium aluminum phosphide, and cluster probes. The dental therapeutic laser is usually the size of an electric toothbrush and come with an attachable intraoral probe that shaped like the wand used for composite curing light units. Laser therapy works on the principle of inducing a biological response through energy transfer. The parameters that are used determine the effective depth of penetration. For triple LT to be effective, the applied irradiation parameters include wavelength, irradiance, pulse rate, intensity and dose, output power, and treatment time. However, if the parameters are incorrect, the treatment might be ineffective. There is a biphasic dose response curve, a phenomena called as hormesis, which follows the Arndt-Schulz law. Now, this law states that weak stimuli slightly accelerate the vital activity, stronger stimuli raise it further until a peak is reached, whereas even stronger stimuli suppress it until a negative response is achieved. Then the mechanism of action. Biostimulation is the main mechanism of action for triple LT. It has an analgesic effect by causing release of endorphins and therefore inhibit the nociceptive signals and controls the pain mediators in the nerves, and increased vascular activity by inducing temporary vasodilation, thereby increasing blood flow to the damaged areas, and anti-inflammatory action by stimulating the lymphocytes, macrophages, activating mast cells, and increasing the production of ATP in the mitochondria. Then faster wound healing by stimulating fibroblast development and accelerating collagen synthesis in the damaged tissue. And nerve regeneration by proliferation of growth factors, thereby promoting neuronal sprouting and myelin formation for optimal nerve recovery and rapid cell growth. Now, when red light of wavelength between 600 to 890, 10 nanometer falls on the cell's mitochondria, it is absorbed by the chromophores, including the protein called as cytochrome C oxidase, which increases its activity. Now, as a result of this, three molecules are affected: ATP, reactive oxygen species, and nitric oxide. Now, increase in ATP increases the cell's ability to fight infection and accelerates the healing process. The reactive oxygen species activates the transcription factors, thereby positively impacting the cellular repair and healing. And nitric oxide, being a potent vasodilator, increases the circulation, decreases inflammation, and enhances the transport of oxygen and immune cells throughout the tissue. Now, on the other hand, when at the application of near infrared light activates the light sensitive ion channels and increases the level of calcium. ROS and cyclic AMP interact with these calcium ions, and all of this increases the cell differentiation, proliferation, and migration. Now, contraindications and safety measures. The laser beam should not be directly aimed into the eyes, and protective spectacles should be worn. And any site of known primary carcinoma or secondary metastasis should not be treated unless the patient is undergoing chemotherapy. It should not be directly treated over a developing fetus, and a low frequency pulsed visible light might trigger a seizure in photosensitive epileptic patients. Now, triple LT has clinical applications. It can be used intraorally as well as extraorally, and has soft tissue as well as hard tissue applications. The soft tissue applications include after ulcers, herpes simplex infections, oral lichen planus, xerostomia, mucositis, paresthesia, periodontitis, and nausea. Whereas hard tissue applications include dentinal hypersensitivity, temporomandibular disorders, orthodontics, sterilization of hard tissue, and bone implant interface. This triple NT can be a useful adjunctive treatment modality in various fields of dentistry that have shown significant benefits in pain relief, wound healing, and inflammation reduction. It is favorable to both the patient and the dentist. Thus, triple LT can prove to be an elixir of life for oral health workers. Said by Lao Tzu, the journey of 1,000 miles begins with a single step. Therefore, the use of triple LT should be explored in every field of dentistry in order to gain more knowledge on how to best use this phenomenon. Thank you.
Thank you. Over to the judges.
Thank you, ma'am. What is the cost of this triple LT unit?
Sorry?
What is the cost of the triple LT unit?
It is very economical, ma'am. Basically, there is a range of laser devices which are available. The minimum cost will be around 1 lakh, which is used. But there are other companies also which are very costly, but the basic equipment which can be used is very cost effective.
Okay, thank you.
Thank you. Thus, we have come to the end of a faculty paper presentation session 1. I'd like to thank our judges and all the faculties. The results will be announced later. Once again, thank you. Good morning, everyone. Good morning, everyone. I welcome you all to the scientific session Triple Conclave. I welcome all the judges and delegates to the session. Today's scientific session will be paper presentation by faculty, session 2. I'd like to welcome the judges of this session, Dr. Beena Verma, Madam, Professor Emeritus, Amrita School of Dentistry, and Dr. Arvind MS, Reader, Amrita School of Dentistry. Welcome, you judges. We are beginning our session. Hi, ma'am. We are beginning our session. Judges, please note, our first presenter is faculty paper number 14. Judges, kindly note, our first presenter is faculty paper number 14.
Good morning. May I start with the session? I am paper number 14.
Yes, please start with the session.
Yeah. Good morning, everyone. Today, my topic is on periodic acid shift staining in oral exfoliative cytology of diabetic patients, the Odyssey for non-invasive screening, a systematic review, and meta-analysis. Now, diabetes is a global health problem and one of the fastest growing chronic conditions. It is adjudged that 1 in 2 diabetics are unaware of their condition. The WHO has predicted this disorder will prevail as the 7th primary cause of fatality by 2030. Exfoliated cytology, a simple, quick, and inexpensive procedure, is used to study exfoliated desquamated cells. Between diabetics and normal patients, several changes have been noted at the cellular level, namely the nuclear area, the cytoplasmic area of oral mucosal cells, the nuclear cytoplasmic ratio, hyperplasia, and an elevation in glycogen deposits in the cells of oral epithelium. The research question of today is, can periodic acid shift staining in oral exfoliative cytology be used for diagnosis of diabetic patients? An overview of our procedure. First of all, we had a set of eligibility criteria. We did a literature search, screened the manuscripts, assessed the quality of the manuscripts selected, and then we would be presenting the findings. During the time, we have followed the PRISMA guidelines for transparent reporting of systematic reviews and meta-analysis, as well as PICO was followed as well. Our inclusion criteria was primarily manuscripts which used a periodic acid shift staining for exfoliated oral mucosal cells. The subjects in the sample were human. The diabetes mellitus treated with oral hypoglycemic agent alone were selected, and also the subjects were to be free of other additional systemic diseases. The exclusion criteria were if they were not original articles, if there were any duplicate publications, if there was an animal study or an in vitro study, and of course, if the manuscript was not published in the English language. The flowchart on the selection strategy was a database scrutiny in Scopus, Medline, Cochrane, Embase, and Google Scholar, post which we arrived at around 47 articles. Keeping the inclusion and the exclusion criteria in place, finally, we arrived at a sample of 6 manuscripts was attained for full text review. Following this, we did a data abstraction and quality assessment. The Cochrane Handbook of Systematic Reviews recommended Newcastle-Ottawa scale, the NOS, was used, which primarily has 3 quality domains for selection of study groups, comparability of the groups, and ascertainment of the outcome, which in totality has around 9 points. Of the 6 studies that we selected, all of these studies had a point of more than 6, pertaining to the fact that they were of high standards. This is an aggregate data of the selected studies. We have studies by S.S. Ravi Kumar et al., Imran A. et al., Saleh M. et al., Asimi Rad et al., Hali Karmat et al., and Reddy et al. All the studies were conducted from a time period of 2011 to 2019, all of it conducted in India, except by Saleh et al. And Asimi Rad et al., which was in Saudi Arabia and Iran, respectively. They were all prospective study designs with a single center. They didn't have any financial aids, and the sample size ranged from 45 to 150. All these studies had the following screening criteria. First of all, the case history and the glycemic control reports were taken. At least a look back period of 1 year where the patient was diagnosed and on medication for the same was done for all the studies. Following which, a confirmatory blood evaluation was done. Then exfoliated cytology of the oral buccal mucosa. It was fixed on a glass slide with alcohol and stained with periodic acid shift reagent. The sensitivity and the specificity were checked for in all of these studies. Based on these studies, we have arrived for statistical analysis. A forest plot was done where we saw that the diagnostic test in this case, which is the periodic acid shift staining in the case group, is as effective. Sorry? Sorry, you're not clear. Hello? Excuse me. Okay. By the forest plot, we arrived at the consensus that a diagnostic test in this case, the periodic acid shift staining, was as effective as that in the control. In control in all these studies was the assessment of serum glucose levels, blood glucose levels, and it corroborated the fact that an elevated serum glucose level was in tandem with the periodic acid staining intensity for glycogen deposits in the oral mucosal epithelial cells. The only exception of among these studies which was not corroborated was Ashami Rad et al. And the study by Saleh et al. Had the highest weightage of association. The limitations that we found in all these manuscripts was that there was no numerical quantification or standardization of values. And also this test is not indicative of any long-term glucose level. On the other hand, the advantages overweighed it being non-invasive. It requires minimum technical skill, can be done in a medical setup or a dental clinical setup. It is painless and of course inexpensive. I conclude that the systemic review and meta-analysis of studies suggested that a PAS staining in exfoliated cytology is recommended for screening in diabetic patients. The robustness of the studies includes quantifying the specific correlation between glycogen storage in oral mucosal cells and the serum blood glucose. Compared with other prior research, we found that this was the only systematic review and meta-analysis on the subject. However, we would like to say that given the increased risk of diabetes in the population at hand, future studies with much higher population quantity and diversity is required to arrive at even a more consensus about the quality of this diagnostic method. Thank you, and these are my references.
Thank you, ma'am. Over to the judges.
Sorry, I was muted. It's a good review, but did you compare it with HbA1c?
No, ma'am, and that is one of our limitations when we came across it. None of the studies, they all are saying it as a test of the current period or the current blood glucose. They are saying it is not indicative for a long-term blood glucose level, ma'am.
No,
and
all will it be possible that if you had compared it with HbA1c? Or
yes, ma'am. Ma'am, I do not believe it is possible because we are looking at oral mucosal epithelial cells. There is cell turnover. So HbA1c, we are looking at a period of 3 months or more. Oral mucosal cells, epithelial cells would have a higher turnover. No, I do not think.
Yeah, exactly.
Evaluate it at that
level. Okay. Okay, good.
Thank you, ma'am.
We can move on now.
Thank you. Judges, please note our next presenter is faculty paper number 15. Judges, kindly note our next presenter is faculty paper number 15.
Can I start?
Yes, ma'am, you can start.
Okay.
You're not audible.
Hello, we can start. Somebody is keeping the time, no?
Yes, ma'am, keeping the time.
I don't have the.
So today's my topic is applications of dentofacial radiography in forensic odontology. We know the four main areas of forensic dentistry involves the identification of the dead human remains, bite mark analysis, and interpretation of all the oral and maxillofacial lesions. Whereas the dental, we know always the jaws and teeth are the most well-preserved parts in the human body. So always the comparison between the ante-mortem and the post-mortem dental characteristics perform the ideal for personal identification. So it is always the central dogma for dental identification. So we can compare using the written notes, study cast, as well as the radiographs. And the main two approaches are the classic approach where we use the conventional radiographs, but the main disadvantage of conventional radiograph is it is very labor intensive, highly error prone, and very subjective, and it is always based upon the summary information. So the computer assisted method has given us more efficiency as well as accuracy for comparing the ante-mortem as well as the post-mortem radiographs. Now coming to the conventional radiographs, the periapical and the bite wings are always used along with the panoramic radiographs. But the main drawbacks again is the reduced image quality, discerning over tooth structure because of overlap, and always there will be differing projection geometries between the ante-mortem and the post-mortem radiographs. So the digital radiographs has become where we can see the side-by-side display of this both the images. Therefore, and also we don't need any conventional light bulbs. And also the digital image repository archiving is carried out after extracting the dental features for each case dental images. So here in each radiograph, what do we compare? We compare the shape and size of each tooth, the root features like number, curvature, as well as length of each one, the extracted tooth, teeth spacing, as well as the spacing between the adjacent teeth. So these are the three stages by which we compare. First is the radiographic segmentation, contour extraction, as well as shape matching. In radiographic segmentation, we have the gap valley detection, where the gap between the upper and the lower tooth is projected in y-axis by a projection histogram. This is the projection histogram. And next, we do the tooth isolation method, where the gaps between the neighboring tooth can be identified and segmented properly. And next, we'll see about the crown contour extraction, where we take two classes of pixels, that is the tooth pixels as well as the background pixels, and we also compare the edge points with the non-edge points. So crown extraction and root extraction is done separately, and here this is how we will do the background pixel as well as the teeth pixel along with edge points and non-edge points. This is the contour shaping or the match shaping. Match shaping can be done. Next, another use for forensic is we can estimate the age. Estimation of age, we have different methods which we are all familiar. The emergence method most commonly used, and here the different stages of the tooth, calcification of the tooth bud system we can compare and note it in this chart and understand the age of the that person. Next, the cephalograms also can be used for identification of the age, because according to Harvard, there can be a standardized maxillary length for each age for males as well as females. Thus, we can compare between the possible age of the patient. Also, the size of the maxillary sinus as well as the frontal sinus can be used for the estimation of the age in the patient. Next, for estimation of sex, we always know that the calcification as well as the eruption of the teeth in girls is more earlier than that in boys. So comparing the mandibular canine, it is about 11 months earlier in girls than in boys.
Ma'am, you have 1 minute more.
Definitive. And cephalographtic radiographs, like all these types of measurements can be taken in a cephalogrammetric radiograph to identify. Also, a PA projections can also be used for determination of age. Also, we can determine which type of race through radiographs. And finally, coming to the physiognomy, where we can do a registration of the soft tissue dimension in 3 dimensions. So we can always, by the dead remains or the dead skull, we can reconstruct the soft tissues in the patient. And finally, the multi-size tomography can give us all the coronal, sagittal, and the oblique views, but we can always to construct the 3-dimensional views to visualize the soft tissues as well as the bone. So to conclude, I would say that by the modern imaging techniques, organ medicine radiography specialists we can more efficiently and more accurately help in the identification of the dead person. Thank you.
Thank you. Over to the judges.
Yeah, doctor. Could you add anything on a radiological aspect in craniofacial superimposition? Maxillofacial radiology. So.
We can always compare between the, actually we can identify the age, sex as well as the race. Along with that, we can each by tooth, we can compare the size of the tooth by contour. This is the 3 stages by which we can compare by radiographs. We can do the radiographic segmentation, contour extraction, as well as the shape matching, by which we can do the exact identification between the antemortem as well as the postmortem radiographs.
Okay, doctor. I would like to know if you're aware of any software which is particularly able to do this craniofacial superimposition from the antemortem 3-dimensional radiographs which are already available.
Sorry, sir, I don't know any app definitely which can do this.
Thank you.
Thank you. Judges, please note, our next presenter is faculty paper number 16. Judges, kindly note, our next presenter is faculty paper number 16.
Slides are visible?
Yes, ma'am. Your slide is visible, ma'am.
Okay.
Put it in the
yes, ma'am.
Full
Yes,
screen mode.
yes, ma'am. Yes, ma'am. Ma'am, may I start, ma'am?
Yes, ma'am. You can start.
A very good afternoon. A very good morning to one and all. The topic of my presentation is Park the Pain, a supportive and diagnostic procedure in orofacial myalgia. I am going to cover my topic under these headings. So starting with the introduction, chronic or persistent pain conditions are the most common cause of disability in India and globally. And myofascial pain distress syndrome is the main reason behind that. And in that, the trigger points plays a very important role for the pain. What are the trigger points basically? Trigger points are discrete, focal, hyperirritable spots located in a taut bands of skeletal muscle. They produce pain locally and in a referral pattern. What are the reason behind the formation of these trigger points? Excessive muscle work resulting in muscle overload, such as excessive eccentric contraction, is one suggested mechanism leading to the trigger points formation. gonadal hormonal imbalance, subclinical hypothyroidism, nutritional deficiency, mechanical factors, and psychosocial factors may be the perpetuating factors in the trigger point formation. So what is a normal muscle and what is a trigger point? These horizontal lines, they represent the normal muscles, and this dark line, they present the taut bands. So, and these red points in between them is present the trigger points. So between the taut points, these trigger points will be present. Due to the continuous contraction of the muscle, there will be the ischemia. These lead to the formation of your trigger points. So these are the contracture nodes in between them, which are responsible for the pain in the patients. So to relieve this, we can do many treatments. We have many treatment modalities, but the few chairside are the needling. We can go for the wet needling or the dry needling. Wet needling, also known as the trigger point injections, they are given with the anesthesia, anesthetic solution, but without the adrenaline. And the quantity in which we can give them, give it is 0.5 ml to 1 ml of the solution. We should take care of the local twitch response so that we can come to know that we are in the proper trigger point. Then second is a dry needling. As the name is telling, it is a dry needling. There will be no any injectable solution will be there. We can do it with the vigorous in and out movement with the needle. We insert the needle at a degree of 20 to 30 degree to the respective trigger points. So why should we do this dry needling or wet needling? So what is the mechanism of their action? This dry needling is basically act at the synaptic left level, where there is the adrenaline, acetylcholines, and these are the receptors. So when we do the dry needling here, we are basically preventing the synapses, preventing this formation of the receptor and the acetylcholine combination. So if this will not form, there will not be any excitatory response by the pain, which is transfers later on to the sensory cortex centers, and through which the patient says, yes, he or she complains of the pain. If we will work on this area where the receptor receive the acetylcholine, so the pain will not be perceived by the patient. So before doing the dry needling or the wet needling, depending upon the dentist skills and the patient perceiving of the pain, we should take the medical and the dental history properly. Patient positioning should be done properly, and should be take care of the needle phobia, especially in case of the children, where we can go for the vapor-coolant spray. And the most important thing are we should able to reproduce the pain. This I am doing in my department, basically. You see the dry needling. Yes, we have to hold the needles in between the two fingers, and then we do the vigorous in and out movements. Then how should we palpate the taut bands? There are the two different methods of palpating the taut bands. One is the pincer method and the flat palpation method. The method which I am showing in this picture is the flat, and the second one is the pincer palpation. We hold the trigger point in between the two fingers. This is basically the fanning. How will we break the trigger points?
Your time is over. Can you please conclude your session?
So thus to conclude by saying that we should take the proper case history of the patient before giving any of the trigger points, so that we can treat the orofacial pain properly in that patient. So these are my bibliography. Thank you.
Thank you, ma'am. Over to the judges.
Yes, doctor, have you tried, which all muscles have you tried this on?
Pardon, sir?
Which all muscles have you tried this on?
I'm so not audible, sir.
Which all muscles did you try this technique on? Which all muscles?
Yes, sir. Sir, I have tried on the temporalis, anterior temporalis also, sir, on the masseter muscle, upper trap, sir, and the sternocleidomastoid muscle.
Okay, and you are basically looking at pain reduction, right?
Yes,
You're
sir.
not addressing the cause of myositis, right?
No,
Are you
sir.
addressing the cause of myositis?
Yes, sir. Sir, if the yes, we have to do, sir. If in a patient we are giving the trigger point for the 5 days, put the patient on the anti-inflammatory, even though the patient is not relieved, then definitely, sir, I have to see into the systemic conditions of the patient also, sir, because calcium and vitamin D plays a very important role in the contraction of the muscle, sir, and they are very vital for their proper working, sir. So I have to see in the systemic.
So you do a workup. So you do a workup for the TMJ case as such, and then only if it's a myositis case, you go with the dry needling or a wet needle. Am I right?
Sir, because both are the different entities, sir. Myocyte, yes, myocyte can be a contributing factor, your comorbidity with the TMD, sir. We can't say directly because of the TMD, this pain is so it can be a comorbidity. So we can do both the things treat with the. So if the having the referral centers, because every muscle have a referral centers in the orofacial region, sir. That may be confused us with a preauricular tenderness, TMG, arthralgia, capsulitis, retrodiscitis, sir. That we have to take care of a little bit.
One last doubt, doctor. How does this act as a diagnostic procedure, by the way?
Yes, sir. Sir, if the patient complains of pain in this area, because this is the masseter area, it has a referral to the temporal preauricular also. So if the patient came as for the diffuse pain, I have a pain here, and he is not able to localize the thing, sir. If we give to a source of the pain apart from the where he perceived the pain, if we give the injection here, the patient may feel the relief because the source of the pain has been controlled. So that acts as a diagnostic, sir.
Thank you, doctor.
Thank you, sir.
Did you mention myositis?
No, ma'am. I have mentioned only, ma'am, myalgia, ma'am, basically.
No, myositis is inflammation. No? So
yes,
definitely inflammatory lesions you cannot.
Ma'am, yes, ma'am. Ma'am, in that area, ma'am, in that case, ma'am, we have to inject at a distance of 1 to 2 centimeters from the trigger point, ma'am. But ma'am, without the vasoconstrictor, without adrenaline, ma'am, if we will inject with the adrenaline, again the patient will come with the more pain. Already he is pain more because of vasoconstriction. So ma'am, in case of the myositis, we have to be little bit to give it to the patient, ma'am.
Okay. Okay.
Thank you.
Shall we proceed to the next?
Judges, kindly note the next presenter is faculty paper number 17. Judges, please note the next presenter is faculty paper number 17.
Good morning. Is my screen visible, ma'am?
Yes,
is my
screen?
Yeah.
Yes,
Yeah.
your screen is visible,
Good afternoon. My topic is on evaluation of oral lichen planus lesions using clinico-fractal analysis, a retrospective cohort study. So first, let's see the introduction. So basically, we all know that oral lichen planus is a chronic immune-mediated disorder with the prevalence in India of about 5% and oral lesions around 0.5 to 2.2%. Being chronic in nature, it has periods of remission and exacerbation, and it's always very vital to assess remission properly. So generally, how do we assess this remission is basically based on how we visualize the lesion and also based on the patient's perception of the visual analog scale. So now here we've tried to assess the remission with fractal dimensions. So this fractal dimension analysis is nothing but we make use of JPEG images of the patient on an image chase software, which assesses the complexity of the lesion, which is converted into binary numbers, and then we obtain the values. Being introduced in the year 2005, this fractal dimension has been used in and out in research, but 90% of all the research that is being carried out is based on radiologic evaluation of bone quality. And assessment of treatment progression has been done in oral lichen, very few studies in oral lichen planus, and as of now, there's just one study apart from this. So let's see a brief literature review. Over the past 5 years, we've seen that there are around 100 studies on using fractal analysis for studying the bone, and only 3 in lichen planus, 8 in leukoplakia, and oral cancer 7. Out of the 3 in lichen planus, 1 is only for treatment progression. So taking this into consideration, we aimed at evaluating the remission of lesion using pre and post operative images of oral lichen planus that was treated with 0.1% topical triamcinolone acetonide, and we obtained retrospectively the visual analog scale and the Thong-Prasong clinical scale to be compared with our fractal dimension analysis. The materials and methods, we got the institutional approval, and then, as I said, we basically got the pre and the post operative pictures, and age was between 30 to 60 years, and all males and females were included as participants. We excluded for which we did not have any availability of records, asymptomatic patients, and also patients treated with steroid or other immunomodulatory drugs for other conditions, and other modalities of treatment other than topical 0.1% Kenalog was excluded. So we calculated the sample size to be 30 with actual power of 0.9 and alpha error of 0.04. So the main criteria for this is we used a standardized camera and with the clinical photographs and the clinical data. So camera was a digital 12 megapixel camera, f2.4 and quad LED flash. So as I said, visual analog scale was used to determine the perception of the patient for the pain, the burning sensation, and Thong-Prasong scale is a clinical evaluatory scale where we measure the lesion clinically with a divider over a particular surface area and grade it as 0 to 5 depending upon the atrophy and the erosive areas. And this scale is again observer dependent. There could be a little observer bias which has to be overcome. So this is the image chase software that we used for fractal dimension. We took pre and post operative clinical photographs and treated the patient with topical steroid, and it's after 1 month follow-up. So the images were converted into a 8-bit type, blurred by Gaussian filter over a diameter of 35 pixels, and then it was subtracted over the original image. So, and then the noise was reduced. And then as we can see here, when it is skeletonized, the first image is the pre-operative image where the complexity of the image is shown by these lines. And when the lesion has healed, the complexity has reduced. And this is how we assess the lesion in binary forms to give a more objective evaluation of the treatment. So we calculated the fractal dimensions based on box counting technique over the box size for both pre-operative and post-operative photographs. We did a statistical analysis using SPSS version 26, and we considered any p-value less than 0.05 to be statistically significant. So visual analog scale analysis was significant with p-value of 0.01. Thong-Prasong scale was 0.001 and fractal dimension was 0.1.
Ma'am, your time is over.
Yeah,
Can you conclude the session?
Yeah, so it was found that it was equally efficient, and these are the studies that have been conducted using all these techniques. So finally, I would like to tell is that since fractal analysis is comparable to that of VAS and Thong-Prasong scale, it would be a promising, cost-effective, and less complex technique in objective evaluation of remission of lichen planus. And we could also do prospective studies having this as a baseline. Thank you.
Thank you, ma'am. Over to the judges.
Yeah, doctor, how did you
Yes,
go
sir.
about standardizing these picture photographs on a retrospective study?
Sir, actually, in our we follow a certain protocols to be taken for every case, sir. We use this specification, so only those were considered, sir.
But when you're feeding something into an image, that picture has to be exactly replicated, right? You are able to do that?
Yes, sir.
For all these 30 cases, you are able to do that?
Yes, sir. Yes, sir. Yes, sir. So this is already a part of a previously conducted study.
Okay.
And then we did fractal analysis for it, sir.
Okay. One more thing.
Yes, sir.
Did you do the image J assessment, or a third party was helping you with the assessment?
No, sir. This is easily available online. All of us can do
So
it,
you
sir.
personally did the assessment?
Yes,
the
sir.
box count
Yes, sir. It just when you feed it in the software, we can just do it, sir. It is not a big deal.
Okay, doctor. See, from what I understand,
Yes,
if you are treating a case of oral lichen planus,
yes, sir.
you are going to have a visual change, right? Yeah, that is what you're
Yes,
trying to assess.
visual
right?
change. Yes,
Yeah.
sir.
So this visual change could be assessed with your plain human eye, right?
Yes, sir.
So what is the point in going for a fractal analysis in
A
that
human eye in observer variation will be there. This is more objective with numbers. We are able to prove it, sir. That is
Okay,
the
and
whole
the patient
concept.
is going to tell you a subjective evaluation also, right?
Yes, sir. That is patient's
chronic
perception. Yes,
yeah.
sir. Though we
So-
have the Thong-Prasong scale also, that again, we might have to have two observers and do inter-observer reliability. So if the photograph is taken in a standardized way and everything done at the right proper technique, I think this would be a very good tool, a standardized tool, because the machine, I mean, the
Standardized
computer
tool for doing what?
Objectively evaluating treatment prognosis.
Okay, and one more suggestion, doctor, if you don't
Yes,
mind.
sir. Yes, sir.
Like in a professional presentation, it would be better if you don't use the comic Sam as a.
Sure, sir.
Yeah.
Yes,
Just
sir.
take it as a
Yes, sir.
suggestion on a good.
Yes, sir. Yes, sir.
Thank you.
Yes, sir. Thank you, sir.
Were all the photographs from the same area or different areas?
Ma'am, mostly on the buccal mucosa, ma'am.
No, standardization includes the site also, no?
Yes, ma'am. Yes. Ma'am, but because since it is only the photograph, and we are going to assess only
even
the
if
pre
it
and
is
the
the-
post-operative photographs. So I don't think it will matter, ma'am.
Yeah, the gingiva, it is slightly different. Tongue, it is slightly different, no? So when
Yes,
you take the
ma'am.
photographs also, there may be some variations, right?
But it will be of the same patient, no, ma'am. So
yeah, that is
so
okay.
then because we are going to do only the fractal analysis, so it's only in that standardization of the photograph, ma'am. Other everything is taken care of by the software.
Okay. Okay.
Thank you, ma'am. Thank you, sir.
Thank you. Moving on. Judges, please note, next presenter is faculty paper number 90. Judges, kindly note, next presenter is faculty paper number 19.
लॉगिन लॉगआउट क्यों हो गया ये? लॉगआउट क्यों हो गया ये?
कौन से लॉगआउट हो गया?
Hello, sir. You're
Hello?
audible. You're audible, sir. Can you please share your
Yeah,
screen?
but I am unable to share the screen actually. Hello? Just a minute. Yeah, is it visible?
No, sir, it is not visible.
It's not visible. Just a second. Actually, I'm having some issue with internet. Now is it
Yes.
visible?
Now it is visible, sir.
Okay. Very good morning to all. Very good afternoon to all. My topic is for presentation is early detection and multidisciplinary approach to oral cancer patients. These are my contents of the paper. So to introduce, oral cancer is a serious and potentially life-threatening disease that can affect the lips, tongue, gums, floor of the mouth, and other areas of the oral cavity. Early detection and a multidisciplinary approach are crucial for the successful treatment of oral cancer patients. Early detection of oral cancer is essential for improving the chances of successful treatment and reducing the risk of complications. A multidisciplinary approach involves a team of healthcare professionals from different specialties working together to provide comprehensive care for oral cancer patients. This may include oral and maxillofacial medical healthcare professionals. So these are the etiological factors causing oral cancers: tobacco, alcohol consumption, betel chewing, human papillomavirus infection or carriage, poor oral hygiene, genetic predisposition, Epstein virus infection, immune system diseases such as organ transplant recipient, HIV infected patients. These are the distribution of oral cancer in India, in north, central, and south, west, east, and northeast. So according to the incidence, there are some preventive awarenesses. First, to quit smoking, stop alcohol consumption, and vaccination for human papillomavirus causing oral cancers, and use of the social media to educate the patients, and depicting the oral cancer on the depicting the picture on the packet of the cigarette. Then early detection of oral cancer. Early detection of pre-malignant and malignant oral lesions is crucial, as late rate of 60% causes use surgical oncology. Yeah. Hello. Interventions or low survival rate. Many clinical, histopathological, radiological, and optical techniques to diagnose precancerous lent oral cancer lesions are in use today. These are the detecting techniques. There are several techniques. Some are physical examination, biopsy, vital staining, imaging techniques, spectrophotography, biomarker detection. The latest technology are biomarker detection, which includes the gene DNA array, enzyme assay, liquid chromatography, immunohistochemistry, polymerase chain reaction, and immunoprecipitation. Yeah. Then to diagnose the oral cancer and to treat the oral cancer, we have to follow the multidisciplinary approach for a successful outcome. So first, the early diagnosis is a crucial issue as so the routine management of oral cancer is first surgical resection with or without postoperative adjuncts and other therapies used as a part of postoperative chemoradiation and radiation. This approach is of combining multiple treatment has increased survival rates in the last decades. Successful treatment of oral cancer patients is a complex issue that requires multidisciplinary approaches, including oral and maxillofacial surgeons, oral and maxillofacial radiologists, radiotherapist, otorhinolaryngologist, oral and maxillofacial radiologist, oral pathologist, and prosthodontics. So now the recent advancements we can go for with the help of this multidisciplinary approach is that first is data collection. In this, we can collect, we can do the clinical examination, then do a CBCT histopathological examination, and then collect all this data. And for this, we require oral pathologist, oral radiologist, and prosthodontist. Then combining this data, we can plan a vertical surgical planning. For this, we require oral radiologist, oncologist, oral maxillofacial surgeons, and prosthodontist. Then merging dental model and fibula. For this, we require prosthetic and maxillofacial surgeons. Then design processes, define processes, and 3D print the processes and post processing.
So your time is up. Can you please conclude your presentation?
Yeah. This is one of the case in which we use the to rehabilitate the patient. These are the internal pictures. These are the digital planning for the patient. Then to conclude, early detection and a multidisciplinary approach are critical for improving the outcomes of oral cancer patients. A timely diagnosis of oral cancer is essential for effective treatment and a better prognosis. A multidisciplinary approach involving various healthcare professionals such as oncologists, surgeons, and speech therapists can provide comprehensive care to patients with oral cancer. Collaboration among these specialties can help tailor treatment plans to each patient's unique needs, improving their chances of recovery and enhancing their quality of life. Additionally, patient education and awareness about the importance of regular oral cancer screening can also contribute to early detection and better outcomes for patients. The take-home message is overall a coordinated effort between healthcare professionals to improve outcomes and a better prognosis of those with oral cancers. Thank you. These are my references.
Thank you, sir. Over to the judges.
What is the role in the clinical diagnosis and referral?
Sorry.
Clinical diagnosis. What is the importance of clinical diagnosis?
Multidisciplinary approach involves.
No, each one has its own role, isn't it? That is what is multidisciplinary. It has to be integrated. But what I'm asking is, what is the importance of clinical diagnosis? How far it is important?
Prompt clinical diagnosis helps in early detection, depending on the knowledge and experience of the clinician.
Okay.
No questions, ma'am. Doctor, you can.
Thank you. Moving on. Judges, please note the next presenter is faculty paper number 18. Judges, please note the next presenter is faculty paper number 18.
Can you see?
Yes, ma'am, we can see the screen.
Okay, okay.
Can you please put it in full screen?
Okay, okay. Can you see proper?
Yes,
Yeah.
ma'am, we can see your screen.
Okay, okay, okay. Thank you so much. A very good morning to you. I'm Dr. Somi Fatima. Now I'm going to show the study efficacy of pentoxifylline in treatment of oral submucous fibrosis. Oral submucous fibrosis is one of the most prevalent potentially malignant disorder affecting the oral cavity and pharynx. In this study, we use the pentoxifylline to relieve the clinical symptoms like burning sensation, mouth opening, intra-incisal distance, cheek flexibility. There are some etiological factors of the oral submucous fibrosis like areca nut, tobacco, smoking. Material and method. The study was conducted in our Department of Oral Medicine and Radiology, Uttar Pradesh, 2018, December to March 2018. The study was included 20 patients clinically diagnosed the OSMF, patients who were hypersensitive to drug pentoxifylline with the positive drug history of the anticoagulant were excluded. Prior to the study and informed the consent was requested from every participant. After taking written information, consent detained the case history through clinical examination. Staging of the OSMS was done according to the criteria. Professor Mover CV et al. 2020, which are as follows. There are the following armamentarium. Treatment modality. The patient was given intralesion injection of pentoxifylline, trade name Trantal, manufactured by the German Remedies Division of the Cadlia Healthcare Limited, given bi-weekly for the period of 3 months. All the patients were instructed to perform with mouth opening physiotherapy exercise at home. Each visit parameter like increase in the intra-incisal distance, cheek flexibility, temperature, relief in the burning sensation, and any side effect was measured and recorded. The dropout figure 0. This is a case history pro forma which noted the clinical symptoms of the patient and taken the all history of the patient. This is a consent form of the patient. This is a treatment of the pre and post treatment, how the patient come to mouth opening. This is a patient, the mouth opening of the patient is 12 mm. After the treatment, it is increases 15 mm. We're taking the bi-weekly intralesion pentoxifylline. It is another patient. Here is also another patient. This is one of the more patient. It is a result of the pentoxifylline. We can see the how can improve the mouth opening of pentoxifylline. It is a pre and post. Tongue protrusion, cheek flexibility, burning sensation according to the VAS scale, visual analog scale. Intralesional of pentoxifylline are given the promising treatment modalities of OSMF. However, more number of large clinical traits are required to establish its efficacy. Thank you.
What is the mode of action of pentoxifylline in oral submucous
Ma'am, it is a peripheral vasodilator. It's thinner the blood, so it's improve the cheek flexibility and burning sensation also.
Does it have any effect on the muscle?
Yes, ma'am. Pentoxifylline improve the muscular activity because it's thinner the blood. It's thinner the blood. That's why improve the muscular activity.
What are the side effects? Main side effects in which all patients you cannot use?
Ma'am, dizziness and vomiting.
Dizziness and is it contraindicated in any patient with systemic disease?
Ma'am,
any systemic disease.
Ma'am, can you pardon?
Is it contraindicated in any patient with systemic disease?
Any patient who are any patient like as MI, cardiovascular, the patient who indicated peripheral like pentoxifylline.
No, I didn't get you. Hello?
Ma'am, I cannot hear properly.
Is it contraindicated in any patient with some systemic diseases, specific systemic diseases? Sorry.
Ma'am, CVS patients, ma'am, like MI patients, ma'am.
What will happen if you give?
Yes, ma'am.
What will happen if you give pentoxifylline to such a patient?
Ma'am, it's thinner the blood. It's thinner the blood. That's why we take any kind of surgery. We take any kind of surgery. So blood is more occur, ma'am.
Okay. Okay.
Did you have any control group? Is this an RCT? Is it a randomized control trial or?
Can you pardon, sir? There is a
Okay, was this study a randomized control trial? Was it an RCT? Did you have a control group?
Sir, Trantal we use.
No. Did you have a control group?
So sorry, I can understand, sir.
Okay, that's okay. We'll move to the next presentation.
Okay, sir.
Thank you.
Thank you. Judges, kindly note the next presenter is faculty paper number 20. Judges, please note the next presenter is faculty paper number 20.
It's my screen is visible, ma'am.
Yes, sir, your screen. No, sir, your screen is not visible.
Yeah,
you can only see a
thank you.
black screen.
Now it's visible, ma'am.
No, sir, it is not. It's not visible.
Ma'am. Now the screen is visible, ma'am.
Yes, sir. Now the screen is visible.
Okay, thank you, ma'am. Good afternoon to one and all. Today my presentation topic was comparative evaluation and dosage dependent antimicrobial efficacy of derived nanoparticles against the dental karyogenic pathogens and in vitro study. So these are the contents. So according to the contents, I explain the details in depth. So coming to the introduction, the World Health Organization states that so all plant products, it is used for primary health care. So the percentage of usage of primary health care will be 80%. Why we can use the herbal medicine? Because it is available all over the world and it is easily accessible. My research material is ellagic acid. So already we know that ellagic acid is more available in many of the plant materials. In this research, I can take the ellagic acid material from pomegranate. So what I can do in this research is I can modify the ellagic acid combined with free silver material. I can convert it into nano silver particles, ellagic acid as one of the coupled agents. Why we have coupled with plant product means it should be less toxic in nature because the method is green synthesis by means of salt gel procedure. So as already told that the availability of ellagic acid is more in number. So we can easily synthesize the silver nanoparticles as a silver oxide as a precursor. So the advantage of nanoparticle is more effective, better antimicrobial property, high stability and high carrying capacity and easily adhesion to all over the structure. So the limitation or challenges of green synthesis is it should be stability in hostile environment, lack of understanding for preparing the nanoparticles because it is a minute work and technically sensitive work for making the nanoparticles into effect. It needs the expensive analysis for requirement. It needs skilled operators. The most possibilities or advantage part is it can be reused or recycled. So already we know that silver nanoparticles, it can inhibit the bacterial growth by interfering with the cytomembrane and causing the metabolic damage. But in this research, I can convert as we know that silver particles having the little bit toxic in nature. When we are using the ellacic acid as a coupling agent to make the silver nanoparticles, it should be non-toxic in nature. So all coming to the aim to evaluate the antibacterial property of synthesized ellacic acid coupled silver nanoparticles against Streptococcus mutans and Lactobacillus acidophilus. So objectives. So in this research, I can tell only the objectives regarding the antimicrobial evaluation by means of zone of inhibition, minimum inhibitory concentration, minimum bactericidal concentration, colony forming units, and biofilm against the Streptococcus mutans and Lactobacillus. So here the Streptococcus mutans, the ATCC number is 25175 and Lactobacillus is 4356. So synthesis of nanoparticles according to Safi et al. Ahmed. So he using the nanoparticles by means of salt gel method. So already know that why we are using the natural material, it acts as a bioreduction in nature. So first we can move on to the zone of inhibition. Here the concentration are 500 microgram per ml, 250, 50 and 100 microgram ml, and we have positive and the negative control. Negative control is without tested material. So from this table, I can visualize that 500 microgram, the zone of inhibition will be the 18 millimeter in nature. So this is an developing synthesized silver nanoparticles. So it is, when compared to the positive control, it is lesser in nature, but it has the significant differences present. Coming to the relative discussion for zone of inhibition, Emmanuel et al. He stated that he are using the J. gallica extract against Streptococcus mutans and Lactobacillus. He shows 25 millimeter. So, but in our study, the zone of inhibition was lesser than Emmanuel et al. Because we are using the different green synthesis method. So the difference is lesser in nature. So this will be the minimum inhibitory concentration and the biofilm. For validity of the study, I can take the...
So your time is over. Can you conclude your presentation?
Sorry, ma'am. Conclusion.
Yes, sir. Your time is over.
Okay. So I conclude that we can use the ellacic acid as nanomaterials. We can use against the Streptococcus mutans and Lactobacillus in 500 microgram per ml. So these are my references. Thank you.
Thank you. Moving on to judges.
That silver particles itself has some antimicrobial property, no? That's what you have told.
Yes, ma'am.
So then how do you decide that it is because of the silver particle or this pomegranate, whatever acid you have extracted?
Yes,
how do you
ma'am.
decide?
Yes, ma'am. First, we can take the metal precursor, ma'am. That is a silver oxide nanoparticles. We can mingle with ellacic acid in the ratio of 5:5, ma'am.
No, you didn't get my question.
Yes, tell me.
So you should have done a comparative study, silver particles alone and silver particle impregnated with pomegranate.
Yes, ma'am.
Then you could have got a better result, right?
Yes, ma'am.
Whether it is only because of the silver particle or there is an additional effect.
Additional effect by, yes, ma'am. Additional effect by using the ellacic.
So from this study, how will you know? That's my doubt.
Ma'am, actually, this is the vast study, ma'am. So previously, I can done the characterization method, ma'am. So for characterization only, we have to find out whether the nanoparticles is present in the particular solution or not, ma'am. So in characterization, we can use UV method, FTIR method, that is functional group description method, DLS. So every character and SEM analysis also, ma'am. So after that only the particular concentration we can move into the antimicrobial property, ma'am. So finally we can test it with cytocompatibility with human gingival fibroblast cell line, ma'am. So for confirmation, I can take the microscopic pictures also.
You have given it as a comparative evaluation, right?
Yes, sir.
What are you comparing this group with?
So the comparative against both Streptococcus mutans and Lactobacillus acidophilus.
Okay,
That is
your comparison is between two microorganisms, right?
Yeah, it is not between silver and this thing.
Nano
That's what I.
What is the normal antimicrobial therapy that you normally try for Streptococcus or Lactobacillus?
Yes, sir. For IC50, so only I can calculate the drug ratio is IC50 value, sir. So in IC50 value for Streptococcus mutans, it is the 200 microgram per ml. For Lactobacillus, it is the 125 microgram per ml, sir. So that is the IC50 value.
Of what? Of what? Which drug?
Sorry, sir. Ellacic acid coupled silver nanoparticles.
Okay. No, my question was two things. One, have you compared this with the normal gold standard medication that you're actually using? Okay. And number two, madam was asking, now silver nanoparticles itself has an antimicrobial effect, right? So are you able to differentiate between the nanoparticles effect as well as the coupled effect? Did you get the question?
Yes, sir. For coupled effect only, I can take a characterization method, sir. So in characterization, I can use the FTIR, that is Fourier transform infrared spectroscopy, sir. So
Okay, you're doing this for developing a medication purpose or inducing it into any material, dental materials?
Dental materials, sir, for making the dental materials.
And the last thing, do you know of any effects or adverse drug or effects of this material, or have you documented any?
Yes, sir. Yet now the in vitro study only completed, sir, by using the human gingival fibroblast cell line for cell type cytotoxicity, sir. So next stage I can move on into further research, sir.
Thank you.
Sir, I am audible, sir.
Thank you, doctor. Thank you.
Thank you, sir.
Thank you. Judges, please note our next presenter is faculty paper number 22. Judges, kindly note our next presenter is faculty paper number 22.
Good afternoon, everyone. Am I audible?
Yes, ma'am, you're audible.
Shall we start with the presentation?
Yes, ma'am. You can start the presentation.
Good afternoon, everyone. Good afternoon, dear judges. I'm here to present a case report. Though multiple syndromic and non-syndromic odontogenic lesions of the jaw exist in the literature, the synchronous occurrence of benign and malignant lesions are extremely rare with few cases reported. This is one such case where there was a synchronous occurrence of cyst malignancy and syndrome in the same patient. This patient, aged 28 years, reported to our OPD with a chief complaint of an incident growing painful swelling in the right side of the upper jaw since 2 months. And there was no relevant medical history or family history, but patient had a habit of tobacco chewing and alcohol consumption for the past 2 years. On general examination, the patient revealed a sprainal deformity, that is, the right shoulder blade was lower when compared to the left shoulder blade. On extraoral examination, the facial features were found to be apparently normal, except for a facial asymmetry which was noted in the right middle third of the face, extending supero-inferiorly from the right lower eyelid to the inferior border of mandible with obliteration of the right nasolabial fold. The skin over the swelling was normal with no evidence of secondary changes. On palpation, the swelling was soft to firm in consistency, tender, and compressible. Lymph node examination revealed there were two palpable submandibular lymph nodes on the right side, which were firm in consistency, mobile, and tender. Intraoral soft tissue examination revealed an expansive ulceroproliferative growth in relation to the right maxilla, extending from the distal aspect of 1-3 to the maxillary tuberosity, with the obliteration of the buccal vestibule, and medially it was extending till the midline, suture of the midline. And the surface of the growth was irregular with indentation of the opposing teeth. This growth was erythematous with evidence of pus discharge. On palpation, the growth was soft in consistency, compressible, tender. The surface was rough with evidence of pus discharge, but there was no evidence of bleeding. On intraoral hard tissue examination, we could appreciate pathological displacement of 1/6 with the evidence of root exposure. There was grade 2 mobility in relation to 1/5 and grade 3 mobility in relation to 1/6 and 1/7. In addition to that, there was missing 4/4/3/3 and reclined 7/3. Based on the chief complaint, the patient's personal history, and the clinical findings, we arrived at a provisional diagnosis of expansile soft tissue growth in relation to the right posterior maxilla, probably a malignant tumor. So we subjected the patient for further investigations. We took an OPG first. In the orthopantanogram, to our surprise, we could appreciate multiple distinct jaw lesions. We could appreciate an ill-defined radiolucency in relation to the right posterior maxilla, extending from the distal aspect of 1/5 till the involving the maxillary tuberosity. There was also distraction of the maxillary tuberosity, along with involvement of the maxillary sinus, and there was an impacted 1/8 associated with the lesion. Other than this, there were multiple distinct, well-defined radiolucencies surrounded by corticated borders associated with impacted 2/8, 4/8, 4/4, and 3/3. We subjected the patient for further investigations. We took both CBCT and CECT for the patient. Both the investigations reaffirmed the findings of orthopantanogram with a clear distinction of the extent of the lesions in all the 3 dimensions. In the CECT, we could appreciate a solid heterogeneous enhancing mass involving the right upper alveolus with destruction of both the buccal and the palatal cortical plates, which was associated with impacted 1/8. And in relation to the left maxillary sinus, we could be able to appreciate the homogeneous lesion associated with impacted 2/8, which is encroaching the medial wall of the left maxillary sinus. And an additional finding, the visualized section of the brain showed calcification of the fox cerebri. And we took a skull PAVO for the same patient, and it reaffirmed the calcification of fox cerebri. We also took a chest X-ray for this patient to find out any chest abnormalities or skeletal abnormalities since the patient depicted sprainal deformity during the clinical examination. So in the chest X-ray, we could appreciate there was mild scoliosis towards the right side, and there was a bifid rib, which was noted in the anterior end of the left fourth rib. We went for a PET CT to rule out any metastasis elsewhere in the body. In the PET CT, we could find a hypermetabolic activity in the right maxillary alveolus, and there was peripheral sclerosis and opacification of the left maxillary sinus associated with an impacted 2-8 likely to be a dentigerous cyst. In addition to that, there was also hypermetabolic activity in relation to the level 2 cervical lymph nodes and retropharyngeal lymph nodes, suggestive of metastasis. So histopathological diagnosis was moderately differentiated squamous cell carcinoma, inflammatory dentigerous cyst in relation to 2-8 and 4-4, and odontogenic keratocyst in relation to 3-3 and 4-8 region. So our final diagnosis was a rare variant of Gordon-Codd syndrome with involving malignancy and both odontogenic keratocyst and dentigerous cyst. So to be diagnosed as a Gordon-Codd syndrome, the patient should
Ma'am,
have
your time is
fulfilled
over. Can you please continue?
two major or one major and two minor criteria. Our patient fulfill three major criteria and one minor criteria. To conclude, this Gordon-Codd syndrome is a rare autosomal dominant disorder, multi-system disorder which requires multidisciplinary approach. So this case report sheds light on the schema operandi of arriving at a concrete diagnosis for such a case with numerous pathologies. Thank you.
Doctor, was there any lymph nodes present on clinical examination?
Yes, sir. There was right side submandibular lymph node. Two nodes were palpable, and clinically we could find only the submandibular node. But in the PET scan, there was also metastasis involving the retropharyngeal nodes and the level 2 cervical lymph nodes.
What all differential did you consider before going in for a radiographic examination?
So after the provisional diagnosis, we arrived at differential of carcinoma of right maxillary antrum and also major salivary gland tumor involving the palate.
Okay, did you consider, there was pus discharge, right? Did you consider any aspect of infection causing this?
No, sir, because the patient's history was clear and the patient also had a deleterious habit of tobacco chewing and alcohol consumption. So we straight away went for because it was a rapidly growing swelling also. So we went for a straight diagnosis of carcinoma or malignancy.
Okay, patient had any respiratory issues by the way?
No, sir, no, nothing was there.
Okay, and why did you go? You went in with the CBCT and then went with the CECT.
Yes, sir. Because in CBCT, the exact extent of the lesion could not be appreciated. So we went in for a CECT.
But I think you had a soft tissue and a hard tissue. You're always suspecting a heart. From the OPG itself, you were suspecting that already there are multiple underrupted tooth with cyst and probable tumors involved already, right?
Yes,
and
yes, sir.
And the soft tissue lesion as well, right?
Yes, sir.
On that note,
so actually, CECT was advised by the Department of Oral Surgery because we finished the patient with CBCT and we had a discussion of this case with the tumor board. So they wanted a CECT and we went for CECT and further investigations of PET scan.
I think my point would be you can directly go in with the CECT in this kind of case. This is a case which can clearly go in for a CECT at the first shot after the OPG. You don't have to take a CBCT in between because you're seeing a case where there is a soft tissue and a hard tissue pathology overlapping, right? And if you are looking at the soft tissue pathology as well, and if you're looking for an expansive lesion which is involving both spectrum, a better call would be to go in with the CECT at the first shot itself.
Yes.
If that is available, if you're not looking at a screening modality, right? Because your OPG had already given you some information which you needed, right?
Yes, yes.
At that level, you can do that. Yeah. Thank you, doctor. Thank you so much. Nice case.
Thank you.
Okay, we'll go to the
Thank you. Moving on. Judges, please note the next presenter is faculty paper number 25. Judges, please note the next presenter is faculty paper number 25.
The screen is visible. Hello, screen is visible.
Yes, sir, your screen is visible. Can you put it in full screen?
Yeah. Is it now fine?
Yes, sir.
Yeah. So my topic is dental 3D printing, the changing phase of dentistry. So now I'll start with the contents. So these are the contents of my presentation. What is the definition? Why 3D printing? What is the process? 3D printers used for the dentistry, methods of 3D printing, clinical applications of 3D printing, and the final is conclusion. So what is 3D printing? Basically, 3D printing is the process in which multiple layers of materials are added one by one under computer control to create three-dimensional object. Now, what is 3D printing? The 3D printing is generally used to describe a manufacturing approach that builds objects one layer at a time, adding multiple layers to form an object. Why 3D printing is required? It is used for mainly these purposes: educational, motivational purpose. It is a new approach for diagnosis as well as treatment planning. It is also used for faster and smoother procedures. Now, educational and motivation. When I was studying at that time, it is so difficult to understand anatomy. Where is the vessel going? Where is this tissue going? Where is the salivary glands? Nowadays, it is available with the 3D printing models. So it is very easy to remember. We don't have to like mug up as well as gaze the things. So this is why it is useful. It is also useful to tell us difficult anatomical structures also. Now, second, where it is useful for the patients. It is also useful for the patient. We want to motivate the patient that you have to get this treatment done. If we have 3D printed models, it is very easy to tell the patient to go for those treatments. It is a faster and smoother procedures. I remember when I was using this alginate or rubber-based impressions, I have to make the models and I have to send it to the lab. It goes to Bombay or Kerala and it will take a lot of time. Nowadays, what we have to do, we have to just take a scan and immediately it goes to the lab. We don't have to even prepare the models. Now, 3D printing process, how the 3D printing process goes. So as we all are aware of, first what we have to do is the scanning of the model or scanning of the tooth or what are the dental structures like intraoral scanning. And the next procedure is, so image equation is first done. Then it is converted into STL files. And then STL files are sent for the 3D printing. And ultimately, the final model is being prepared. These are the different 3D printers which are available in the market for the 3D printing. These are the three different technologies: STL, FDM, and this laser screen sintering. Now, application and uses of 3D printing in dentistry. So 3D printing in dentistry are used in almost all the departments. We can start with oral and maxillofacial surgeries for the fractures, for the screwing, for the platings, for making the mock surgeries. It is commonly used. So we can see some lesion is there and we have to excise the lesion, then we have to do the reconstruction. For that, we can create 3D printed models and it is easily done. So this is also a model of osteoma that is in the paranasal sinus. We can also use it for the implant procedures. We can also use this for the plates during the either reconstruction procedures or even during the this fracture cases. In prosto, it is most commonly used also in prosthodontics. Nowadays, nobody is like taking impression. They just do the crown cutting and then go for the scanning and send for the 3D printed models. And on 3D printed model, either the zirconia or PFM or the Brexit crowns are prepared. Even this cast partial dentures, that is also this metal works can be prepared with the help of 3D printing. The first patient treated with the help of 3D printing, that is in 1999. And this is a patient. 3D printed implants and fixed metal processes. We can design everything on the simplicity. Then we can go for the 3D printing models so that angulation is perfect. We know exactly the depth. We will not go beyond it. So it is commonly used for that also. It can be
Your
used along
time
with
is
the
over.
CPCT also.
Can you please
Okay.
conclude your presentation?
Yeah, so ultimately the 3D printing is useful in a such a way that it makes our life so easy. We don't have to like think a lot. Even in root canal treatment also it is used. CPCT is showing us 5 or 6 canals, and as a clinician we cannot perform it. So we are having already the models, and we can easily perform any of the complex treatment or the simplest treatment with a more efficacy. Thank you.
Thank you. Over to judges.
Yes, doctor. Could you, add all those softwares which will help you in 3D printing and designing at clinician level?
Sir, usually I am not doing it, but yeah, a lot of models are there, 3D models, softwares are there, which I use for this, DDS Pro and many other models, softwares are there, but I am not 100% aware of the names of it, sir.
I think we can use Blue Sky Bio, ExoCAD, ExoPlan. These are software which will help you with 3D, designing
Right, sir.
and then probably printing. I'm very happy that you included about the root canal treatments also, because you can print the guides for exclusively doing root canal treatments where multiple root
Yes,
canals
sir.
also. Even before going in with the root canal, you will have a stent which you can keep on top of a single tooth itself. So you
Yes,
can
sir.
engage multiple root canal, you can approach correctly with stoppers
True,
so that
sir.
you don't, go beyond the apex.
Go
Or,
beyond, yes, sir. No apical perforation will be there, right? And no canals are also missed.
Are you using any of these 3D printed models now? No.
Yes, sir, all. We are using for endo, yes, we are using for
No,
endo, we are
are
using
you
for
personally
implants.
using it for any implants or anything?
Yes, sir, we are
You
using
are
for
using
implants
it.
also.
Okay. Are you aware of this dual impression, dual technique which we use for complete dentures?
A dual impression of a complete denture for with the help of this 3D printing, sir?
Exactly, yeah.
Yes, sir. That is a major advantage nowadays, that once you scan the patient, even that patient is in US and patient wants another denture, we can get the printed done and we can send it.
No. The thing like what I was asking is,
Yeah, you
with
take the
with the
impression, yeah, intraoral scanning and then superimposition. That's what you are
exactly,
telling, sir.
yeah,
Yeah, sir.
exactly, yeah.
Yes, sir.
Yeah,
Right.
right. Thank you, doctor.
Okay. Thank you so much. Thank you.
Thank you. Judges, please note our next presenter is faculty paper number 12. Judges, kindly note our next presenter is faculty paper number 12.
Yes, Dr. Apsi, is that the last presentation?
No, sir, second last. We have 2 more presentations.
Can you hear me?
Yes, ma'am, we can hear you.
Okay.
Can you please share your screen?
Is it not shared?
It is shared. Can you open your presentation?
Is it shared?
No, ma'am, it is not.
Ma'am, is it shared?
Yes, ma'am, we can see it now.
Okay. Let me start my presentation. Let me start my presentation.
Yes, ma'am, you can start your presentation.
Okay. Respected judges, good afternoon. Today, I am presenting a paper on research titled Divulging the Undivulged. You know, this is a famous actor, Paul Walker, and his body was burned beyond recognition. Antemortem dental radiographs were used for his recognition. What will we do when identity of an unknown person is mysterious even after death? Yes, we have to unveil the unknown person. So the aim of my study was to evaluate the measurement of frontal sinus and to examine the combined patterns of frontal sinus and nasal septum as observed on a postero-anterior cephalogram and to use the data in gender determination and personal identification. Significance of the study was that literature review did not reveal any combined use for identification in Kerala population, and also the study employed PA cephalogram as a demonstrated adequate and standardized frontal sinus morphology and nasal septum pattern with minimal distortion on a single radiograph. Inclusion criteria were healthy adult male and female individuals aged within 20 to 50 years and willingness to participate in the study. Exclusion criteria were pregnant women, radiographs with artifacts, and poor quality radiographs. So this is a cross-sectional study conducted in the Department of OMR during the study period 2018 to 19. Ethical committee clearance was obtained before starting the study. A total of 120 individuals, that is 60 males and females, were included in the study. Coming to methods, radiographs were performed after taking necessary radiation protection measures, and tracing of frontal sinus and nasal septum outline was done on the radiograph. Then maximum height and width of frontal sinus by a line was drawn directly between both orbital cavities at the nasofrontal suture. The width of the frontal sinus at the widest point was measured, and the maximum height of the frontal sinus was measured by drawing a line parallel to the nasofrontal line at the highest superior point. Frontal sinus pattern according to Taniguchi-Ito criteria, that is the maximum horizontal dimension was measured from the central septum on both sides. The difference in right and left dimensions were divided by greatest dimension and multiplied by 100. If the percentage obtained was more than 20%, then it was asymmetrical for the respective side sign. Nasal septum pattern according to Taniguchi-Ito criteria, that is straight, right deviated, left deviated, sigmoid, and reverse sigmoid. Then the various possible combination of the resultant pattern were evaluated. Statistical analysis were done, and coming to results. On comparison of maximum height and width, mean value of maximum height and width was more in males than females, which was highly significant. And on comparison of right and left height and width, left side height and width was more in males and females when compared to right side. So only the left width was significant. On overall comparison of frontal sinus pattern, symmetrical pattern was predominant in males and females, followed by left asymmetry and right asymmetry, and this was insignificant. So coming to nasal septum pattern distribution, right deviated nasal septum was more predominant in males compared to left deviated and symmetric pattern. Coming to females, symmetric pattern was more predominant, and this was significant. So after combining the frontal sinus and nasal septum pattern in all the 120 individuals, it was concluded that 41 males and 31 females were correctly classified using the combined analysis with an overall percentage of 66.7%. And in personal identification, there were 24 classifiable patterns in 70 individuals and unique pattern in 50 individuals. So the result confirmed that this combined analysis can be used for the useful in the early screening in mass disasters. So coming to limitations, the frontal sinus will become thinner and look larger during the old age, and the technique needs standardized parameters, and it was also affected by environmental factors, genetic factors, as well as growth hormone. Future perspectives for the studies with larger sample and also with implementation of newer parameters are necessary. So to conclude, according to Saltman, the larger the island of knowledge, the longer the shoreline of wonder. So these are my references. Thank you.
Now, doctor, you mean to say there is a difference between the frontal volume from males to females, or?
Sir, actually, the difference between males and females, and also that is the gender determination. So, and also in personal identification, by using the Frendesinus measurement, we can identify that it will be unique for a particular individual.
Okay, for that you need to have a ante-mortem scan as well, right?
Yes. Ante-mortem radiographs are necessary, but here in this
Very
study,
unlikely for a patient to go in for a PA. Not very as common as an OPG that we take for a patient, right? Unless it's an orthodontic case or probably even for an orthodontic case, you would go in for a lateral cephalogram.
Sir, actually, after death, we can do a PA. Actually, it is a study that whether this Frendesinus and nasal can be combined, and whether it can be used in the personal identification and gender determination.
Okay, you are trying to prove a point that there is a uniqueness in a lot of patients. Around 50 patients had unique pattern. That is what you're trying to say,
Yes. Unique patterns are there, and also overlapped patterns are also there.
Okay, but from this study, we cannot classically say that, probably this is a male or a female looking at the just after the postmortem. If you take a from a PS, you cannot identify whether it's a male or a female, right? You can just say that, at this point, you are able with the information that there is a difference, and if you work with that, you can probably use it as a mass scale.
In mass disasters, if so many people are there, then we can identify whether it is a male or female by doing the measurement and also patterns of Frendesinus and nasal septum.
But I'm sorry, but I didn't understand. You said there is no gross change, right? It's almost similar, right? Males and females. That's what your study said, right? Your results.
That was insignificant. Frendesinus pattern was that is asymmetry, symmetry. That was insignificant in the study.
Right. Thank you, doctor.
Okay, thank you, sir.
So this ante and post-mortem, will pneumatization affect the site? Will it happen? Pneumatization, like in maxillary endo.
Ma'am, cannot hear, ma'am. Pardon. Ma'am.
What about pneumatization? Will it happen in the frontal sinus as happens in the maxillary sinus?
Yes, ma'am. Pneumatization will be there. So
the dimensions and the shape, everything may change.
Yes, ma'am. Dimensions and that will change, and sinus will become larger. So that's why the study took only 20 to 50 years age group. So the Frendesinus will be matured only within the only by 20 years of age, and after 50 years or during old age, this Frendesinus will be there will be resorption, and Frendesinus borders will be thinner and sinus look larger.
So you can use it only in that stipulated age group. No?
Yes, that is the limitation, ma'am.
Okay.
That is the limitation of the study.
Thank you.
Thank you, ma'am. Thank you, sir.
Moving on to the last presentation of the session. Judges, please note, we have faculty paper number 23. Judges, kindly note, next presenter is faculty paper number 23.
13 is not there.
No, ma'am, 13 is not responding.
topic for today's presentation is non-sleep industry.
Not audible.
Am I audible now?
Yes, ma'am, you're audible.
Good afternoon, everyone. Today's topic for presentation is sleep industry. There's no sort of it is a review. I will be reading under the contents. Sleep disorders, sleep-related breathing disorders comprises a variety of diagnoses which include central sleep apnea, obstructive sleep apnea, upper airway resistance syndrome, and obstructive sleep apnea is the most prevalent sleep disorders, and it accounts for about 80% according to the American Dental Association. And significant and anatomical abnormalities and variations poses risk factor for this development of sleep disorders, and this vulnerability is also due to the both genetic susceptibility, but the contribution of genetic susceptibility to the disease development and its extent is unclear because of the limited studies in these areas. The repercussions of the sleep disorders are seen in different systems, including the central nervous system, cardiovascular system, which subsequently causes mortality and the morbidity. The gold standard for the sleep-related disorders, particularly obstructive sleep apnea, is polysomnography, but the structured questionnaires along with the clinical prediction models also plays an important role in the diagnosis of the diseases. The first line is always continuous positive airway pressure, but in studies, it was shown that whenever the patient has poor patient acceptance or adherence, there will be low effectiveness of the treatment. So in such patients, oral appliances fabricated by the qualified dentist in dental sleep medicine for patients who are unable to tolerate this disease, a CPAP is an alternative treatment for such cases. There are short-term RCTs, that is randomized controlled trials, that shows that the mandibular advancement oral appliances therapy, which improves the somnolence, vigilance, and neurocognitive performance in such patients. There are certain limited number of studies which shows the improvement with the help of upper airway surgeries, but the results are not very clear because of the limited studies in the region. Orofacial myofunctional therapy, which aims to retrain the positioning of the different structures, including lip, tongue, and the palate, and positioning of the teeth, helps in the normal nasal breathing. So in a study by D. Felicio et al., it was shown that in a study among 54 children with OSA, there was myofunctional therapy was carried out, and there was significant improvement in the mean oxygen saturation and the desaturation index in the treatment group. And a meta-analysis shows a decrease in the apnea hyperapnea index in about adults at 50% and 62% in children, and the polysomnographic studies have indicated 72% reduction in snoring and improvement in the muscle tone. So they are the adjuvant of obstructive sleep apnea patients. Policy statement by American Academy of Dental Sleep Medicine state that dentists play an integrative role in reducing the public health burden in a diagnosis of these sleeping-related breathing disorders. Further explorations in the field of actively should, including the oral physician, the management team will actually help for the collaboration with the referring sleep medical physician, so that there will be better opportunity for best effective treatment for the patients. These are my references. Thank you.
Doctor, what are the clinical signs that you would look for when you're having when you're suspecting a case of OH?
In oral features, like there will be accretion of the dental teeth, and there will be more erosive changes, the regressive alterations of the teeth will be there. Patient gives the symptoms of snoring. A patient will have difficulty in the oral mouth breathing due to the obstruction in the sleeping pattern. So.
Okay, doctor, as I understand, there's a clear classification of how when you are supposed to go for a CPAP, right? If it's a case which is indicated for a CPAP, I don't think you are treating it with an oral appliance would help you that way, right? There's a clear classification. I do appreciate that, there is a lot of enhancement of, airway volume. Even when you're taking a scan, in the increase in the airway volume increases when you're using an OSA. Sleep appliance.
Yes,
Okay.
sir.
But again, there are some, there is some level of contradiction where people use mandibular advancement devices where there is compression of temporomandibular joint, disc space, which again in turn causing pain. So looking at that aspect, there is a clear protocol which has to be established, right? So
Yes, sir.
which all cases you can go in for a CPAP,
Yes, sir.
which all
That
cases
is
you can.
the that is the problem because of a dilemma in treating the patients, which kind of patients can be treated by medical sleep physician, on which kind of patients can be treated by therapist. So there is a clear definition is not actually is not there. So there requires more randomized control trials and analysis in such cases.
There is a definitive study where you look at the episodes of apneic episodes the patient is getting. Okay, so if that index is very high, and if it is not an upper airway respiratory syndrome, then you would probably go in for a CPAP rather than a
appliance.
There are cases where you can give us appliance and a CPAP together, because while traveling, the usage of a CPAP is a very difficult process. Okay, but again, there are hybrid machines which you can fit inside a small bag also. CPAP machines are available, which is less than 18,000 rupees. You can buy one of those appliances. So still there are people who are using CPAP machines, but it's definitely a game changer using appliances. There are sleep appliances specifically. There are labs which do sleep appliances, oral sleep appliances in the US. Again, in India, there are a lot of labs where they are doing sleep appliances, which will enhance the patient quality of life. Definitely, the hypapneic episodes come down. The patient will be more active. The patient's the whole compliance increases actually. Thank you, doctor.
Thank you, Doctor. We have come to the end of our faculty paper presentation session 2. Thank you, Dr. Beena Madam, and thank you, Dr. Arvind Sir, for giving us your time and patience. As a token of our gratitude, on behalf of the scientific committee, we would like to present you the certificate of appreciation.
Thank you.
Thank you, madam, for this opportunity, and thank you all participants. It was lovely listening to all of you. Thank you so much.
Once again, thank you all. The results will be announced later. Have a nice day.
Okay. Have a nice day and thank you all. ठीक है, ठीक है। तुम हाँ, मेरा हॉल है, तुम्हारा हॉल 2 है। तुम क्या प्रिपेयर हो गई हो? कौन से? डोमिनिक से? क्या बोले से? क्या क्या पूछी तुम ऐसा?
अच्छा ठीक है आस्था। हाँ हाँ ठीक है ठीक है। अब चलो तो मेरा तो लास्ट में होगा 3:30 के बाद ही होगा क्योंकि 2:30 से शुरू है। मेरा एकदम लास्ट है प्रेजेंटेशन उस हॉल का। और तुम्हारा हो जाएगा उससे पहले, मेरे पहले तुम्हारा हो जाएगा। ठीक है आस्था।
അല്ല ഒന്നും ഇതിനകത്തൊന്നും കാണുന്നില്ല. മ്യൂട്ട് നമ്മളെന്താ ചെയ്യണം? മ്യൂട്ട് ചെയ്തിട്ടുണ്ട്. ഉണ്ടല്ലോ മ്യൂട്ട് ചെയ്ത് വെക്കണം. പ്രസന്റ് ചെയ്യുമ്പോൾ മാത്രം അൺമ്യൂട്ട് ചെയ്യണം. കേൾക്കുന്നുണ്ടോ?
അപ്പൊ തുടങ്ങിയിട്ടില്ലല്ലോ ഇല്ല ആ തുടങ്ങി അതായിരിക്കും
Good afternoon, dear delegates. Kindly label your with your phone number. Kindly label your name with your phone number. Good afternoon, ma'am. Good afternoon, Dr. Lakshmi. Good afternoon, Dr. Lakshmi, ma'am.
Can you hear me?
Yeah, ma'am. Kindly confirm with each paper one. Please raise your hand. PG paper one. PG paper two. PG paper two. Please raise your hand.
PG paper 1 is here. Please confirm.
Okay. PG paper two.
Paper 2 is also here.
PG paper 3.
Can you see?
Yeah.
PG paper 1 is present.
Yeah. PG paper 02, please confirm.
Paper 2.
PG paper 3. PG paper 3, please confirm. PG paper 4.
PG paper 4 is here.
Okay. PG paper 5.
PG paper 5. Present. PG paper 5, present. PG paper 6. Please come to PG paper 6.
Yes, I'm present.
Okay. PG paper 7. Please come to PG paper 7.
PG paper 7 present.
PG paper 8.
Present, ma'am.
PG paper 9. PG paper 9. PG paper 10.
Yes, I'm here.
PG paper 10. PG paper 10, please confirm.
I'm present.
Okay. PG paper 9, please confirm. PG paper 9, please confirm. PG paper 9. PG paper 9, please confirm.
Hello, ma'am.
Good afternoon. Let's start the session. Am I audible? Hello, am I audible? Please respond. Am I audible?
Yes.
Okay. Vishwagiri College of Dental Science. I'm delighted to host Kerala State's 5th annual of Conclave. Let's start the scientific presentation under Department of Oral and Maxillofacial Pathology, starting with postgraduate's paper presentation. Now, going on to session 1, call 1, we invite judges for our session. It is my privilege to invite Dr. Priya Thomas and Dr. Lakshmi Priya. Dr. Priya Thomas, Professor, Department of Oral and Maxillofacial Pathology, Annu Dental College, Kodamangalam. Dr. Lakshmi Priya, Professor and Head of Department of Oral and Maxillofacial Pathology, Al-Azhar Dental College, Tirupura. We welcome you, ma'am. Now let us proceed to the instructions. For paper presentation, you have 5 minutes. You will be given 30 seconds for the screen share before presentation. If your time exceeds more than 30 seconds, next candidate will be called off and you will be given a chance at the end. You will be given a warning at the 4th minute, preceded by a final warning at the 5th minute. I hope the instructions are clear. Now let's start the section. I would like to call PG paper 1. You will be given 30 seconds for screen sharing.
PG paper 1?
Yeah, please.
Yeah, you will
Can you see?
screen sharing. Yeah, sure.
Yeah, we can see.
Can I start?
Yeah,
please, ma'am.
Yeah, good afternoon, everyone, and happy Holi to everyone. I'm going to present a review on microRNA, role in salivary gland tumors, diagnosis, and prognosis. These are my contents. Let's start with what is microRNA. MicroRNA is a major class of small, containing 22 to 24 nucleotides, non-coding RNAs, which are present in animal, plants, and some viruses. The first microRNA was discovered in C. nor Hebditis elegans in 1993, and at present, there are 2,675 human mature microRNAs have been annotated. The important role of microRNA in biological functions are cell differentiations, embryogenesis, metabolism, organogenesis, and apoptosis. Let's see how this microRNA takes place. The biosynthesis of microRNA is a very complex process which takes place within the nucleus, where the primary microRNA cleaved into a precursor microRNA in the presence of DG and an enzyme which is known as DROSHA, where after that it goes out from the nucleus into the cytoplasm, where maturation process continue. This precursor microRNA is cleaved by RNA type 3 enzyme, which is known as dicer. We generate a duplex RNA of about 22 nucleotides. And these microRNA duplex, which augment with the AGO complex, the protein which is organoid, which attach with this duplex, and the passenger, one of the two strands, which degrade, and the main arm becomes the mature microRNA. This mature microRNA leads to the messenger RNA target cleavage, translation repressions, and messenger RNA deadenylations. Let's see how the method of this microRNA analysis happens. The first step is microarray. Microarray is a technique which is used in journal laboratory, which helps us to look at gene expression or the amount of gene expression RNA from any genes at the which is found in the cells. Next is the microRNA sequencing. MicroRNA sequencing is different from another RNA sequencing because in this the microRNA, the input material which is often enriched with small mRNAs, and identification of maturation mutation in microRNA could be identified by ultra deep sequencing, even if these mutations occur in a very small fraction of samples. Next is the real-time polymerase chain PCR method for analysis of microRNA. There are two methods, poly-A tailing method, and another is the traditional method. And the next method is absolute quantification of droplet digital PCR method. Droplet PCR method, in which happens in 3 steps. First, reaction is the reaction regions are partitioned into approximately 20,000 droplets, and after that, the PCR reaction completed, and every droplet is seen with the fluorescence. Fluorescence is checked whether it is a positive or the negative results. What is the main role of microRNA in salivary gland cancers? Very few studies have been done in which the microRNA role in salivary gland tumors. Mostly these studies are done in two major carcinogens, that is mucoepidermal carcinoma and ACC. According to Chen et al., he investigated the mRNA expression profile in adenoid cystic carcinoma, and different expression patterns in cancer cell during metastatic developments has been seen. And various researchers examined microRNA profiles in saliva also, which is easily available and obtainable. According to
Sir, you
Mestiaon,
have 1 more minute
discovers
left.
4 types of microRNA. The expression in saliva samples have deep diagnostic value, possibly allowing the discrimination between it differentiate between a benign or a malignant salivary gland tumors. Next is the investigation are carried out in the blood samples also, where we found a significant upregulation of these microRNA patients with malignant salivary gland tumors compared to benign tumors. According to CentOS, only microRNA R9 exhibits significantly increased expressions in benign tumors, whereas microRNA 195 shows significantly decreased expressions in malignant tumors. According to Zhang et al. Showed that microRNA 21, which has important role in the embryological development of submandibular glands, is implicated in submandibular tumors, also salivary gland tumor progression also. MicroRNA in diagnosis and prognosis of salivary gland tumors. MicroRNAs plays an important role in tumor development and tumor progression because it has a very important, it regulates the biological processes. Two studies demonstrated that a combination of microRNA found in the saliva capable of diagnosing patients with different malignant. Only 1 minute, please, ma'am. Salivary gland tumor with 90% specificity.
Your time is up. Sir, your time is up.
Last, I want to conclude that recent emerged the potential cancer cell regulators.
Okay, sir.
It's very important. MicroRNA identified in various studies might be potentially used in different diagnoses, and accurate diagnosis will helpful for accurate treatments. These are my references, ma'am. Thank you.
Okay, thank you, sir. Now it's time for discussion. Over to you, Dr. Priya, ma'am.
Yeah, Dr. Amit, this was a review done in salivary gland, right?
You have a review done on
Hello, can you hear me?
microRNA, ma'am, on salivary gland tumors. Yes, ma'am.
Okay, so these are whatever studies you had referred, they were done on serum, or they were done on what was the outcome of it, serum or tissue samples? What you had taken?
Ma'am, few studies are done on serum or plasma.
Yeah, whole plasma, and the others in any tissue samples you had taken and seen for the regulation, any studies which you had referred?
Ma'am, as you see, I will quote you.
I came across serum,
Few studies were done
saliva.
on serum, ma'am. Yes.
Yeah.
Yes, ma'am.
What about tissue samples? You came across any literature in tissue samples which they've done in salivary gland tumors?
No, ma'am. Mostly these studies were done mostly on serum or plasma or saliva, which I have studied, ma'am.
Okay. Fine.
Yes, Dr. Amit.
Yes, ma'am.
Yeah, it was a good presentation, but I think the slides were a little busy actually. You could have made it much more, lesser words you could have put. And you said that microRNAs are upregulated and somewhere it is also downregulated, right, in tumors?
Yes, ma'am. Yes, ma'am.
So, okay, how can you use it as a prognostic marker?
Well, in some cancer cases, that some microRNA act as oncogenes. On the contrary, these microRNAs act as tumor suppressors. But these oncogenic microRNA, their activity increases in the cancer process. On the contrary, the tumor suppressor microRNA, their activities decreases, downregulated. which leads to all the angiogenesis, cancer activation processes.
So you think you can take it on a clinical level?
Sorry, ma'am?
Can we take it on a patient basis?
You can't hear me, ma'am. It's not clear, ma'am.
No, can we use it for the patients? You say it's, can we use it for prognosis of the patient?
Yes, ma'am. It's helpful for the prognosis of the patient.
This is the prognosis. Okay.
Thank you,
Thank you.
judges.
Thank you, ma'am.
Next is feature paper 2. You will be given 30 seconds for screen sharing.
Okay, ma'am.
Your time starts now.
Ma'am, is the screen visible and the
Yeah,
presentation also? Ma'am, just a minute. I'm just putting it in the full screen mode. Is it visible? And I'm audible?
Yes, yes.
Okay. Good afternoon, respected judges. The topic for my research is analysis of mucormycosis patients. Ma'am, can I continue or should I stop?
Your time starts now. You can continue. The time is running.
Okay. Good afternoon. The topic for my research is analysis of mucormycosis patients during the second wave of COVID-19 in India. These are the contents. Introduction. Mucormycosis is a serious but rare fungal infection which is caused by a group of mold called mucormycosis. The spores of this fungi are ubiquitous in nature. They can be inhaled and can infect the lungs, sinus, and brains and eyes of a person. It is an opportunistic infection, and when inhaled by the patient with a compromised immunity, it may lead to them developing the disease. It is non-contagious in nature, but can be debilitating or fatal if not treated quickly. And during the second wave of COVID-19, this rare disease transformed into a common occurrence, and up until 28th June 2021, India reported 40,845 cases of mucormycosis. If the progression is not checked early, 50 to 80% of the patients can die, and permanent disability because of amputation of organs is very common. Thus, the early detection of the fungal infection is the need of the hour. The aim and objective of the study were to study the incidences of mucormycosis based on demographics and dental diagnosis and treatment. The objective was to analyze the patient's data who suffered from the disease and to use the analytical summary prepared for an early diagnosis of the disease in the most commonly affected patient demographics in order to prevent the amputation and other complications of the disease. These are few of the literature reviews that I did during my study. Most of them worked with relation between COVID-19 and mucormycosis. The data was collected from private dental clinics and from the Department of Oral and Maxillofacial Surgery of RUHS. 97 patient data was collected, which was entered into the questionnaire which was made using Google Form. This was the questionnaire. There were total 9 questions, which included the history of COVID, the demographics of the patient, the jaws involved, and the surgery performed, etc. The data was entered into the Google form, and these pie charts were obtained with respect to individual questions which were observed and analyzed. The results obtained showed that mucormycosis was most predominantly seen in the age group of above 50 and then in the age range of 41 to 50 years. Males were more commonly affected. 63.3% of the patients had the history of COVID-19 and 62.5% showed presence of symptoms. Maxilla was most commonly affected, and during the surgical intervention, segmental removal of the jaws was most common, with removal of both anterior and posterior segments. Conclusion. COVID hit us in 2019, and it's been 4 years since then, and yet we do not have a permanent cure for the disease. Up until we cannot stop COVID, we can at least try to eliminate or reduce the comorbidities occurring with it. Mucormycosis has the ability to permanently disable a person for life, and thus proper diagnosis and treatment planning is the need of the hour, which can be achieved by extensive research and treatment planning. The limitations that I observed during the study was that because of improper and incomplete maintenance of patient records in dental setting, I was not able to collect proper data, and a multiple parameter analysis was not possible. The future aspect of the study are to collect more extensive data and correlate more factors with mucormycosis, like systemic diseases, habits of the patient, hospitalization history, etc., identifying risk factors and implementing preventive measures such as enough testing facilities for black fungus, maintaining a regular communication between the healthcare authorities and COVID and post-COVID patients for early assessment and detection of the infection to halt the disease in its budding stage, and create an awareness amongst the population. These are my references. Thank you.
Ma'am, you have 1 more minute left.
I'm done.
Ma'am, you have 1 more minute.
Yeah, I completed my presentation.
Okay, thank you, ma'am. Now over to you, Dr. Priya Pama.
Thank you.
Yeah, was this all histopathologically diagnosed cases? How many cases did you come across?
Ma'am, are you able, sorry, are you just able to see my presentation, right? I just
I
shared
saw
my
your
screen again.
presentation. Yeah.
Ma'am, I actually collected patients' data, and
Yeah.
97 patient data I collected.
It was data. No, you didn't cross-check with histopath finding. You're not.
No, ma'am.
They were
Not that,
diagnosed
ma'am.
cases?
Yes, ma'am. They were diagnosed cases. They were the cases which were diagnosed and they were treated, and that data I collected.
How was the prognosis of these patients?
Ma'am, in general, the prognosis was not that good because people were not aware about the disease. And in the majority of the cases, as you can see, there was a removal of the jaw was there, like in major, like it did extend, basically, because I collected the majority of the data from dentist. So a lot of jaw removal cases I came across where maxilla or mandible was removed. I want to extend the research towards ENT as well, because yes, there are cases in which the eye orbit and everything was also removed. So those cases I did not come across, but once I get in touch with ENT from whom I can collect the data, I'll do the study on that as well.
Okay, based on your analysis, other than COVID, or what in COVID could have led to mucormycosis in these patients?
Ma'am, can you please repeat the question?
Basically, did you were they on corticosteroids for long? All these patients which you analyzed, or there were some other factors associated with COVID?
Yes, ma'am. So, ma'am, originally my research was based on these parameters only, that if the patients had the history of using corticosteroids, what systemic diseases they had. But the issue that I faced was that when I collected all the data which I received, this medical history aspect, that did the patient was on oxygen cylinders, did they consume steroids? There was also this study which sort of proved that people who were using cow dung and cow urine for the treatment of COVID got more prone to mucormycosis. So these 3-4 parameters I was not able to assess in my study because I was not able to get the data. So with respect to COVID, what I observed was mucormycosis is something which we can come across if we have a low immunity, regardless of getting COVID or not. But people who had COVID, they showed more chances for the disease, and that is obviously because of the lower immunity. The relationship with respect to steroids and all, that I'm trying to get my hands on, because I need patients' data, because for the study I did not take patients' contact information. So I'm just trying if I can get that and their consent, so that I can have a one-on-one interview, so that I can get more elaborative data for the same.
Okay, fine. Lakshmi ma'am?
Thank you, Priya ma'am. Now over to you, Dr. Lakshmi.
Good afternoon,
ma'am.
doctor.
Good afternoon, ma'am.
Where's the patient population from? From the clinics or is it from a hospital?
Ma'am, the patient population.
The data you collected, right? Where is it from? Is it from clinics or hospitals?
No, ma'am. Ma'am, Rajasthan University of Health Sciences. Ma'am,
Okay.
from the dental college, ma'am, in Jaipur.
Dental
Yes, ma'am.
college. Okay. So, did you come across any patients without any immunocompromised situation in this whole data? Anything striking or any different feature or anything unique you found in these data? All were immunocompromised or?
Ma'am, at present, with respect, I think I won't be able to comment on that because my data is quite low right now. So
Okay.
at present, I did not come across any uniqueness as such.
Okay.
But the one thing that I observed was that in majority of the cases, maxilla was involved. In the demographics, 99% maxilla was the jaw, which was affected by the fungus.
Okay. And were there any different in the symptoms? Did you take a note of that? Was there any difference between a normal presentation and a COVID patient with mucormycosis? Was there any difference in that?
Ma'am, in my study, I was not able to observe that, but
Okay.
in the literature review that I did, in that I observed that the extent or the intensity of the fungus was more in the when it was in the COVID patients.
Okay. Okay.
Thank you, judges.
Thank you, ma'am.
Next. So next is PG paper 3. You will be given 30 seconds for screen sharing.
Yes, ma'am. Can you see my screen, ma'am?
Yes, yes.
Okay. May I start, ma'am?
Yeah.
Okay. Good morning, good afternoon, all. Today my presentation is expression of CFAs in normal oral mucosa versus odontogenic keratocyst using real-time quantitative polymerase chain reaction. Coming to the introduction, OKC is a unique cyst with the neoplastic characteristic, say locally destructive, highly recurrent, and having highly aggressive behavior with the mitotic count 8 and the expression of P53, proliferative cell nuclear antigen, and the Ka67. Coming to the CFAs, the activator protein complex are the transcriptor factors that controls a variety of cellular processes which include differentiation, proliferation, and apoptosis. And they comprises of two families, June family and the FOS family. Among this, the CFAs is the most important one because they are mainly involved in the tumorigenesis. The CFAs is a proto-oncogene. Activation of the CFAs transgene will result in the overexpression of cyclin D1, A, and E, which might contribute to uncontrolled growth leading to tumor. This overexposed CFAs will result in high-grade lesion and poor prognosis. By connecting the two dots that OKC exhibit neoplastic behavior and CFAs plays significant role in tumorigenesis, the study was aimed to evaluate the expression of CFAs in subject with odontogenic keratosis by keeping the normal oral mucosa as a control. This is the XYO study with a 24 sample, 12 OKC and 12 apparently normal mucosa, included both male and female of year 20 to 65 years, histopathologically confirmed cases of OKC and the normal oral mucosa, and exclusion criteria are people who has undergone the treatment for OKC, known malignancy of other cysts, or known malignancy, or the people taking the psychoactive drugs. Coming to the materials and methods, the fresh tissue samples, as soon as the finishing of operation was taken, one was given for the histopathological confirmation and other was taken for our study. Now it was stored in the RNA later and it was kept over thawing in the ice for thawing. After the triazole reagent was added. Using the tissue grinder, the tissue was completely homogenized into a paste. After that, chloroform was added and centrifuged. With that, we have got three complete different layers. The superficial most layer will contain the RNA. With the RNA, continuous ethanol rehydration was done, and we have got the following pellet. With the pellet, we have added the DEPC liquid. With that, we have done the nanodrop quantifier. The nanodrop quantifier is basically in order to see the quality of RNA. With the RNA,
we have extracted the cDNA using the following cDNA conversion kit. After that, the given forward and the reverse primer was designed, and it was given as a lyophilized form. With the designed primer and the extracted cDNA from the sample, we have standardized the temperature, annealing temperature, and it was standardized for almost 60 degrees Celsius. Keeping the GAPDH as a housekeeping gene, we have started with the PCR setup with a 96 well plate. Each well plate consists of cDNA 1 ml, primer 0.8 ml, probe 5 ml, and rock 0.2 ml, and 3 ml of nucleus-free water. And then 96 well plate was loaded in the real-time polymerase chain reaction machine. This was the amplification plot which we got. Coming to the result, we have found that OKC is expressed in higher level when compared to that of the control. Coming to the discussion, the CFOS plays a major role in the in a hypoxia, increased angiogenesis, so that increased amount of proliferation is there, and there is an increased methylation of the DNA and decreased apoptosis, and also increased activation of the osteoclast. They are stimulated by various stimuli such as cytokines, UV radiation, growth factor, tumor promoters, etc. Various previous studies have found that the underexpression or
We have 1 more
overexpression.
minute left.
Yes, ma'am. Overexpression and underexpression both are there. In some tumors, overexpression has created a problem, whereas in few tumors, underexpression of CFOS has created a problem. In our study, we have found that CFOS is overexpressed in OKC. The specific targeted therapy with the CFOS inhibitor can act synergetically and more effectively with the conventional enucleation. The limitation of the study is we have not found the actual role of expression. We have just found it is overexpressed. But what is the actual role? We have not found. Take home message is a rose is not a rose in case of OKC. So the recent advances, even though have found many genetical understandings, still many studies has to be encouraged to understand the molecular insight of the OKC. Thank you.
Thank you, ma'am. Over to you, Dr. Priya, ma'am.
Yeah. Basically, did you correlate clinically your expression values with
No,
any
ma'am.
clinical findings or clinical features?
No, ma'am. No, ma'am.
You've not done anything.
No, ma'am. We have not done anything clinically.
So you've
ma'am.
not come to an inference about the overexpression and OKC. You've not correlated with why it is, how it is.
No, ma'am.
Or the possible reason why all the samples showed overexpression?
No, ma'am. 2 of them has come undetermined, ma'am.
2 of them is okay. The remaining all have shown overexpression.
Yes, ma'am. Overexpressed, ma'am.
And did you do it in duplicates or you do it?
Duplicates, ma'am.
You've done it in duplicates.
Yes, ma'am.
Okay. Okay, fine. Did you try it in any other this one?
Yes, ma'am. In dentage resist, actual thing was normal oral mucosa, OKC, and dentage resist, ma'am. Among this, OKC has given the highest value. And next to that is the dentage resist. Next to is the normal oral mucosa, ma'am.
So you didn't compare it with oral mucosal tissues, this one, right? The expression of OKC and normal tissues, you have not compared.
We have compared, ma'am. When compared to the normal mucosa was taken as a control. When compared to that, it was overexpressed.
Okay, okay, fine. Yeah, fine. Yeah. Lakshmi, ma'am.
Yes, ma'am. How many samples did you take, doctor?
12 in normal oral mucosa and 12 in OKC, ma'am.
12 in OKC. Okay. So you're saying that it's also increased in dentage resist, right?
Yes, ma'am.
Okay. Was there a significant difference in OKC and dentage resist expression?
Yes, ma'am. Yes, ma'am. It was very significant, highly significant. 0.001 we have got. When compared to DC, OKC was expressed high, ma'am.
And when compared to normal mucosa, it was much more significant.
Yes, ma'am. Both are significant. DC is dentage resist and OKC both are highly significant when compared to normal oral mucosa.
Okay.
When intercomparing between the DC and OKC was high, ma'am.
Okay. So why did you choose CFOS?
Because it is the highest among all those June family and C family. The June B and the CFOS both are showing the highest chance for tumorigenesis, ma'am. So that I have chosen CFOS.
Okay, very good. Okay.
Yes,
Thank you, judges. Next is PG paper 4.
Can you see it?
Yeah.
I'm audible now?
Yes, ma'am.
Okay. Can I start?
Time starts now. Yeah.
A very good afternoon, one and all present here. I'm here to give my review on collagen 4, a biomarker in cancer progression. These are my content. Basement membrane, the molecular component of basement membrane includes collagen 4, lidogen, laminin, ectogen, and perlicane. About 50% of basement membrane contains collagen 4, whereas laminin is the most abundant non-collagenous glycoprotein in the membrane. Nitrogen accounts for 2 to 3%. Presence of collagen 4 was demonstrated by Pies and Nakani in 1967 and Lee et al. In 1969. Function of basement membrane, it acts as a barrier separating the epithelium from the surrounding stroma. The structure of basement membrane in defining tissue architecture, it regulates cell behavior and recurrent of signaling pathway is emerging. It defines the tumor microenvironment and provides significant host derivative regulatory signal during the progression of tumor growth and metastasis. Under specialized condition, it acts as a filter with selective permeability and substrate for cellular differentiation and gene expression in tissue. Collagen is the main structure protein in extracellular matrix found in our body. It consists of amino acids bound together to form the triple helix of elongated fiber known as collagen helix. There are 28 types of collagen been identified. There are 5 types of main collagen. Function of the collagen is they provide structural strength, support, shape, elasticity to the tissue. They provide flexibility, support, and movement to the cartilage. It protects organs like kidney and spleen. When exposed in damaged blood vessel, it initiates thrombus formation. Structure of collagen type 4 includes 6 genetically distinct alpha chain polypeptide from alpha 1 to alpha 6 that are encoded by collagen 4A1 and collagen 4A6 gene. Alpha chain is 400 nanometer long and it has 3 domains: a short and terminal non-collagenous 7S domain, a long middle triple helical collagenous domain, C-terminal globular non-collagenous domain. Collagen 4 is a heterotrimetic molecule. Collagen 4 in cancer progression, Ikeda and his colleagues demonstrated the effect of promoter hypermethylation on the expression level of collagen 4A5 and collagen 4A6 gene. They suggested that the hypermethylation leads to diminished level of alpha 5, alpha 6 collagen in cancer tissue. Normal production and assembly of basement membranes is disinterrupted in malignant progressions. At immunohistochemistry study was performed on colorectal cancer, tubular adenoma, and normal colonic mucosa using monoclinic specific antigens. They revealed here in these slides, the black arrow, blue arrow, and yellow arrow indicates the alpha 1, alpha 2, alpha 5, and alpha 6 expression. Whereas the red arrow indicates the expression of alpha 1 and alpha 2 in capillary basement membrane. In Q and R, we can see with yellow arrow, there is loss of expression of alpha 5 and alpha 6. RT-PCR of non-collagenous is performed of alpha 1, alpha 2, alpha 5, and alpha 6. 1 to 9, lane 1 to 9 indicates the colon cancer cell line. Here, alpha 5 and alpha 6 expression is lost. Genomic map of sequences between
we have 1 more minute left.
Collagen 4A5 and collagen 4A6 is seen in figure A. Vertical line and C number shows CGP sites. B indicates the methylene profile. C indicates the rate incidence of methylation is higher in RT-PCR negative colon cancer than positive. Methylation of CGP island of the promoter regions was identified as the epigenetic mechanism for the silencing of the multiple gene. In malignant tumor, hypermethylation of multiple gene was reported. Several studies are there for the role of collagen 4. M. Zargana demonstrated the role of type 4 collagen through immunohistochemistry. Harshvinder Kaur and Sneha concluded that the loss of collagen 4 with the progression of lesion. This is my conclusion. The expression of alpha 5 and alpha 6 gene are down regulated in cancer.
Ma'am, your time is up. Thank you, ma'am.
Just
now over to you, Dr. Priya, ma'am.
Yeah, could you give me the inference from your study in short?
Yes, ma'am. It is expressed that alpha 5 and alpha 6 chain are down regulated during cancer. Hypermethylation of promoter region is one of the events that is responsible for the loss of alpha 5 and alpha 6 chain. Remodeling of collagen 4 alpha chain is reported in invasive cancer.
Okay, now it is down regulated. That's what you're telling, right?
Yes, ma'am.
So what could you infer from that if this is down regulated?
Ma'am, it can be used as a diagnostic biomarker for the diagnosis of cancer.
Okay, but there are different grades of cancer, no? So can you come to an inference about this related to the grades of cancer? You want to diagnose cancer. How can you diagnose this?
Ma'am, by immunohistochemistry, they have stained.
Yeah, okay. Now, is there any variation between the different grades of cancer? You know that there are 3 grades of cancer, right? Well,
yes, ma'am, but
yeah,
by this we cannot.
Did you check in all the 3 grades?
Ma'am,
or you just took cancer? I mean, you just took as a general.
I am just reviewing this, ma'am.
Yeah, that's what did. Anywhere was it given?
No, ma'am, the grades was not mentioned.
They've just done it in just general oral cancer, right?
Yes, ma'am.
Okay, okay, fine. Yeah. Lakshmi, ma'am?
Yeah. So I think the cases you've mentioned here is more of colon tumors, right?
Yes, ma'am.
Oral lesions? I didn't see any oral lesion there in your review.
Yes, ma'am. In oral, ma'am, there are several researchers has been there. They have done in oral squamous cell carcinoma, varicose carcinoma, multicystic ameloblastoma.
I think that you could have highlighted more than the general things. So,
yes,
so is it always down-regulated, or are there some instances where it is upregulated?
No, ma'am. They are only down-regulated.
Down-regulated. Okay. So can we use it as a prognosis for diagnosing metastasis? Or can we diagnose a metastasis with that, with the expression of type 4? Or your
yes,
down-regulation?
Yes, ma'am, we can.
It was not mentioned anywhere, right?
Yeah, ma'am.
About the severity, like what Priya ma'am said, or the prognosis of the disease.
Yes, ma'am, that was not mentioned.
Okay. So can we use it for all those things?
Ma'am, I would check in.
Okay. Okay, good.
Okay, ma'am.
Thank you, judges. Next is PG paper 5. PG paper 5.
Hello, ma'am.
Yeah. Okay. You will be given 30 seconds for screen sharing.
Hello, ma'am.
Yes. Hello.
Hello. Can you see this?
Yeah. Yes, ma'am.
Okay.
The time starts now, ma'am.
Okay. Good afternoon, all. My presentation is about a case report on ameloblastoma calcifying odontogenic cyst associated with odondo. A 16-year-old male patient was presented to the department with the chief complaint of swelling in the upper left front tooth region of the jaw since 3 months. The swelling started gradually and increased to attain the present size. No history of associated pain, paresthesia, nasal stiffness, or epistaxis were
These are the preoperative view. Extraoral examination revealed a solitary swelling present on the upper left front tooth region, extending from ala of nose 4 centimeter in front of the tragus, measuring 3 into 2 centimeter in diameter, which was non-tender and bony hard in consistency. On intraoral examination, a bony hard swelling was present in the maxillary left buccal vestibule with obliteration in relation to 2.4, 2.5, 2.6 region. Palatally, the swelling extends from 2.4 to the distal aspect of 2.6, extending to approximately 1 centimeter distal to the midline, which is non-tender on palpation. Mucosa overlying the epithelium was normal. On vitality test revealed 2.3, 2.4, 2.5, 2.6 were non-vital, and 2.7 is clinically missing. Radiographic features. Pan view showed multilocular mixed radiolucent radio-opaque lesion on the left maxilla, extending from distal aspect of 2.3 to the posterior wall of maxilla. Towards the superior aspect, a radio opacity is seen in the apical region of 2.6, apically displaced to 2.7 and 2.8. In incision biopsy, we give the report as calcifying odontogenic cyst of left maxilla. Excisional biopsy, multiple grayish bits of tissue appears to be a part of cyst, and a single hard tissue bit along with extracted tooth submitted. Light microscopic view. Submitted section shows multiple bits of tissue. One bit showed tissue which is a part of cyst wall lined by ameloblastoma-like epithelium with a focal collection of ghost cells, some of which are undergoing calcification. Supporting connective tissue is fibrocellular, and few odontogenic epithelial islands and few ameloblastomatous follicles are also noted, with the peripheral tall columnar cells and central stellate reticulum-like areas surrounded by eosinophilic homogeneous area resembling dendrinoid. One follicle show ghost cell changes in the center. On Van Gieson staining, the ghost cells appeared as yellow and the dendrinoid appeared as pink in color, red in color. Decalcified section of the hard tissue submitted shows features of complex composite odontome. And on the basis of histopathological and special staining report, the final diagnosis was given as ameloblastomatous COC associated with the odontome. Coming to discussion, calcifying odontogenic cyst is an uncommon lesion that demonstrates considerable histological diversity and present variable clinical behavior. Some reports showed that calcifying odontogenic cyst often coexist with other odontogenic tumors such as ameloblastoma, ameloblastic fibroma, and ameloblastic fibroadenoma. Ameloblastomatous COC microscopically resemble unicystic ameloblastoma except for the ghost cells and calcification within the proliferative epithelium, along with the intraluminal and intramural ameloblastomatous proliferations. The ameloblastoma-like proliferation typically lack Vickers and Gorling's criteria of ameloblastoma-like cells. Ameloblastoma ex-COC designate an ameloblastoma arising from the cystic lining epithelium of COC. The ameloblastoma ex-COC shows ameloblastomatic proliferation within the cyst wall without ghost cell and calcifications. VNG criteria for ameloblastoma-like cells can be easily identified. Okay. Coming to conclusion, ameloblastomatous COC is a rare variant. There are very few cases reported with this variety of calcifying odontogenic cyst in the literature. As a conservative treatment in the form of enucleation have been proven to be effective, it need to be differentiated from ameloblastoma ex-COC since it require more aggressive form of treatment. Careful post-operative observations are necessary for calcifying odontogenic cysts which are associated with the ameloblastoma. These are my reference. Thank you.
Thank you, ma'am. Over to you, Dr. Priya, ma'am.
Yeah. How do you distinguish this from your dendrinogenic ghost cell tumor?
Now, calcifying odontogenic cyst is a cystic type of lesion. A dendrinogenic ghost cell is a solid one.
Okay, and histopathology, what do you think would be the differences between the two? Because you had dendrinoid material in yours, right?
Yes, ma'am.
Yeah. So histologically, how will you differentiate between the two?
Histologically, in dendrinogenic ghost cell tumor, more amount of dendrinoid production can be seen.
Okay. Then anything else? which will tell you that that is dendrinoid and this is what was the age of the patient here?
16-year-old.
16-year-old. Oh,
Yes, ma'am.
yeah. Okay, fine. Yeah. Lakshmi, ma'am.
Oh, any other differential diagnosis you had in your mind?
Sorry, ma'am.
Any other differential diagnosis you had in your mind? Because you see a lot of areas in your slide, right? Like, one area you showed a follicle, right? Ameloblastomatous follicle.
Yes,
And you can see an induction phenomena around it, right?
Yes, ma'am.
So did you have any other different diagnosis in mind?
Because of the, we already noted the ghost cells and calcifications in the
If you hadn't seen, what would you have diagnosed?
ameloblastoma.
With an induction phenomena? It was a very nice picture, actually. What you showed in histopathology, you showed a follicle with that induction phenomena, right?
Yes, ma'am.
So anything else you can add on that? So basically, you saw the cystic area and the ghost cell, right?
Yes, ma'am.
That's why you thought it's a COC ameloblastomatous, right?
Yes.
Okay. How was the basal layer in the cystic layer?
It was tall columnar cells, but it failed to satisfy the VNG criteria.
Okay. So there's no reversal of polarity.
Yes.
Okay.
So thank you, judges.
Thank you.
Now it is species paper 06. Will be given 30 seconds for screen sharing.
Is my screen visible? Hello.
No, ma'am. No.
My screen is visible?
Yeah. Yes, ma'am.
Okay. May I start the presentation?
Yeah.
Okay. Good afternoon, everyone. The title of my presentation is Evaluation of Serum Levels of Chemarin in Oral Potentially Malignant Disorders and Oral Squamous Cell Carcinoma using QRT-PCR. So this is the basic outline of my presentation. So to begin with, cancer is the second leading cause of death globally, according for an estimated 9.6 deaths annually. India has the largest number of oral cancer cases and 1/3 of the total burden of the cancer globally. The process of malignant transformation from OPMD to OSCC is complex, and angiogenesis being one of the most important events. Thus, assessment of pro-angiogenic factors such as chemarin might be useful for detection of the early malignant changes in the oral cavity. Chemarin, it is a novel adipokine which is proved to be elevated in numerous solid tumors. Biopsy is invasive, time-consuming, and difficult to maneuver in patients with reduced mouth opening, like in cases of oral submucous fibrosis, which is one of the overriding oral potentially malignant disorders. Minimal invasive alternatives such as serums can be used for sampling in order to detect the biomarkers, which help in early diagnosis of OPMDs and block further progression into cancer. So that brings to the objective of my studies. First is to determine the serum levels of chemarin in subjects with normal oral mucosa, OPMD, and OSCC, and to compare the serum levels of chemarin in all the above groups. So this is an ex-vivo prospective case control study with 12 subjects in each of the said subjects. So this is the basic outline of the methodology. So let's begin with the sample collection. First, 5 ml of peripheral blood was collected, and then the serum was isolated, and 1 ml of triazole reagent was added, and the samples were stored in -80°C freezer until assayed. Later, all of the samples were taken out, were thawed on ice, and then 200 microliter of chloroform was added, and then vortexing was done. Later, the phase separation started after vortexing, and when it was spun down, we could see that there were 3 distinct layers formed, and the above layer that we see over here, the clear layer, the aqueous phase, is the RNA. This was taken to a new tube, and then we'll add isopropyl alcohol, which will cause precipitation of the RNA, and then it will give a RNA pellet at the bottom after spinning it down. This RNA later will be reconstituted in nucleus-free water, and reconstitution will be done. And this RNA will be later quantified using a nanodrop spectrophotometer. The RNA that we have extracted is not stable. It has to be converted into a more stable cDNA, that is complementary DNA. It will be reverse transcribed. So this is the final cDNA that we have obtained. Later, the primers were taken from the local vendors for Camerin and GAPDH. Camerin is the gene of rest of us, and GAPDH is a housekeeping gene. Later, setting up of qPCR plate was done. The 96 well plate contained, each of the well contained 10 microliter of the solution. In that 10 microliter, first was cDNA that we have extracted, the 2 ml, and then 1 microliter of the primer and 5 microliter of fiber grain, which will give the fluorescence. And to this, nucleus-free water was added to make the solution up to 10 microliter. And then the qPCR was set up. And then this is the amplification plot that we obtained. We'll get a CP value, and based on that, we'll take out all the formulas and will finally be yielding the fold increase. And this was the result from the normal, which will be 1, which will always be 1. OPMD showed that it was 6.59 times more than normal, and in OSCC it was 12.21 times more than normal. So statistical analysis was done, and statistically significant value of 0.0003023 was obtained. So coming to the discussion, a handful of studies have been done which have showed that Camerin in fact is increased in case of OSA diagnostic markers. And one of the studies compared the pre and post-operative levels of Camerin. So indeed, Camerin can also be used as a prognostic marker. Coming to the conclusion, most OSCCs are not diagnosed until an advanced stage. Early oral cancer detection is imperative. Yeah, thank you. So the last thing that I would like to add, that suppression of Camerin can also be beneficial in suppressing the tumor spread. So all in all, Camerin can be used as a diagnostic marker, prognostic marker, and also as a targeted therapy marker. So the current study paves way for further clinical studies, and large multi-institutional studies have to be done OSCC in order to increase the survival rate and quality of life for the OSCC patients. These are my references.
Thank you, ma'am. Now over to you, Dr. Priya, ma'am.
You had actually you had mentioned that it is can be used as a target, right? So directly this chimerin can be targeted or what? Or you need something in between to target it?
No, ma'am. This can only be, it is an adipokine basically. It will have role in angiogenesis. It will activate VEGF, which has role in neoangiogenesis. So Camerin can only be like that, only can be targeted.
And also you mentioned that it is a prognostic marker, right? So again, have you tried it in different grades of potentially malignant disorder and in SEC?
Actually,
what kind of cases did you take in SEC? General or again different grades have you taken?
I have taken differently, but that was not my criteria. Like I had taken differently, but in my study that I have not done.
Because whenever we give a diagnosis, we give it as either well, moderate, or poor, right?
Yes,
so
most of the cases that I got were well differentiated only.
So you have included well only. Is that what? That is my question. Or you have mixed up both well and moderate. Hello. Yeah.
5 or 6 were well differentiated, ma'am, and around 2 or 3 were poorly differentiated, which showed high increase of chemistry.
Oh, so as the grade is increasing, it is supposed to be going high. It will have a high expression.
Yes, ma'am. It will have a higher expression.
Okay. And you've done it in duplicates only, no? Your PCR?
Yes, ma'am. Duplicates.
Okay. Okay. Fine. Yeah. Fine.
So how many samples were there? Basically your squamous cell carcinoma and pre-malignant?
12 samples of OSCC and 12 samples of pre-malignant.
Malignant. And you compared with normal mucosa.
Yes.
Okay. So how was it statistically? Was it statistically significant or?
It was significant, ma'am. As the like in normal patients also we'll see Camerin, but as the progression increases from pre-malignant to malignant, the expression goes on increasing.
It is higher. Okay. So only 3 cases were poorly differentiated, right?
Yes, ma'am. Only 3 cases.
Out of the 12.
Yes, ma'am.
Okay. So you think that can be used as a biomarker?
Yes, ma'am. It can be used.
Okay. So anything regarding metastasis or how the prognosis is regarding your Camerin activity?
Like it shows that one of the study with tissue they have done pre and post operatively they selected, and post operatively like after the surgery they told that Camerin levels decreased. So after the surgery,
Yeah, after the surgery, after the tumor is removed, the levels are decreased. Okay. Okay.
Thank you, ma'am. Those who are presenting, please switch on your camera. So next is PG paper 7. You will be given 30 seconds for screen sharing.
Good afternoon to all. I'm here to present a case on clear cell variant of mucoepidermoid carcinoma, a diagnostic intricacy. A 22-year-old female patient reported at the department with a painless swelling on the left side of the palate. And the history of presenting illness, the fluid aspiration was done 7 years back, but the records were not available. On clinical examination, a soft tissue swelling of 3.5 into 2 centimeter was present on left posterior hard palate region, palatal to 26, 27, and 28. Surface erythema and ulceration was present. It was non-tendron palpation and no discharge was seen. CBCT showed well-defined soft tissue swelling with approximate dimensions 23.8 into 16.2 buccopalatal into 12.3 millimeters superior inferior, noted in relation to left maxilla palatal to 25, 26, 27, 28. Pressure resorption was noted on the palatal aspect of T 26, 27. Ultrasound examination showed mixed acoustic lesion with acoustic enhancement. Multiple discrete hyperechoic foci was noted within the lesion. FNAC showed numerous round to ovoid cells with abundant eosinophilic cytoplasm with basophilic nuclei resembling epidermoid cells, mixed inflammatory cells, few desquamated epithelial cells, and RBC. A provisional diagnosis of minor salivary gland neoplasm was given. An excision biopsy was done, and the gross appearance is as shown here. Now, microscopy. Histopathologic examination showed tissue composed of proliferating tumor cells arranged as sheets and islands. Most of the tumor cells are round to ovoid cells with clear cytoplasm and eccentrically placed vesicular nuclei. Occasionally, some cells are round to ovoid with peripherally placed flat nucleus resembling mucus cells. At one area, cells appears polygonal with abundant eosinophilic cytoplasm and centrally placed basophilic nucleus resembling epidermoid cells. Cuboidal cells with basophilic nucleus and thin rim of eosinophilic cytoplasm were also present. They represent the intermediate cells. Tumor cells showed nuclear atypia, vesicular nuclei, prominent nucleoli, and areas of necrosis. Large cystic areas lined by clear cells, some of which contains homogeneous eosinophilic material resembling mucin, were also seen. A special staining of pH staining and mucicarmine was done, which showed only focal positivity. Final diagnosis of high-grade mucoepidermoid carcinoma, clear cell variant, was given. Discussion. Mucoepidermoid carcinoma is a malignant epithelial tumor of salivary gland. It comprises 5 to 10% of all salivary gland tumors. It is classified into low, intermediate, and high grade based on morphologic and cytologic features. When clear cells predominate, it is called clear cell variant, and in such cases, it need to be differentiated from other clear cell tumors like epithelial myoepithelial carcinoma, clear cell oncocytoma, myoepithelioma, myoepithelial carcinoma, hyalinizing clear cell carcinoma, and metastatic renal cell carcinoma. The identification of the three cell populations, the epidermoid, intermediate, and the mucus cells, is the key to the diagnosis of mucoepidermoid carcinoma. The grading criteria is as shown below. The clear cells, the origin is still not very clear. It may be due to the presence of mucin or glycogen or spas organelles or fixation artifact. Hydrophic degeneration of epidermoid cells may also cause clearing. Although clear cells do not affect the grading of mucoepidermoid carcinoma, it has been noted that clear cells usually predominate in high-grade tumors. Also, it is seen that mucoepidermoid carcinoma will show relatively poor differentiation or high malignancy if the source of the clear cells is squamous cells. Since in the present case, the clear cells are mucin and glycogen negative, origin may be from epidermoid cells, and hence this case can be categorized as
high-grade mucoepidermoid carcinoma of clear cell variant. These are my references. Thank you.
Thank you, ma'am. Over to you, Dr. Priya, ma'am.
Now you have considered this based only on clear cells. How have you put it as high-grade mucoepidermoid carcinoma? Just based on,
not only that, there was only very few cystic spaces were present, and necrosis were present, and cellular.
But in one of the photos that you showed, I think that had quite few cystic spaces, right?
There were the only cystic spaces.
That
present.
was the only area which showed
only
cystic spaces.
areas showing.
And were they lined by mucus cells, those cystic spaces?
When we did PS and mucicarmin, those cells did not exist. So they were probably no mucus cells. Only focal positivity was shown.
And any other features which you could take into consideration to call it as high grade, not other than this clear cell variant?
Because the origin of the clear cells is something that we have to look into. The clear cells, if they had shown PS and mucicarmin positivity, then we could think that they were actually
could be mucus,
mucus cells converting. In that case, it will be low grade. But that is not the case here. Then another case of clearing us by the squamous cells undergoing hydrophic degeneration. In that case, all those cells are actually epidermoid cells which have undergone clearing. So it has to be considered as a high grade.
And did you come across mitotic figures and all, and intermediate cells in your slide?
Intermediate cells were there, but few. But
what
mitotic figures also few. But nuclear cellular pleomorphism was very obvious.
Okay, fine. Yeah.
Okay. So in your slide, you had more of epidermoid cells, less of cystic and less of intermediate.
More of epidermoid cells, less of epidermoid cells.
Okay. So can we do something else to find the origin of these cells, clear cells? You said that it was negative for PAS and glycogen. Okay.
Yes.
And how did you arrive at the
we can do CK5 or 6 like that. So we can definitely
possible,
know this
right?
one. That will be positive.
So it can be much more accurate, right?
Yes, we can give an accurate.
Anyway, it's a nice case. So how was the prognosis? How was the sinus that involved? The maxillary sinus?
Not involved, but there was a pressure resorption of the near the palatal roots, in the palatal part inside.
Okay, good.
That's a recent case, so we have to still follow up. So we don't know. Thank you.
Thank you, ma'am. Next is PG paper 8.
Yes, ma'am.
You got 30 seconds for screen sharing.
Ma'am, is it visible?
Yes.
Yeah. Can I start, ma'am?
Yes, you're done, start.
Good afternoon, everyone. Today my topic is on the review on extracellular matrix development and progression of tumor. Let's start with the definition. It is a network of extracellular macromolecules such as enzymes and glycoproteins that provide structural and biochemical support to surrounding cells. Components of extracellular matrix are proteins and water mainly. In proteins, fibrous structure protein, collagen, elastin, and fibrillin, water-hydrated gels, which includes proteoglycans and hyaluronan, adhesive glycoproteins and receptors, which includes fibronectin, laminin, and integrin. Now, the functions of extracellular matrix: differentiation and growth, morphogenesis, response to injury and trauma, structural modification, angiogenesis, survival and migration, damaged tissue remodeling. Now we will see how extracellular matrix and tumor are related to each other. The extracellular matrix represents one promising avenue of research in cancer therapy. The extracellular matrix is critical part of tumor microenvironment. Tumor cells both produce extracellular matrix protein themselves as well as induce surrounding cells to alter their own extracellular matrix production. Moreover, the extracellular localization of ECM makes it well suited for use in imaging and targeting because it is accessible to probes without the need to cross the cell membrane. Now we will see how it helps in tumor progression. Single tumor cells or group of tumor cells dissociate from primary tumor, invade into surrounding extracellular matrix, densely aligned collagen fibers act for track of proliferation of neoplastic cells, enter the vascular and lymphatic space, penetrate target tissue. These metastatically competent cells are responsible for clonal dominance even at distant metastatic foci. This is the schematic representation where there will be attachment of detachment from the cells, then there will be collagen migration and enter the vascular system, and metastasis will be there. Recent studies showing ECM expression in tumor. Ebel and Inland showed that cancer cells frequently have altered production of ECM proteins. Sahai et al. Showed that proliferation activation of fibroblasts to cancer-associated fibroblasts. Hobbs et al. Studied that the mouse xenograft host demonstrated that tumor cells produced most of the ECM modulating enzymes. Cell adhesion and cell invasion in malignancy is through number of specific cell surface associated molecules which mediate cell to extracellular matrix and intracellular interactions. This includes first integrin. They are cell surface receptors and it is increased in malignant melanoma. Studies also show that its receptor is present in oral squamous cell carcinoma. Second is laminin. It is a basement membrane glycoprotein. Studies show that it's increased in epithelial hypoplasia and in oral squamous cell carcinoma. Cadherin, it is homophilic cell adhesion proteins. These are of two types, E-cadherin and N-cadherin, which will be increased in oral squamous cell carcinoma. CD44, it is a transmembrane glycoprotein. Its presence will determine the grade, stage, and presence of metastasis and survival in carcinoma, such as non-Hodgkin lymphoma. Collagen, type 1 collagen is present in malignant transformation of epithelial cells in well-differentiated oral squamous cell carcinoma. Type 4 collagen increased expression may lead to nodal metastasis and increased in oral squamous cell carcinoma. Type 7 promote cell adhesion, migration, and differentiation. Fibronectin and tenascin, they are glycoproteins. They cause proliferation and migration of tumor. And studies show that their level will be changes in well-differentiated oral squamous cell carcinoma. These are my references, and thank you.
Thank you, ma'am. Now over to you, Dr. Priya, ma'am.
Yeah. Could you just can you conclude from what are the relevant points of your review?
Yes,
just in short, yeah, what is the importance of ECM in various cancers? Or in short, can you conclude?
Ma'am, ECM level will be increased, such as integrin and cadherin, CD44, collagen, and fibronectin. This all will in this ECM level will be increased, but laminin will be decreased in oral squamous cell carcinoma. So we can use it as a biomarker for detecting the oral squamous cell carcinoma, and it also helps in grading the oral squamous cell carcinoma.
Yeah, you would have taken a few studies into consideration, right? So were they all IHC studies or did you include anything else?
Ma'am, somewhere immunohistochemistry study, and once for fibronectin used PAS stain for studying.
Oh, you have taken special stains into consideration. PAS, PAS, For fibronectin.
Yes, ma'am.
How were they able to distinguish fibronectin in PAS?
Ma'am, highly stained eosinophilic.
In which cases did they take?
Sorry?
In which cases? Was this done in normal or in some diseases?
No, ma'am. It will be highly stained in oral squamous cell carcinoma.
Okay. Okay. Yeah, fine.
Now over to you, Dr. Lakshmi.
So, in a nutshell, conclude your presentation.
Ma'am, ECM will help in determining the progress and behavior of the tumor. It will also help in determining the grade of the tumor, such as oral squamous cell carcinoma, and it also help in diagnosis of non-Hodgkin lymphoma.
I mean, like what ma'am said, you could have streamlined a little bit more or taken some studies and presented, okay? That could have been much better actually.
Okay, ma'am.
Okay, next time I think you should do that, okay? Much more streamlined presentation. This is more elaborate and so you can take some studies or put some articles and then explain it, okay?
Ma'am, I have, okay.
You have put references, I know.
No, I have included in integrin, laminin, and cadherin. All the studies I have written on that.
Okay. Okay, so you're saying PAS staining is more in?
Fibronectin and tenascins in oral squamous cell carcinoma.
Thank you, judges. Next is PG paper 9. PG paper 9, please confirm. PG paper 9. Okay, so next is PG paper 10.
Ma'am, can I share my screen, ma'am?
Yes, yes.
Can I start, ma'am?
Yes, ma'am.
Good afternoon to one and all. Today my presentation topic is prognostic impact of lymph node micrometastasis in oral squamous cell carcinoma. Explore the unseen. Oral cancer is a major problem in the Indian subcontinent. Globally, oral cancer is the sixth most common type of cancer, with India contributing to almost 1/3 of the total burden. Oral squamous cell carcinoma has high tendency for regional and distant metastasis and thus remains one of the most difficult malignancies to control. Cervical lymph node metastasis will carry the poor prognostic factor for patients with OSCC. Approximately 10% of recurrent cases histologically diagnosed as non-metastatic suggest that these tumor cells were undetected in the resected node. In this schematic diagram, we can see the architectural changes in the pre-metastatic metastatic lymph nodes. In case of benign lymph node, the lymph node architecture are normal and the fatty hilum we can see. And in case of pre-metastatic lymph node, we can see the lymph node architecture become round, enlarging, and the cortexes become irregular. And the metastatic lymph node, we can see the fatty hilum is diminishing, and the cortex architecture is totally thickened, irregular, and the lymphovascular remodeling occurs around the hilum. And coming to the metastasis, spread of tumor by invasion in such way that discontinuous secondary tumor mass or masses are formed at the site of lodgement. And approximately 30% of the newly diagnosed patients with clinically evident metastasis and 20% have occult metastasis. And now coming to the micrometastasis, occult metastasis occurs in two forms, which could be either micrometastasis or individual tumor cells. And risk of micrometastasis is high for cancers of oral cavity, oropharynx, and hypopharynx, and supraglottis. Single island of micrometastasis has the potential to seriously affect the recurrence and survival for the patient. And now coming to the now treatment modalities, such as traditional treatment modalities such as clinical assessment, many sophisticated imaging procedure, even the routine histopathology examination by H&E stain section, unable to detect micrometastasis. So the aim of our study to evaluate the micrometastasis and individual tumor cells in regional lymph nodes of oral squamous cell carcinoma by immunohistochemical marker, and we evaluate the tumor staging. An objective histopathological evaluation with H&E stain and histopathologic evaluation with the modified PAP stain, and compare those two results with the ISC marker PAN-CK. And we took 40 known negative lymph node sections, and we analyzed the result by using H&E, hematoxylin eosin, PAP stain, and immunohistochemical marker pan-cytokeratin. And before coming to the result, I want to show that the normal histology of the lymph node. It is in PAP stain section, we can see the perinodal fat and the germinal centers of the lymph node. In this photomicrograph, we can able to identify the tumor keratin pulse. Now coming to the result, in this section, in this photomicrograph of the H&E stain section, it is very difficult to detect the small tumor islands. Even an oral pathologist unable to detect these small tumor islands with the help of H&E. In this PAP stain section, we can easily identify those tumor islands. And if we see the H&E stain section of the photomicrograph, it is very difficult to identify the tumor islands in H&E section, but in PAP stain section we can easily identify. But many times that many micrometastatic deposits we can't able to identify with PAP stain also. So our study, we conducting the study to detect the occult micrometastasis with the help of this ISC immunohistochemical marker PAN-CK. Here we can identify the small tumor islands, and here in this photomicrograph we are able to detect the small tumor islands with the help of ISC stain, which are definitely missed out in the H&E and PAN and PAP stain also. So coming to the discussion, micrometastasis may go undetected in routine H&E stain section in around 21 cases, leads to recurrence, incorrect staging, affecting the prognosis. Therefore, there is a need to identify.
You have one more minute left.
The sensitive technique overcome the limitation of conventional H&E, able to detect occult micrometastasis, improve prognosis of the patient. And PAN-CK conclusion, PAN-CK has proven to the efficient in upstaging the primary tumor and thus affects the treatment and prognosis of patients with OSCC. This technique is justified for improved diagnosis and treatment planning for N0 OSCC patients. These are all my references. Thank you.
Thank you, ma'am. Over to you, Dr. Priya, ma'am.
Now, did you check for what was the analysis done for the 3 stains? How did you come to, how was your inference from the 3 stains?
Ma'am, we took 40 negative lymph node samples of OSCC patient, and in this sample where the PAP stain, we compare the H&E and PAP stain. And where in this PAP stain, we identify that there is no metastatic deposit. But if we compare, when we compare the PAP and ISC, then we can detect that micro 1 tumor islands are present in this.
Were you able to get more? Were you able to identify more islands with PAP than hematoxylin eosin? That's what you were trying to tell.
Yes, ma'am. We can't identify the small tumor, and those 6 samples we got positive, where we can't detect the tumor islands with the help of the H&E and PAP.
And PAP, you could identify the same?
No,
both you can't identify.
No, PAP we can't identify, but with the help of ISC, we can identify that the small tumor islands is present there.
Okay. So did you do any analysis for this, or you just, it is more of a descriptive study that you've done?
Ma'am, analysis, we did that it can affect the staging, and treatment planning may be altered after detection of the micrometastasis.
Okay, fine. Yeah, if you see micrometastasis, obviously the treatment plan will be altered. How many cases did you do for this staining?
I took, ma'am, 40 samples, lymph node samples. And from there, we got only 6 samples positive in the ISC cases.
Okay, now was this missed in histopath diagnosis?
Missed in, ma'am, PAP stain and H&E.
No. This actually, you had done the study, right? No, in normal report when they had given it, was this micrometastasis missed, or Was this added to the report? That's what I wanted to ask.
No, ma'am, it was not there in the report.
Okay, because you would have taken the archival tissue and done the study,
Yes,
right?
yes, ma'am. Yes,
Yeah, that is why I asked. So was it mentioned in the report? Have they missed it in the report?
Yes.
Okay, okay, fine. Yeah. Lakshmi ma'am.
So what period were these cases, these 40 cases you said, right?
Yes,
It is negative lymph nodes, right?
Yes, ma'am.
Okay. What was the period that you, the cases, what was the period of time?
Ma'am, we took archival collections since 2 years.
2 years. So you had the clinical data also?
No, ma'am. We have the biopsy report only.
Biopsy report, okay. So was there a correlation between the grade of the carcinoma and this, what you identified in your study with your IHC or PAP or whatever it is?
No, ma'am.
Was there a correlation between, you had the details of the diagnosis, right? All these 40 cases? So
Yes,
all of them were all of them took up a stain in the CK? Like all those 40 cases turned to be positive?
And only 6 cases we got positive, ma'am.
6 cases only?
Positive.
Positive, okay. Out of the 40, you got 6 as positive.
Only 6 are positive we got.
The other 34, it was supported by the original diagnosis.
Yes, ma'am.
It was negative.
Negative only.
Okay. So out of 40, you got 6 a different diagnosis.
Okay. Yes, ma'am.
Okay. Okay, fine.
Is this speech paper 9? Speech paper 9, please confirm.
It is 10.
Okay, page paper 10. This is page paper 10.
Yeah, now maybe paper 10, right?
Okay, last time presentation was page paper 9.
Yeah.
Okay. Ma'am, judges, it was page paper 9. Last presentation was page paper 9. Now it's page paper 10. Will be given 30 seconds for screen sharing.
Is my screen visible?
Sorry, ma'am.
Is my screen visible?
Yeah, ma'am.
Yeah, should we start?
Yeah.
Okay. The topic of today's presentation is an exploding mass of the mandible, a rare case presentation. So we had a 27-year-old female who complained of pain in her lower right back tooth, which was present since 2 months. Her medical, dental, and personal history were non-contributory. The pain was eventually subsided by a pea-sized swelling, which grew to the present size in just 15 to 20 days. So this was the history of presenting illness. On extraoral examination, we saw a gross facial asymmetry. There was a diffuse swelling in her lower right side of face, which measured approximately 6 into 4 centimeters. And the skin over the swelling appeared normal, and there were no secondary changes present. On palpation, the swelling was tender and there was no rise in temperature. It was firm to hard in consistency and there was no discharge that was present. Her lymph nodes were also not palpable. Coming to the intraoral examination, there was a diffuse swelling noted in the right side of the floor of the mouth involving both the gingivobuccal and the gingivolingual sulcus, measuring approximately 4 into 2 centimeters. And also the overlying mucosa appeared quite erythematous, which was even bleeding on palpation and was tender as well. The swelling was firm to hard in consistency and grade 1 mobility was associated with all the teeth on that side of the arch. Coming to the radiographic examination, we could only see a widened periodontal ligament space and loss of lamina dura associated with 4-6. And on occlusal view, we could see a soft tissue shadow in relation to the lingual aspect of 4-4 to 4-7. The CBCT revealed that there was a perforation of the buccal cortical plate and also there was blurring of trabeculae that were noted. So we came to these of the differential diagnoses we had to include based on the clinical and radiographic examination. So the first one was ameloblastoma, aggressive ossifying fibroma, ameloblastic carcinoma, squamous cell carcinoma, fibrosarcoma, and osteosarcoma.
Basically, these were based on the history on the radiographic examination. We also did few of the general tests like the complete blood count, the urine analysis, and also BT-CT along with HCV and HBS antigen. None of them were very significant and were well within the normal ranges. Then the incisional biopsy was taken from the lingual aspect of 4-6. So we received one soft tissue bit approximately 2 into 1.5 centimeter in its dimension. And then when we checked it under the microscope, under the 4X, we could see a stretched parakeratinized stratified squamous epithelium, and the underlying connective tissue showed sheets of cells which were arranged in a lobular pattern. Then when we went on a higher power, we could see that there were these fibrocollagenous septa, which were dividing the myxoid connective tissue stroma into well-defined lobules. In the lobules, in the center of the lobules, we could see round to polygonal shaped cells, whereas in the periphery, we could see spindling of cells that was noted. On higher power, in the round of the polygonal shaped cells that we could see numerous binucleated cells. We could see numerous mitotic figures. Few were atypical as well. The mitotic figures were like 3 to 4 per 10 high power fields, along with numerous pleomorphic cells and desired nuclei. There was also increased nuclear cytoplasmic ratio within the spindle cell population. So at other areas, we could see this cartilaginous matrix deposition with lacunae containing chondrocytes in them. This was present well surrounded by these sheets of chondrocytes. Along with that, we could see atypical chondrocytes which were located within the cartilaginous matrix. So we came to the histopathological differential diagnosis of chondroid osteosarcoma, chondroma, and chondrosarcoma. Chondroid osteosarcoma was ruled out as we could not see any amount of bony trabeculae or the lace-like pattern that we classically see in osteosarcoma. So chondroid osteosarcoma was ruled out. Chondroma had to be ruled out because there were a lot of atypical mitotic figures. There were pleomorphic and desired nucleus, and the history was more towards a malignant lesion. Finally, we came to a diagnosis of chondrosarcoma. The next job was to grade the chondrosarcoma. Hence, a Ki-67 was done, which showed 10%.
We have 1 more minute left.
So grade 1 chondrosarcoma was the final diagnosis that we had given. Now coming to the discussion, chondrosarcoma is a malignant tumor with pure hyaline cartilage differentiation. Approximately accounts for 20% of the malignant bone tumors. In maxillofacial region, they account for 1 to 3% of chondrosarcomas. In the head and neck region, the age range is 35 to 45 years and more commonly seen in males. Maxilla is more commonly affected than the mandible in the ratio of 1.75:1. The mucosa is often intact and it is an expanding lesion which is frequently painless. Radiographically, it is very non-specific and it gives a poorly defined border and cortical expansion is noted. And coming to the histopathology, it is very cellular and with pleomorphic and hyperchromatic chondrocytes will have mostly multiple nuclei, and it will contain a hyaline type of cartilage with lacunae containing round to oval cells with enlarged nucleus and chromatin. Cells may be enlarged, may be arranged in clusters or large sheets. There may be many binucleated cells and they also may contain areas of calcification. There are these 3 histological variants of chondrosarcoma: clear cell chondrosarcoma, mesenchymal chondrosarcoma, and differentiated chondrosarcoma. Okay. Our case was that of conventional chondrosarcoma. So it is a radio-resistant tumor and surgical treatment is the mainstay.
Thank you, ma'am.
Yeah.
Thank you, ma'am. Over to you, Dr. Priya, ma'am.
Yeah. Could you tell me the comparison between your case and those reported in literature? Is there any differences between that in literature and your case?
Yes, ma'am. Our case did not show a very classic pattern of the cartilage, that hyalinized appearance or that hematoxyphilic appearance. So that was a little confusing for us to come to a diagnosis that these are chondrocytes and these are chondroid matrix. But finally, we searched, then we could see few correlations with chondrosarcomas, and also we had taken multiple opinions from the general pathologist also, who confirmed that these are chondrosarcoma cases.
Okay, and clinically, did you find any difference between reported cases and yours?
No, ma'am. Clinically, the classic
Site or age group or anything like that?
Age group, yes, ma'am. Earlier, we could see this patient had about 27-year-old female, while the age group reported is 50 years approximately. But the common location was in the mandible is posterior region only. So that.
And what about yours? What about your case?
Ours was also in the posterior mandible, ma'am. So that was correlating with the case report that we had seen.
Okay, it is posterior mandible, and radiographically you could not find anything, right? Except in the
periodontal widening. Only that was seen, ma'am. Radiographically, it is not specific, ma'am. Whatever cases we have seen also, we couldn't see, like the reported literature also doesn't have any specific features. This is the only thing given there, ma'am.
Okay, fine. Yeah. Ma'am?
What was the duration of the lesion?
Ma'am, the swelling, the growth was from 15 to 20 days, ma'am, whereas the pain was present for 2 months. Before that, she didn't have any swelling or any other complaint.
Okay. And you said that how was the mitotic rate in the slide?
3 to 4 per 10 high power fields, ma'am.
Okay, and your Ka67 was low.
10% positive, yes, ma'am. So we gave a diagnosis of grade 1.
So you gave it as a low grade.
Yes, ma'am.
Okay, fine.
Thank you.
Okay, thank you, ma'am. Thank you, judges. Dr. Priya, ma'am, thank you so much, and kindly receive the certificates as our token of appreciation. Thank you all. Now we are winding up the section.
Yeah, thank you.
Thank you so much.
Thank you.
Penicillin. Good evening, everyone. Please confirm PG paper 31. Please raise your hand. So please confirm PG paper 31. PG paper 31. Okay. PG paper 32. PG paper 32. PG paper 33.
Yes, ma'am. 32.
Okay. PG paper 32. PG paper 33. Please confirm PG paper 33. PG paper 34. PG paper 34. PG paper 35. PG paper 35. PG paper 36.
36, I'm there, ma'am.
Okay, fine. PG paper 37. PG paper 37. PG paper 38.
38, I'm there, ma'am.
Okay. PG paper 39. PG paper 39. PG paper 40.
40, I'm there, ma'am.
Okay, fine. Good evening, everyone. Pushpagiri College of General Sciences is delighted to host Kerala State's 5th Annual O Conclave. Let's start the scientific presentation under Department of Oral and Maxillofacial Pathology, starting with postgraduates paper presentation. Now, going on to session 4, hall 1, we invite judges for our session. It is my privilege to invite Dr. Shahnaz Mehboob and Dr. Sanjit Sudhagar. Dr. Shahnaz Mehboob, Assistant Professor, Department of Oral and Maxillofacial Pathology, PSM College of Dental Sciences, Thrissur. Dr. Sanjit Sudhagar, Assistant Professor, Department of Oral and Maxillofacial Pathology, PMS College of Dental Sciences and Research, Toronto. We welcome you all. Okay, so now let us proceed to the instruction. For paper presentation, you have 5 minutes. You will be given 30 seconds for the screen share before presentation. And if your time exceeds more than 30 seconds, next candidate will be called off and you will be given a chance at the end. You will be given a warning at the 4th minute, preceded by a final warning at the 5th minute. I hope the instructions are clear. Now, let's start the session. I would like to call PG paper 31. You will be given 30 seconds for screen sharing. PG paper 31. 31. Okay. Now you move on to PG paper 2, 32. PG paper 32, 30 seconds for screen sharing.
Hello, is screen visible?
Ma'am, your time starts now.
Hello.
Yeah, ma'am, your time starts now.
Good afternoon. Good afternoon, everyone. Good evening, everyone. So topic for the today's presentation is awareness amongst the nursing students and the staff about the ill effects of the tobacco on oral cavity. We all know the different forms of the tobacco, that is the smoked and the smokeless form. And we all know about the various effects of the tobacco on the oral health along with our body. So these are the effects of the tobacco: precancerous lesions and the cancerous lesion. So in India, the oral cancer contributes to the 1/3 of the total burden of the oral cancer of the world, and 49% of the cancer is because of the tobacco. So aims and the objective of the study are to study and evaluate the awareness about ill effects of tobacco in oral cavity, and to assess their awareness about oral pre-cancer and cancer in the different screening methods. But why nurses? Why in nursing students and staff? Because an oral health checkup admission to hospital provides an opportunity for the nurses to screen for oral diseases, including oral cancer, and allows nurses a greater role in the total patient care. As a part of a total patient care, nurses hold a vital role in prevention and the early detection. And these efforts with the referral to oral cancer screening are vital for decreasing the cancer mortality and the morbidity rates. So the cross-sectional descriptive survey was carried. A self-structured close-ended questionnaires were administered through the Google Forms, and the data collected was compiled in a systematic manner and analyzed in the terms of the yes or no questions. And the questionnaire was circulated in the 5 nursing colleges in Mumbai. And out of 254 students, 95%, that is 240 students, agreed to participate in the study. And the questionnaire comprised of the contact details, knowledge about the different forms of the tobacco, precancerous lesions, oral cancer, their appearances, and the screening methods. So these were the reasons on the staff. They were not aware about the ill effects of the tobacco on oral cavity. 10% were not known that tobacco will lead to the oral pre-cancer, and the 15% were not aware of the long-term effects of the tobacco. 41% did not aware that e-cigarettes are carcinogenic, and 28% did not know that treatment of the oral cancer could lead to the loss of the facial structure. And 31% did not know about the precancerous lesions of the oral cavity. And 46% did not know how the oral screening can be done. 66% they had not attended any screening camp. So coming to the discussion part, not many studies are conducted amongst the nursing population regarding the oral cancer and the pre-cancer screening and the ill effects of the tobacco. So the similar study was conducted by the Kartner M. et al. 2009 regarding the oral cancer awareness amongst the nursing staff in UK. And the results were quite similar. And authors had concluded the awareness of the oral cancer risk factors was poor amongst the nursing staff. So according to my knowledge, this is the first study which is done in India. But the limitations of this study are the number of participants were very less. It was almost like around only 3% of the students were involved in the survey. So the same study has to be done on a wider population, considering the students from the different parts of the country. And coming to the conclusion part, the awareness about the ill effects of the tobacco on oral cavity amongst the nursing student and the staff was poor. So this study highlights the need for improved education of the nurses towards oral cancer and pre-cancer.
We have 1 more minute left.
As it forms a major burden on the oral health care. The lack of the awareness of the oral cancer risk and the clinical signs may also prohibit nurses from delivering preventive advice. So primary prevention, as we know, the prevention is always better than cure. Primary prevention is the most cost-effective prevention program, as it aims to reduce the incidence of the cancer by the risk factors modification. So the 50% of the all cancer in males are the tobacco related, and a large proportion of them can be prevented by the anti-tobacco program. And our government is conducting such programs for the early detection program. So under the Swachh Mukh Abhiyan, that is the oral health mission, the government is conducting the camps in the nursing colleges to create the awareness, and so that they can screen the patient when they are admitted in the hospitals for the oral cancer, so the pre-cancer lesion, and then they can refer it to the dentist. So this even in our department, college has also done such survey and such lectures which created for the
Thank you,
in the
ma'am.
dental in the nursing students. So thank you amongst the nursing students, and these are my references.
Ma'am, your time is up.
Thank you.
Those who are not presenting, please mute your board. Those who are not presenting, please mute your section.
Okay, now it's time for discussion. Over to you, Dr. Shahnaz, ma'am.
Okay. What was your sample size?
Ma'am, 240 nursing, 241 nursing staff and students.
Okay, like among them, were there smoking people, like were there smokers? Did you include them in the study population?
പക്ഷെ ഇവിടം തൊട്ട് ഞാനിന്ന് തന്നെ അതാ വലിയവരല്ല കൊച്ചിനോടെ അടിക്കാൻ പറ്റുമോ? പക്ഷെ ഇത്രയും ഭാഗം ഇവിടം വരെ ഇന്ന് എത്ര മരുന്ന് ആന്റിബയോട്ടിക് കഴിച്ച് വേറെ ബാക്കിയുള്ള മമ്മി പറഞ്ഞ കുക്കറി കോഫ് ഓർഡർ ചെയ്തിട്ടുണ്ട്, നാളെ വരും. കുർക്കി കോഫ് ഞങ്ങൾക്ക് ശ്രമിക്കാം, എല്ലാം ശ്രമിക്കാം. ആവി എന്ന് പറഞ്ഞാൽ ഡെയിലി പിടിച്ചോണ്ടിരിക്കുക, മിനിമം 4-5 വട്ടം ഡെയിലി പിടിക്കുന്നുണ്ടാവും. ഒരു രക്ഷയില്ല നൈറ്റ് കേട്ടോ, വന്നു കഴിഞ്ഞാൽ ശല്യമാണ്. പക്ഷെ ഇവിടെ ഒരുവിധം അവളാ കൊണ്ടുവന്നത്. എന്നിട്ട് അവള് 2-3 ദിവസത്തിൽ തുള്ളിച്ചാടി നടക്കിട്ട് ഞാനും അച്ഛനും ഇവിടെ കിടന്ന് അനുഭവിക്കുക. അയ്യോ, ഇന്നലെ മിനിയാന്ന് ഞാൻ വന്നത് അച്ഛനടുത്ത് നീ ഒരു കാര്യം ചെയ്യും, ഗ്യാസ് പുതിയത് ഫിറ്റ് ചെയ്തിട്ടുണ്ടോ ഒന്ന് തുറന്ന് മണപ്പിക്കാൻ പറഞ്ഞു. ഞാൻ അടുത്ത പറയുന്നത്
Can you please ask Aishwarya to mute, or you can just remove her? She will come again.
Okay, sir. Okay, sir.
We have administrative, please remove.
Yeah, sure, sir. Wait.
We will again.
എൻ്റെ ഒരു മാഡത്തിന് ഇത് മിമി അച്ചാർ ഇത്രേ ഉള്ളൂ, ഇത്രേ. അതിന് 1 മാസം 2 മാസം ഇരിക്കൂല. കുറച്ച് വീട്. എന്നിട്ട് പിന്നെ മമ്മി വരുമ്പോ പിന്നെ വലിയ ചാടി കൊണ്ടത് അതെ. മിക്ക ദിവസവും ഞങ്ങളുടെ ആശ്രയവും ശരണവും അത്. വേറെ ഒന്നും കൊടുക്കണ്ട, ബാക്കിയൊക്കെ മമ്മി ഒരു കൊണ്ടത് അതെ. അമ്മ ഇങ്ങനെ വലിയ പെട്ടി കൊണ്ടുവരുന്നുണ്ട്. അതാ ആഹാ.
Okay, Dr. Shahnaz Mehboob, please continue.
Yeah, okay. Yeah, so
sorry, ma'am.
Okay. So among the study population, did you have the smokers and others?
Ma'am, among the study population,
were the smokers included, like in those nurses itself?
Ma'am, I'm not able to hear you properly.
Did you have in the study population, that is among your nurses?
Yes, ma'am. Yes, ma'am.
There were smokers?
Ma'am, actually, I had not included that question.
Okay. Did you include the question whether they can identify the like clinical presentation, like if there is a precancerous lesion and all?
Ma'am, whatever questions were included, I had mentioned those questions in the presentation.
Okay. So these questions were not included.
Ma'am, all these questions are included, ma'am.
Okay, thanks. So what do you think, what is the step that you can take to increase the awareness?
Yes, ma'am. Like our college, our department, we had conducted a lecture on different forms of the tobacco and how pre-cancer and the cancerous lesions look and how the screening can be done. So such lectures can be conducted, or even in their curriculum, government can add few things which will help them to help in early detection of the oral cancer.
Okay, fine. Okay.
Thank you, ma'am. Now over to you, Dr. Sanjit sir.
Yes. Good evening, Doctor. So in your presentation, you have added as whether they were open-ended questions or closed-ended questions. You have written.
Sir, I'm very sorry. I'm not able to hear you.
Did you written it as whether it is open-ended question or closed-ended questions?
Yes, ma'am. Yes, sir. All questions were close-ended, yes or no type question.
So what inference did you come out of this? So you showed individual frequencies of all these things. So what is your conclusion from all this? So that is only tabulation of your individual results. So what is your inference from all this?
Inference, most of them, they had not attended any pre-screening camp. So if we teach them or we just show them how it is to be done, or if we give even a theoretical knowledge to them so that they can apply, there will be a so that a more patient will be diagnosed at a precancerous level, and then the mortality and the morbidity rate will get reduced because of the oral cancer lead.
Okay, thank you. Okay, thank you.
Okay. Thank you, judges. Now it's PG paper 33. PG paper 33. Please confirm PG paper 33. Okay. PG paper 34. PG paper 34. Please confirm PG paper 34.
Yes, ma'am.
Okay. You'll be given 30 seconds for screen sharing.
Okay, ma'am. Hello, ma'am.
Yes, you can start now.
Okay. My topic is DNA profiling in forensic odontology. And ma'am, is the screen proving?
Yes, ma'am. Yes, ma'am.
Doctor, can you please start slideshow?
Okay. Sir,
Doctor, can you please put on slideshow?
Sir, can you see the second slide, sir?
Yes, ma'am. Outside slides are visible.
Okay, sir. Okay, ma'am. With DNA, the ability to find out more with a lot less has increased our ability for identification. Then with other means of traditional identification become impossible following mass calamities or fire explosion. Teeth provide a rich source of DNA as they have a high chemical as well as physical resistance. And the recent advance in DNA profiling had made DNA evidence to be more widely accepted in courts, and this is revelation to the aspect of forensic odontology. The recent evolution in the isolation of DNA and ways of obtaining a DNA profile is discussed here. DNA profiling is process where a specific DNA pattern called a profile is obtained from a person or sample of bodily tissue. There is a reason why only DNA is used, because in all body tissue the DNA is the same. Even after death of individual, it remains the same even after 1,000 years. And we use both nuclear and mitochondrial DNA for comparison. We compare the unknown DNA with known antemortem sample like hair left in comb, epithelial cells in toothbrush, clothing, biopsy, etc. And if the antemortem sample is not available, we compare it to DNA of parents, children, or siblings. And with DNA fingerprinting, although we use DNA fingerprinting as a synonym for DNA profiling, it's not the same. DNA fingerprinting is actually the forerunner of DNA profiling, and it was developed by Dr. Alec Jeffrey in 1984. And invention of PCR by Carey Mullis in 1985 has allowed us to create a DNA profile from very trace amount of DNA. And the principle of DNA profiling is that we, although in 99.9% DNA is same in every human, only 0.1% is different, and this 1% difference is unique to each individual, and we have non-coding repeated sequence in this non-coding DNA called DNA satellites. We have mainly two types, that is variable number tandem repeat. This tandem repeats is like I've given an 3% examples. Like we can see it is at a particular loci, you can see there are tandem numbers are repeated, and this variable is used to actually identify people. The FBI has approved 24 standard loci, and comparing just 8 is enough to identify a person. That like if two people in the earth having same number of STR, in 10 loci the chance is around 1 in a billion. And so if in 10 loci, if it is same, we can confirm it's the same person. Then we have different methods like RFLP, PCR method, and STR typing methods used. And STR method is the most advanced, simplest, and fastest technique that is most commonly used now. We no longer use RFLP. But it is more accurate, but it is a lengthy, cumbersome procedure. It takes more than 7 days. Then objectives we use in accident and disaster victim identification, example in plane crash, earthquake, tsunami, etc. Then soldiers in war and decayed body identification. Then in sexual assault cases, DNA sample from saliva found in victim can be compared with that of the suspect. Associating body parts. Then this is the steps after collecting DNA from the pulp or saliva. Then the next step is DNA extraction. Then we quantify it. Then we amplify using PCR. Then it's separated, and then analysis is done using gel electrophoresis, and we view it through an X-ray. These are techniques of DNA extraction from teeth. You have cryogenic grinding, milling, preparing conventional endodontic access, vertical section pulpectomy, and horizontal section. And DNA extraction technique, we have several techniques, and we are now there is extraction kits are available now, which can be used conveniently. And this now mainly what we use is standard tandem repeat. STR analysis most commonly used now. This is a simplified model I've shown here, and here the STR profiles of victims in an accident is shown, and we can use that to compare the antemortem sample. Okay, ma'am. Okay, ma'am.
Over to you, Dr. Shahnaz, ma'am.
Yes, sir.
Okay. Which is the best used method of this DNA profiling?
Ma'am?
Which is the best method in this DNA profiling techniques?
STR typing is the best method.
What are the advantages of this STR?
STR typing, record it, we can, then it is easier, and it usually small DNA base length, and it is easier. It takes only little time. The other one, RFLP and all that, take around 7 days to confirm, and the procedure is long, but STR is easiest and simplest, and it's more advanced.
And which is the best extraction method, or like DNA extraction method? Which one is the best?
Organic is the best extraction. Then if you have that, there are various kits available that we can. That is also easiest method actually.
Okay. Okay. Thank you.
Okay.
Okay, can you tell me some limitations of these mechanisms, the techniques?
In identical twins, the DNA profile will be same.
Okay.
Then it is very expensive. Like then it is little bit technique sensitive. Then we need a minimum of 25 nanogram of DNA to visualize it in to amplify it in PCR. If the DNA is less than that, then it is difficult. Then there is high chance we get impure. High chance there will be impure DNA to pure DNA is needed.
So, have you any idea till what time the DNA can be preserved in tissues like tooth, hair?
Sir, it is actually DNA is a stable compound. Like around 1,000 years, it will be stable. That's what I read, sir.
Okay, thank you, sir. Those who are presenting, please switch on your camera. Okay. So next is PG paper 35. PG paper 35, please confirm. Okay. Moving on to PG paper 36.
Yes, ma'am.
Okay. Okay. You will be given 30 seconds for screen sharing.
Yes, ma'am.
Okay.
Is the screen visible, ma'am?
Yes, ma'am.
Good evening, chairpersons and dear delegates. My paper presentation is on role of autophagy in oral squamous cell carcinoma, a therapeutic perspective. Oral cancer is the 6th most common cancer in the world, and oral squamous cell carcinoma accounts 90% of oral cancer with various levels of cell differentiation and lymph node metastasis. Low survival rate of less than 5 years is due to late-stage diagnosis, high degree of invasiveness, and late development of therapeutic resistance. Sorry. OSCC could be treated by surgery, chemotherapy, radiotherapy, hormonal therapy, immunotherapy, or a combination therapy. OSCC is multifactorial in origin, characterized by genetic and epigenetic vulnerability. Among the various mechanisms involved in oral carcinogenesis, autophagy forms an important one. Autophagy. It can be defined as a complex cellular process by which old and defective cellular components meet their metabolic activities. There are 3 main types of autophagy, that is macro, micro, and chaperone mediated, in which macro autophagy is the most common type, and it involves formation of double membrane vesicle called autophagosome, which fuses with the lysosome and leads to degradation of the cellular components. Mechanism of autophagy is a multi-step process. It can be explained in 3 main steps, that is initiation, elongation, and maturation. When there is a stressful environment created in the cancer condition, we have this ULX1 complex and PI3 complex, which activate and localize to nucleation site and induces emergence of small membrane called phagophore. And this phagophore is elongated by two ubiquitin-like conjugation system, that is the ATG5 and ATG16, along with LC31. This induces elongation of phagophore until a double membrane vesicle is formed called autophagosome. In the maturation state, this autophagosome fuses with the endolysosomal compartment to form autolysosome. This is degraded via acidic lysosomal hydrolases. Autophagy has been recognized as a crucial pathway used by cancer cells to survive under stressful microenvironmental conditions, which aids cancer cells in avoiding death by chemotherapeutic agents. Thus, targeting autophagy could be an effective therapeutic strategy against the cancer. Dual role of autophagy in SCC is it can cause tumor suppression and it can also lead to tumor progression. So targeting autophagy as a therapeutic approach can be dealt under these four headings, that is chemotherapy, radiotherapy, hormonal, as well as immunotherapy. In the chemotherapy, we have chloroquine. Chloroquine, when ingested to the OSCC patient, it becomes entrapped and protonated within the lysosome, results in increased lysosomal pH. This renders lysosomal hydrolytic enzyme activity, thus it induces the autophagy. It inhibits the autophagy. And the same mechanism is followed by the hydrochloroquine as well as the lyso-5, which are the newer versions of the chloroquine. Specific autophagy inhibitors. There is a phosphorylation taking place in the PI, which is converting it into PI3K by lipid kinase. This helps in biogenesis of autophagy. This can be inhibited by these specific autophagy inhibitors. In that, the first one is PI3K inhibitors, in which 3-methyladenine is the most commonly used one, which is directed towards the VPS34 of class 3 PIK3 gene. And the other VPS3 members are also involved in autophagy biogenesis, which can be inhibited by STAR405 and spotin, which indirectly acts on the Beclin-1 protein, and that acts on the VPS protein, causing autophagy inhibition. We have ULK1 or 2 inhibitors that are MRT68921 and SBI02069665. Radiotherapy has two roles to play in this autophagy approach. That is, first one, the ionizing radiation induces autophagy by protein conformation. On the other hand, we have this ionizing radiation causing cancer cell death by inhibiting autophagy through ATG5 silencing mechanism. So we have two roles of ionizing radiation in approach of therapeutics.
You have 1 more minute left.
Immunological molecules such as IDO, CT, LA, PD4 cells, they cause cytotoxic T-cell response suppression, which leads to promoting development of tumor. And we have interleukin 1 and 2 are targeted by autophagosomes. This also increases COX-1 and SAPK. Using alpha interferon plus chloroquine can inhibit the autophagy. We have hormonal therapy where we use epinephrine, which changes the level of PE in the cell and thus helps in tumor suppression. To summarize, autophagy is a cell and time-specific mechanism. It plays an important role in OSCC therapeutics. Chemotherapy, radiotherapy, immunotherapy, and hormonal therapies could influence autophagy to various extents. Dual oncogenic tumor suppressor proteins in oral cancer is an important role. More clinical trials are required to unfold many more applications of autophagy in OSCC therapeutics. These are the references that I have used. Thank you for your patient listening.
Okay, thank you, ma'am. Now over to you, Dr. Shahnaz, ma'am.
Okay. So this autophagy, other than this cancerous conditions, where else is it important? Any other area? Do you know any other?
Other than cancer, ma'am, autophagy is a process that is used daily in the cellular basis to maintain the homeostasis of the cell.
So any other disease conditions?
Other than cancer, ma'am. Diseased condition, no, ma'am. As of my knowledge, it is mainly used in the cancerous condition. It cannot be only used in the oral cancers, ma'am. It can also be used in all the other cancers that is occurring in the body.
Okay.
Okay, thank you, ma'am. Now over to you, Dr. Sundit, sir.
Okay, doctor, can you just tell me what is autophagy and how does it differ from apoptosis?
Yes, sir. Apoptosis is a process wherein the complete cell is undergoing autolysis and there is breakdown of a cell. But autophagy is a mechanism which breaks down only the intercellular organelles and it is not affecting the nucleus of the cell, and the cell is also remaining in the condition. So this is the difference between the apoptosis and autophagy.
Okay. Thank you, sir.
Okay. Now it's PG paper 37. PG paper 37. Please confirm PG paper 37. Okay. Now it's PG paper 39. PG paper 39. Please confirm PG paper 39. Okay. PG paper 39. Okay, now it's PG paper 40. PG paper 40. PG paper 40. Okay. Now PG paper 38.
Yes, I'm present.
Okay. I have 30 seconds for screen sharing. Please switch on your camera. Those who are presenting, please switch on your camera.
I start.
Yes, ma'am, you can start now. Ma'am, your time is running. You can start now.
Okay. Is application of immunophils in the string is epidermis nutrition instance something is wrong. So,
Ma'am, your audio is not. Ma'am, you're not audible. Ma'am, you're not audible. Ma'am, are you ready?
Ma'am, you are not audible.
Okay, ma'am, you will be given a chance at the end.
Hello. Hello.
Yes, ma'am. Ma'am, you're not audible.
Am I audible?
Yeah, now.
Can I start?
Yeah, you can start.
Immunofluorescence is a histochemical laboratory staining technique used
Okay,
for
can you please go to the first slide?
Okay.
Can I start? Ma'am, your voice is breaking.
Madam, please start from slide number 1.
Today, the topic of my presentation is immunofluorescence under the following contents: introduction, techniques, applications, and conclusions. And introduction: immunofluorescence is a histochemical laboratory staining technique used for demonstrating the presence of antibodies bound to antigens in tissues or circulating body fluids, essential to supplement clinical findings and histopathology in the diagnosis of immunoglobulin disorders. Permit early diagnosis, treatment, and subsequent monitoring of disease activity. There are 3 basics of immunofluorescence technique: direct, indirect, and complement. In indirect immunofluorescence, the antigens reacted directly with a fluorescent conjugated antibody specific for areas within the tissue. And in indirect immunofluorescence, 2-step serological technique for detecting the circulating antibodies in the body fluids uses serial dilution of patient serum. It is applied to the section of suitable tissue substrate, conjugated anti-human IgG is then applied to localize the autoantibodies, and it is taken from the patient serum that are bound in the tissue substrate. And in this 3-step procedure, which is a catalog component. If present, the fluorescent staining of antibodies or beyond that are achieved by conventional the enhancement is due to the amplification achieved through binding of more than one molecule of complement to each immunoglobulin and the subsequent visualization of the multiple molecules of complement. The main use of this method is in the diagnosis of pemphigoid gestation, in which the autoantibodies evidently fix complement but are difficult to detect using conventional techniques. This technique significantly increases the sensitivity of IIF in pemphigoid gestation. And immunofluorescence methods are used in monitoring this activity in some of the immunoglobulin disorders on the basis of the level at which blistering occurs. Autoimmune blistering disease is subdivided as intraepidermal and subepidermal blistering disorders. In pemphigus vulgaris, it is characterized by loss of cell adhesion leading to acantholysis, which results in intraepithelial blister formation. IgG autoantibodies are deposited in the oral squamous epithelium. IgG autoantibodies target the desmoglein tree. Intercellular deposits of IgG and C3, the latter are predominantly located in the lower layers of the epithelium in almost 100% of the cases. And paraneoplastic pemphigus, it's very similar to PV, but it shows diversity of autoantigens, reactivity with desmoglein tree, desmoplackins in basement membrane zone. And in direct immunofluorescence, it is similar, but it shows similar pattern to that of pemphigus vulgaris, along with the position of IgG and C3 in the basement membrane zone. And bullous pemphigoid, deposition of IgG, C3 or both at the basement membrane zone, deposition of C3 with significantly higher intensity than IgG strongly favors the pemphigoid group of diseases. And in epidermolysis bullosa acquisita, it's multiple deposits basement membrane zone. In epidermolysis bullosa, intense IgG deposition is almost consistently present. The intensity of C3 deposition is really less than that of IgG. Deposition of IgA is present in approximately 2/3 of cases. And in linear IgA disease, linear deposition of IgA at basement membrane zone, deposition of C3 is present less frequently and with lower intensity compared with IgA. And dermatitis herpetiformis, granular deposition of IgA and C3 in the papillary and the base membranes of patient and the biopsy is maintained from non-application skin. Deposition of C3 is seen in approximately half of this. Deposition of IgM or both is less frequent and less.
Ma'am, you
and DF testing of clinically normal skin of SLE patient often shows a study of IgM or components. And in lichen planus, immune deposits are present within cytoid bodies in the superficial dermis and along the epidermal junction, and most frequently present in IgM and fibrinogen. And deposition of IgM in cytoid bodies in the papillary dermis is diagnostic of lichen planus. Conclusion, it is helpful diagnostic tools for identifying the various immunobolus disorders. It results in visualization of agents in the cell.
PG paper 38.
Yes.
Okay, continue.
These are the references I have taken.
Okay, thank you, ma'am. Now it's time for Dr. Shahnaz, ma'am.
Okay. Actually, your presentation was not very clear for me. Have you heard of salt split technique?
Yeah, salt split technique is an variant of immunofluorescence.
Can you tell me what is it about? Like how do you do that?
Ma'am, it is to distinguish epidermolysis bullosa acquisita from other immunobolus disease with subepithelial clafting.
No, what do you do? Like what is the technique, the salt split technique?
Ma'am, the patient's perilesional skin is incubated in a concentrated salt solution, which causes the epithelium to separate from the connective tissue, forming an artificial induced bulla.
Okay. Okay. Fine. Then in this direct immunofluorescence, when you take this oral lichen planus and all, you have a particular pattern. Okay. Do you know what do we call that pattern?
Sorry, ma'am, I can't hear you.
In lichen planus.
Yes,
okay. When we do this direct immunofluorescence. Okay.
Yes, ma'am.
You get a pattern. Okay, there's a pattern, particular pattern. Do you know that?
Fishnet pattern.
Sorry?
Fishnet pattern.
Okay. Any other name? Yeah, okay, fine. Thank you.
No,
Thank you, ma'am. Now over to you, Sanjit sir. Dr. Sanjit sir.
Okay, Doctor, can you enumerate a few advantages of doing immunofluorescence over normal histopathology examination? Advantages of using immunofluorescence rather than histopathology examination for HND, normal HND sections. Are you able to hear?
PG paper 38. Is it audible? PG paper 38. Okay, thank you, sir. Okay, I will be.
That's fine.
Okay. Okay. Okay, I will be calling again. PG paper 31. Please confirm PG paper 31.
PG paper 31. Okay. I'm moving on to PG paper 33. Please confirm PG paper 33. To PG paper 35. Please confirm PG paper 35. PG paper 35. Moving on to PG paper 37. PG paper 37, please confirm. Okay. PG paper 39. Please confirm. PG paper 39. PG paper 39, please confirm. Okay. Okay. PG paper 40. Please confirm PG paper 40. Okay. You will be given 30 seconds for screen sharing. PG paper 40, please continue.
Ma'am, you have to see the screen.
Yes,
Good
ma'am.
evening. Good evening, everyone. Today I'm going to present on the research topic of PDGF, PB, MRD, and potential maladies diagnostic biomarker and oral cervical sclerosis and oral squamous carcinoma. So, coming to the introduction, as you know, oral squamous carcinoma is supposed to about 90% of the oral cancer, and it has a poor prognosis with a decrease in the survival rate for the past 30 years. And the median transformation rate is highest in the OSMF to OSCC, accounting for about 7 to 13%. And the mean value of the transformation rate is 4.3 years. The first marker is platelet-derived growth factor, that is PDGF-BDD. It is released by platelets, endothelial cells, and macrophages, and studies have proven that this causes tumor invasion, angiogenesis, and progression. The next marker is MMP9. MMP9 has to know this zingital megaproteins, which is released by macrophages, neutrophils, and fibroblasts. And this causes the degradation of there is a decrease in degradation of extracellular matrix rather than the tumor angiogenesis. So this is a pathway which is seen in the breast cancer, where we can see the PDGF-BB is acting on the PKT, P13 and AKT pathway, and MAPI and ER2 1 by 2 pathway leading to the tumor proliferation and migration, and MMP9 which acts on the VEGF leading to the tumor angiogenesis. So the main objective of the study is to evaluate and correlate the serum expression of PDGF-BB and MMP9 in OSMF and OSCC cases, and the rationale is to understand the role of PDGF-BB in PDGF-BB, MMP9 and serum proteins and OSMF and OSCC. The novelty of the study is first kind of study to analyze and compare the expression of PDGF-BB and MMP9 OSMF, OSCC, and to compare with the healthy control. And there is no study reported to analyze the expression. And this is a serum sample which is seen in the Indian population. So the study design is a cross-sectional study where we collected blood sample and serum was collected and stored at -80 degrees Celsius. And 3 groups was included: Group 1 healthy control, Group 2 OSMF, and Group 3 OSCC. The inclusion criteria included clinically confirmed cases and with histopathologically confirmed cases. And the exclusion is treated cases excluded with the systemic illness and other OPMDs. Recurrence cases was included and varicose cases was included. So the statistic which was done was mean standard deviation, chi-square to see the association, Pearson to see the correlation. So procedure, serum sample was collected, antibodies, these are antibodies used, and addition.
Dr. Carey, please change the slides also. The slides are not moving at all.
So I'm moving, so you're able to see the slides, sir? So these are the results. So in results, we were able to see a gradual increase in the
Actually,
serum.
in this, your slides are not moving.
Hello?
Ma'am, your slides are not moving, ma'am.
It's moving on. You're able to see the slides now?
We are able to see the slides, but it's not moving, ma'am.
Yes, now it's moving.
Okay, sir. Okay, sir. So from where should I start also? Can I start it from the results, sir? Or from the Aim and objective.
From aims you can start.
In aim and objective, the main aim and objective is to evaluate the serum expression of PDGF and MMP9 in OSMF and OSCC. The ratio is to understand the role between the PDGF and MMP9 in serum of OSMF and OSCC. Coming to the novelty, it is first kind of study to analyze and compare the expression between PDGF and MMP9 with OSMF, OSCC and the control. There is no study done, but in serum sample. The mechanism method cross-section study was done, and serum sample was collected, and 3 groups was included, group 1, group 2, and group 3, healthy control, OSMF and OSCC, each containing 15 samples. Histologically, inclusion included the histopathological clinical confirmed cases of OSMF and OSCC, exclusion of treated cases, systemic illness, other.
Ma'am, you have 1 more minute left.
Okay, ma'am. So coming to the results, we were able to see a gradual increase in the healthy control, OSMF and OSCC. And these are the results. We were able to see that when we saw the subgroup analysis, we were able to see the subgroup significant results in the subgroup analysis. And these are the graph chart. In discussion, it is the first time to do in the OSMF and OSCC. And when in one study, Taiwanese population, they saw the matrix metalloprotein causes the single polymorphism, which leading to the pathogenesis of OSMF, and the PDGF increases, which through the pathway P13 and P13 AKT pathway, leading to the pathogenesis of OSMF and malignant transformation of OSMF to OSCC. This is a hypothesis which was done by me. Whenever there is an increase in exposure of aricamate in Indian population, and the matrix metalloprotein increases, which lead to XNP increase, thereby abnormal extracellular matrix protection and degradation decreases. When the platelet is increased, the collagen synthesis is increased, degradation decreases, thereby.
Ma'am, your time is up. Thank you, ma'am. Now over to you, Dr. Shahnaz, ma'am.
Okay, your presentation was super fast. Can you tell me what is the final conclusion of your study?
In conclusion, there was increase in the MMP9 and PDGF when compared to the healthy control in OSMF and OSCC, ma'am. And it can be due to the ERK, APK, and P13 AKT signaling pathways, ma'am. So this was a small sample. So further, with a larger sample, can be done, and this can be supported the theory, which hypothesis of genetic predisposition. So further, genomic analysis can be done, ma'am.
How many cases did you take of this OSMF and OSCC?
OSMF 15 and OSCC 15 samples, ma'am.
Okay, and how did any grading, anything like that?
Grading was done, ma'am. In OSCC, well differentiated, moderately, and poorly differentiated we took, ma'am. In OSCC, 4 grading very early, we took 3 grading only, ma'am. Early, and moderately advanced and advanced, ma'am.
Okay, so how did it differ with that?
There was a significant, we saw in PDGF, VB, and MLP9 in the subgroups, ma'am. So this thing was increased only, ma'am, the expression of MMP9 and PDGF.
In both the cases, okay.
In both the cases, ma'am.
Okay, thank you.
Okay, thank you, ma'am. Now over to you, Dr. Sundit, sir.
Yes, doctor, what kind of statistical tests did you perform?
So I did a chi-square analysis to see the association and to see the correlation, Pearson correlation was done, sir.
So what was the p-value like?
Yes, sir, p-value was significant, sir. Less than 0.05.
So what is the relation between the MMP9 with regard to both the lesions?
So
how much was the variation?
So I'm not able to hear you, sir. So what is it? What is it?
What was the relation and how much was the difference with you compared to lesions, right? OSMF and OSMF. So
yes, sir,
what was the relationship? What was the relationship? Which one it was higher? When
compared to the healthy group, like OSMF showed an increased value of both the markers, sir. And when we saw with the OSCC also, there was increase, sir. Like comparing to the OSMF and healthy group, OSCC also, the both the markers was increasing, sir. PDGF.
So which one showed more increase? Which one was higher?
Higher increase, OSCC was increased, sir.
For both of them, MMP9 and PDGF.
MMP9 and PDGF baby. And we also
for
correlated with the
OSCC was more when compared to OSMF.
OSMF, sir.
Can you just show that slide? The final result slide. No, the result. Result.
This one, sir.
Yes, yes.
And when we compare with the platelet count, we saw the CBC of the patient's platelet count, sir. So it was like increased in OACC when compared to the healthy.
Okay. Okay. Thank you.
Thank you, sir.
Thank you, sir. Thank you, judges. Dr. Shahnaz ma'am, thank you so much. And kindly receive the certificate as our token of appreciation. Dr. Shahnaz ma'am, thank you so much. Kindly receive the certificate. Now, Dr. Sangeet sir, thank you so much, sir. Kindly receive the certificate as our token of appreciation.
Thank you.
Thank you. Thank you all. Now we are winding up the session. Thank you so much.
Yeah.
Good evening, all. Okay, let me confirm if everyone is present. Please raise your hands or just respond. Faculty paper 01. Please confirm. Faculty paper 01. Please raise your hands. Faculty paper 01. Okay. Faculty paper 02. Faculty paper 02. Please confirm. Faculty paper 02. Please raise your hand or just respond.
Please unmute.
Yes. Okay. Faculty paper 03. Faculty paper 03. Faculty paper 03, please confirm. Okay. Faculty paper 04. Faculty paper 04, please confirm. Faculty paper 04.
Yeah, I am here.
Okay. Faculty paper 05.
Yeah, ma'am.
Okay. Faculty paper 06. Please confirm. Faculty paper 06.
Yeah, I'm here.
Okay.
Yeah, I'm here.
Okay, ma'am. Okay. Faculty paper 07.
Yeah, there, ma'am.
Okay. Faculty paper 08. Faculty paper 08. Please confirm. Faculty paper 08. Faculty paper 09. Faculty paper 09. Please confirm. Faculty paper 09.
Faculty paper 03 available.
09.
03.
Sorry. Sorry, Dr. Karthik. Which faculty paper?
03.
Okay, okay. Faculty paper 08. Please confirm. Faculty paper 08. Please confirm. Faculty paper 09. Faculty paper 09. Faculty paper 010.
Yes, ma'am, I'm here.
Okay. So we're going to start our session. Good evening, everyone. Pushpagiri College of General Sciences is delighted to host Kerala State 5th Annual Triple O Conclave. Let's start scientific presentation under Department of Oral and Maxillofacial Pathology,
Starting with faculty paper presentation. Now going on to session 7, hall 1. We invite judges for our session.
It's my privilege to invite Dr. Maya Ramesh and Dr. Pramod Philip Matthews. Dr. Maya Ramesh, Professor and Head of Department, Oral and Maxillofacial Pathology, Vinayaka Mission Shankaracharya Dental College, Salem.
Dr. Pramod Philip Matthews, Professor and Head of Department of Oral and Maxillofacial Pathology, Maharbasilios Dental College, Kodamangalam. We welcome you all.
Okay, now let us proceed to the instruction. For paper presentation, you have 5 minutes. You will be given 30 seconds for the screen share before presentation. And if your time exceeds more than 30 seconds, next candidate will be called off and you'll be given a chance at the end. And you will be given a warning at the 4th minute, preceded by a final warning at the 5th minute. I hope the instructions are clear. Now let's start the section.
I would like to call faculty paper 01.
You will be given 30 seconds for the screen sharing.
Faculty paper 01.
Please confirm. Faculty paper 01. Okay.
Okay. Moving on to faculty paper 02.
Faculty paper 02. Please confirm. Faculty paper 02?
Yes.
Okay.
Okay, you will be given 30 seconds for screen sharing.
Yes, ma'am.
Okay.
Ma'am, your screen share is ready?
Yes. Is it visible? Is it visible? Hello. Is it visible?
No, ma'am. It's not visible.
1 minute.
Ma'am, you will be given a chance at the end if you want.
Okay.
Is it okay if we call end?
Is it not visible now? Still not visible?
Yeah, it's loading, ma'am.
Visible?
Yeah,
Yeah,
it's
ma'am.
visible. Yeah,
Yeah,
ma'am.
now it's visible.
Your time start now, ma'am.
Yeah. Good evening to one and all. The topic of my presentation is comparative histochemical analysis of 4 markers, mainly MT1, MMP, TIMP1 and TGF beta 1 and alpha SMA in OSMF and OSMF with coexisting OSCC. We all know about the etiopathogenesis of this OSMF. So again, proceeding with that, the researchers have been mainly conducted in the past to study different molecular aspects of the carcinogenesis of OSMF through molecular biomarkers, which help to identify high-risk cases of OSMF and which can be targeted through tailored treatment modalities, which can prove very useful for high-risk patients. MT1 MMP is known for promoting cell migration, regional invasion of tumor, and also promotes basement membrane invasion. TMP1 mainly focuses on the proteolytic activity of MMPs and regulates the balance of matrix remodeling, regulates cell proliferation, anti-apoptotic properties. TGF beta 1 plays main role in collagens and degeneration of extracellular matrix, and also have the main ability for the cell migration and invasion by inducing the EMT. And they also causes differentiation of the fibroblasts, causing converting it into myofibroblasts, and which expresses alpha SMA, which again produces collagen, causing dysplastic reaction and thus contributing to invasion. So the aim of this pilot study to study the expression of all these markers in OSMF and OSMF with OSCC. To study these, 5 blocks were taken of each of these cases, and 4 micrometer section thick were cut for these cases. Scoring of the antibodies were done between the 2 independent oral pathologists, unaware of the clinical histopath details. These were the scoring criteria for all the markers, and this was the pictures taken for the IHC analysis. For results, Mann-Whitney U test was done and chi-square test was done. This was the result and the graphs followed by it.
Can I stop you for a moment, ma'am?
Yeah, yeah.
The slides are not moving actually.
Oh, it's not.
Yeah, it's not moving, but you are talking, but the corresponding slides are not being visible.
Okay, sir. Okay, so sir, I'll present in the last then.
Okay, ma'am.
But my
Okay.
screen has been shared.
It's okay, ma'am. You can present at the last.
We can share. We can see your this thing, but that screen, but it is not moving actually.
Okay, sir. Okay, sir, I'll present. Or in between,
problem.
anyone then is not presenting, then I'll come if it is.
Sure.
Okay, ma'am. Okay, we'll call you.
Okay, ma'am. We will call you.
Okay.
Okay, next is faculty paper
03.
Available
Faculty
here.
paper 03. Okay. You will be given 30 seconds for screen sharing. Okay, you can start.
Is my screen visible?
Yes, yes. Sir, can
Slides
you
moving?
Yes, sir. Yes,
Am
sir.
I
Yes,
audible?
sir. Yes, sir.
Evening, everyone. First of all, to all the women in O Conclave, International Women's Day wishes. And topic is lobular capillary hemangioma of a mandibular gingiva in a female patient. Case report. Like, to intro, the inflammatory hyperplasia affecting the oral mucosa might be in the oral mucosa or in the skin. The term pyogenic granuloma as a misnomer actually is unrelated to infection arising from local irritation or traumatic injury. Sorry, can't get you.
Slide show कर देने से कई बार move नहीं करता है.
कैसे करेंगे?
Hello, can I proceed?
Okay, sir, you can proceed.
Yeah, it's unrelated to the pus, as its name suggests, histologically resembles to angiomatous lesion. Synonyms: fibrous inflammatory dysplasia, papillary palatal hyperplasia, giant cell granuloma, and pregnancy abuse. Occurs mostly in female patients second decade of life due to hormonal imbalance. Clinically, appear as a lobulated, sessile pedunculated, esophagetic growth with surface color ranging from red to purple. Treatment modalities include surgical excision, NDOAG optical laser, rectodesiccation, intralesional injection of alcohol or steroids, sodium tetrahydrosyl sulfate, and sclerotherapy. Coming to the case report, 16-year-old female patient present discomfort of the region between the label surface of lower anterior teeth and inner mucosal layer of the lower lip in relation to the third quadrant. The general health examination revealed the patient was conscious, oriented, afebrile, vitals were stable. Intraorally during clinical examination, a pedunculated mass was observed labeled in relation to the left lower canine tooth. Patient stated that swelling started as a pinpoint lesion before 1 year and progressed to the size of 1 centimeter by 5 centimeter by 1 centimeter. Then color of the mass was coral pink, smooth, symptomatic during the contact between the lower left canine and the inner mucosal layer of the lower. Biolasepic diet laser 10 watts were used for the excision. Postoperative review was after 1 month with good prognosis, facilitating successful outcome. Differential diagnosis includes peripheral ossifying fibroma and peripheral giant cell granuloma to add up. Pre-operate, intraoperate, specimen, histopathology, stratified squamous epithelium, acanthosis, focal ulceration, lobular proliferation of capillary-sized vasculature, fibrotic stroma, necrotic debris, lymphoplasmacytic infiltrate, and focal myxoid degeneration. Postoperative. Coming to the point of discussion. Depending on this rate of proliferation vascularity, there are two histological variants, lobular type and non-lobular type, occur in young adults, mostly in females, second decade, as I already told you, due to increased levels of sex hormones and progesterone. ICD coding is K06.8, pathophysiology. Estrogen enhances vascular endothelial growth factor. There is VEGF production macrophages, likely contributing to development of pyogenic granulomas. In pregnancy, progesterone may function as an immunosuppressant in the gingiva, preventing an acute presenting an acute inflammatory reaction against an oral bacteria and resulting in proliferative gingival inflammation. There is an increased estrogen progesterone in pregnancy, increases concentration of prevotella intermedia, mainly in subgingival biofilm, which decreases the host response to the bacteria and increases vascular permeability and infiltration of fluids in gingival tissues, contributing to the formation of pyogenic granuloma. In 2018, International Society for the Study of Vascular Anomalies, there is ISSVA classification. They listed BRAF and RAS and GNA14 as casual genes for the lobular capillary hemangioma type. Etiology dates to the chronic irritation, poor oral hygiene, ill-fitting oral appliances, overhanging margins of dental restorations, persistent bite trauma, drug-induced gingival overgrowth from use of calcium channel blockers, calcineurin inhibitors, anti-seizure medications or anti-cancer medications, which includes TNF-alpha antagonist, BRAF inhibitors, tyrosine kinase inhibitors, epidermal growth factor inhibitors, mTOR inhibitors, taxanes, and pyrimidine analogs. Immunohistochemistry not readily used to add on CD34, CD31, erythroblast transformation specific related gene, alpha-muscle-actin, muscle-specific actin, and WT1. Emphasis on differential diagnosis. First, peripheral ossifying fibroma. Clinically identical, but only on gingival and linear ridge, presence of bone within the mesenchymal stroma. Peripheral giant cell granuloma, clinically identical, only on the gingival alveoli.
Sir, you have 1 more minute left.
Presence of osteoclastic bijointed giant cells and pyrolis, clinically identical, includes non-invasive tooth and tracing cataplasma can be used. OSCC, identical, invasive elements of squamous epithelium, spongiotic gingival hyperplasia, which includes papillary pubic surface, where you can see the neutrophilic exocytosis, which is not here. Angiosarcoma, infiltrative, rounded, may demonstrate keratin EMA positivity, but mitotic rate is very high. Corpus sarcoma, often seen in HIV/AIDS patients, is not here in this case. To finish off, surgical excision is the treatment option, which includes the conventional type and laser type. We usually have the laser type done in our case. And to conclude, it's the more common non-neoplastic lesion, and it's not associated with the pus, so it's a biogenic granulomatosis is a misnomer. So usually we encounter in the clinical area, so you better be cautious with it. Thank you.
Okay. Thank you, sir. Now over to you, Dr. Maya, ma'am.
Presentation, Dr. Karthik.
Good evening, madam.
Third paper. Yeah, good evening. It was a nice presentation.
Thank you, madam.
And did you follow up the patient? Was there any recurrence or anything? When did the patient come to you?
All very old people.
Recurrence?
No recurrence and all.
No, madam.
Please remain muted.
ഞാൻ ഇവനോട് മെസ്സേജ് ചെയ്യാൻ പറഞ്ഞതാ. Session. Please mute the session. അവനിപ്പോ ദേഷ്യത്തിലല്ല.
Please remain muted. Please remain muted.
ആരാ? എന്റെ ഫോണോ? That's what I told him. Take my phone and go.
Take a phone and go.
Yes, Dr. Berlin, I think you're through your mobile or something, your voice is heard.
Dr. Priyanka, can you please mute?
Yeah, thank you.
Yeah, ma'am. You please continue.
Yes, that's all, Dr. Karthik. It was good. Yeah, it was
Thank you, madam. Thank you. Thanks a lot.
Hello, Dr. Karthik.
Good evening, sir.
Good evening. It's a very, good topic that, good presentation that you've done.
Thank
I think
you,
you have almost covered everything about it, and we need not add anything much more to it, I think. Thank you.
Thank you, sir.
Thank you, sir.
Thank you.
Now, next is faculty paper 04.
Yeah.
So you will be given 30 seconds for screen sharing. Yeah, you can go.
Is the screen visible?
Yes, sir.
Okay. Okay. Shall I proceed?
Yes, sir. Your time starts now.
Yeah. Good evening. The topic of my presentation is role of inflammasomes in oral cancer. So we know that cancer-related inflammation is a very crucial topic that has been under research, especially in the past few decades. So much so that cancer-related inflammation is now considered one of the hallmarks of cancer. So inflammation can have both beneficial effects as well as it can have some harmful effects, especially in cases like in chronic diseases or sometimes in genetic events. When the inflammation becomes more aberrant or very long-standing, the products of inflammation especially can result in certain tumors. So they have certain tumorigenic properties. So what exactly are inflammasomes and what is their role in inflammation? So inflammasomes are basically cytoplasmic protein complexes of the innate immune system. They are usually intracellular pattern recognition receptors. That is, they recognize certain molecular patterns and then they propagate the signal downstream. So there are two broad categories of these inflammasomes, two families. One is the nod-like receptor family and the other is the aim-like receptor family, under which so many inflammasomes have been discovered and are being discovered. In fact, this topic is quite recent, like since 2010 or 11 only, there has been a lot of interest on inflammasomes. So far, around 12 to 13 different inflammasomes have been identified, out of which this particular inflammasome, NLRP3 inflammasome, has been studied very well in human pathologies. It has been found to be associated with a variety of human pathologies like arthritis, Parkinson's disease, diabetes mellitus, and even in a variety of cancers. So how exactly are these inflammasomes activated? So you have certain molecular patterns, pathogen-associated patterns, or sometimes even in the absence of any pathogens, any microorganisms, certain molecular patterns are damage-associated and they will be identified by these inflammasomes and they will propagate the signal downstream. In fact, recently, very recently, in the last couple of years, there has been one suggestion that inflammasomes are actually intracellular sensors. They can sense whether the cell is in homeostasis or not. So if the cell is not in homeostasis, then homeostasis altering molecular process, they can also activate the inflammasomes. So what happens when they get activated? They induce a type of programmed cell death that is called as pyroptosis. So this pyroptosis is basically an apoptosis that is associated with inflammation. And why this happens is because these inflammasomes will also release the pro-inflammatory cytokines, especially the interleukins 1 beta and 18. So briefly, what happens is when the molecular patterns, pathogen-associated molecular patterns or damage-associated molecular patterns are recognized by the cell, they will assemble an inflammasome within the cytoplasm of the cell. And this inflammasome will activate the caspase, especially the caspase 1. This caspase 1 can activate a set of proteins called as gas termins. When these gas termins are cleaved, the N-terminal end of these gas termins will assemble and they will create a pore on the cell membrane through which the contents of the cell will leak out into the interstitial space. Simultaneously, the caspase 1 will also activate the interleukins, and these active form of interleukins are again escaping out of the cell and they will attract further inflammatory responses. So what is the role in cancer? Is it pro-tumorigenic or anti-tumorigenic? Now, much of the study has been done in the past 4 or 5 years. So we are still accumulating data on the role of inflammasomes in cancer, in head and neck cancer especially. So one such study by Bay et al., it found that inflammasome is upregulated in carcinoma tissues and has a role in survival and invasion of head and neck squamous cell carcinoma. Similarly, Huang et al., they found that inflammasomes are associated with inflammation-induced carcinogenesis and in cancer stem cells also. The study by Chen et al., it identified that in addition to the tumor cells, the tumor-associated macrophages can also express the inflammasomes, and when it is done so, then there is a poor prognosis of the particular patient. And one experimental study has identified that inhibitors of inflammasomes can reduce the progression, which means that inflammasome indirectly it is helping in the progression of oral squamous cell carcinoma. So inflammasomes have both pro-tumoral roles and anti-tumoral roles. They can promote cancer cell survival, chronic inflammation, immunosuppression, etc. And anti-tumoral properties include maintenance of homeostasis of the tissue, promotion of anti-tumor immunity, and death of tumor cells by pyroptosis. So in relation to oral cancer, excessive inflammasome activation and apoptosis alteration may contribute to oral squamous cell carcinoma progression. So what is the impact of such studies? So we may be able to identify certain molecules or proteins or certain substances that can inhibit the inflammasome activation, and that can probably help in the cancer chemotherapy or the prognosis of cancer. This is just an opinion piece that I have mentioned here. This is not a finding of a study. It is just a theory that has been
your
proposed
time is
that
up.
caffeine can actually inhibit inflammation. So probably coffee drinking can be associated with a decreased risk of oral squamous cell carcinoma. So
Your time is
you.
up. Thank you, sir. Thank you, sir. Now over to you, Dr. Maya, ma'am.
It was a nice review, doctor.
Thank you, ma'am.
Are you planning to do any study on inflammasomes?
Yes, ma'am. We have certain markers, especially pyroptosis related markers and inflammasome markers like caspase and gas termins. So that we are planning to do an IHC study on squamous cell carcinoma patients, if possible in patients with tobacco related habits and without tobacco related habits, so that we can really find out whether chronic inflammation has a role in squamous cell carcinoma pathogenesis. That is
This will be more when inflammatory cells are more. Will it be more?
It is supposed to be like chronic inflammation. Propagation of chronic inflammation is supposed to be due to some alteration in the inflammasome activation. So if the proteins that are activating inflammasomes are overexpressed, or if they are present for a long period of time, or some genetic event is activating the inflammasomes and maintaining the chronic inflammation for a long period of time, then probably we know that chronic inflammation is associated with squamous cell carcinoma. So probably that can be a role, that can play a role in the pathogenesis of carcinoma.
Okay, thank you, doctor.
Thank you, ma'am. Thank you, ma'am. Now,
Yeah, that's an interesting entity that you have presented here, Doctor. I think I have no further questions. I think already my ma'am has asked the questions. Yeah, carry on. Thank you.
Thank you, sir. Next is faculty paper 05.
Yes, ma'am.
Okay.
My screen visible, ma'am?
Yes, ma'am.
Yes. Good evening, sir, ma'am. The topic for my presentation is evaluation of antifungal efficacy of pepper beetle and Vitex trifolia against albicans and non-albicans in vitro and in silico studies.
Screen share, please do the screen share. Huh?
Yes, ma'am. I screen shared it, ma'am.
Full screen. Yeah.
Yes. So moving on to the rationale, most of the mucocutaneous opportunistic infections in humans are caused by the species of Candida. Phenotypic switching, pigmotrophism, and polymorphism are most of the causes for this transition from commensal to the pathogenic form. And recent studies have documented the surge in non-albican species compared to the albican species. So most common non-albican species includes Glabrata, Crucifera, cephalosis, and now the emerging Candida auris. So Candida glabrata is one of the non-albican species which differs from Candida albicans as it lacks phenotypic switching and it proliferates within the macrophages to contribute for drug resistance against the antifungal agents, and it is most common in immunocompromised people also. So moving on to the need for my study, most of these antifungal agents show drug resistance and adverse effects. So this prompted the need for the effective alternatives. So the phytoproducts have been reported in literature to have potent antimicrobial properties as they are less toxic, more effective and easily available. So the aim of my study is to find the antifungal efficacy of these phytoproducts, namely betel leaf, which is called as the neglected green gold of India, and Vitex trifolia, Cervarobin imarini, against Candida albicans and Candida glabrata. Moving on to my objectives, to evaluate the antifungal efficacy of pepper beetle against albicans and glabrata, then to evaluate the antifungal efficacy of Vitex trifolia, called as Nochi, against albicans and glabrata, to compare their antifungal efficacy and to prove it through molecular docking and in silico study. So this is my methodology where the leaves were procured for betel leaves and Vitex trifolia. They were powdered and 25 grams of the powder were mixed with 20 ml of 96% ethanol and it was left for 3 days. Then it was filtered with Wagman's filter paper. Then the solvent was allowed to evaporate by means of hot water bath to yield the crude extract. Then that particular dry concentrate was dissolved in DMSO, dimethyl sulfoxide. This is the preparation of extract. Moving on to the determination of antifungal efficacy, the strains of both albicans and glabrata were obtained from high media and they were inoculated into SG broth, Sabados dextrose broth, and the suspension was treated to the differential media, which is chrome agar, and incubator. So these apple green colonies were suggestive of Candida albicans and these pale white colonies were suggestive of Candida glabrata. And these were also inoculated into the wells created on Sabaros dextrose agar, and the extract was added to those wells and it was incubated at 37 degrees Celsius for 48 hours. Then moving on to the molecular docking methodology, we use these three tools, NGL tools and Autodoc Vina version 1.5.6 and then Pymol to do the molecular docking. The ligands and the protein were downloaded from Protein Data Bank and PubMedChem and they were analyzed for in silico analysis through these. Moving on to my results. So the positive control that we used was fluconazole and the negative control was DMSO. So for positive control, we got around 30 mm of zone of inhibition and for negative control, it was 8 mm. And the zone of inhibition for Candida albicans using betel leaf and then for Vitex trifolia. Similarly for Candida glabrata, this is for betel leaf and this is for Vitex trifolia. So for Candida albicans, betel leaf gave 18 mm of zone of inhibition, whereas it was more for Vitex trifolia, which is 22 mm, and for glabrata, it was 16 with betel leaf and
18 with Vitex trifolia.
Ma'am, you have 1 more minute left.
Yes, graph showing it, and moving on to the molecular docking. So we could see that it docked very well betel leaf against Candida albicans, whereas we could not see any docking for glabrata. Similarly, Vitex trifolia also showed docking for Candida albicans, whereas it was not there for Candida glabrata. To conclude, antifungal efficacy was trifolia was more against Candida albicans as compared to betel leaf and as compared to Candida glabrata also. So moving on to discussion, Severity et al., Kepech et al., Selvaraj and Makar et al. Are few of the literatures in the manuscripts in the literature who studied the antifungal efficacy against albicans and non-albican species, and they proved against for betel leaf. So these are the limitations of my study. I didn't try different concentrations in other solvents, and I didn't try for MIC also. So for future perspectives, I would like to proceed my study with other phytoproducts and also to identify their active biocomponents using HPLC. So these are my references. Thank you. Thank you, sir.
Thank you, ma'am. Now over to you, Dr. Maya, ma'am.
Can I ask first? Dr. Pramod.
Yes, yeah, Doctor, I think you have a, a very good presentation there, and you have done, I think, good work regarding that. I think further work has to be done, as you have mentioned. I think it's a promising area of research that you are doing. I have a, I think you have mentioned that you have to do different concentrations also, isn't it? Just to test efficacy again. So I think this looks like a promising field, but then I think further studies are needed to really validate the findings, isn't it? Yes, no more questions. Yeah, Dr. Maya.
Yeah, it was a good presentation only, and yeah. We'll go to the next one.
Okay, ma'am. Okay. Next is faculty paper 06.
Yes, madam.
You will be given 30 seconds for screen sharing.
Is it visible, madam? Hello? Is my
Yes, ma'am.
screen
Yes, ma'am.
visible?
Yes, ma'am.
Good evening. Good evening, respected chairperson and my dear colleagues. Today's topic of my presentation is lymphocytes in oral cancer, anti-tumor or pro-tumor activity. The natural immune response depends on the synergy of adaptive and innate immune system. In the early neoplasm, the immune response acts like that of an acute tissue injury. As the cancer settles, the kinetics of local microenvironment of the tumor will make it difficult to differentiate between the reaction as that of an injury or infection or that of carcinogenesis. The concept of immune surveillance is extended to encompass not only the protective role of immune system in tumor development, but also in selecting the variant of the tumor. The converted cells will produce certain antigens which are specific to the tumor, called as tumor antigens, tumor-specific antigens, or some antigens which are also seen on some normal cells, which are called as tumor-specific antigens. And this can be achieved by any of these steps. The immune system of the body will try to eliminate the developing cancer with the help of any of these cells, that is cytotoxic T, natural killer, macrophages, or antibodies produced by plasma cells. To set in as a cancer, the developing tumor will have to invade the immune system by a process called as immune editing, which would involve any of the listed steps. The initial immune surveillance with immunoediting follows three phases, popularly known as 3 E's: the elimination phase, equilibrium phase, and the escape phase. Now, once the tumor is set in, the cells of the tumor, in association with the inflammatory cells of the tumor environment, plus the cytokines and the molecules that are released with the stromal cell, constitute what is called a tumor microenvironment. Considering the immune profile of the tumor can be classified as cold tumor, which do not have inflammatory cells, or hot tumor, which are also called as inflamed tumors. Coming to the cells of the immune system, the cytotoxic T cells are the first line of cells, which are CD8 positive cells. They do not act in isolation, but also require activation by the chemokines, the molecules produced, the other inflammatory cells, stromal cells, as well as the neoplastic cells. They act by directly acting against the tumor cell by interaction by production of enzymes, or by activating the fast receptors on the target cells, leading to apoptosis of the target cells. The next cells are the T helper cells, which are CD4 positive. They can get differentiated into Th1 cells in presence of interleukin 12, which has an anti-tumor effect, or in Th2 cells in presence of interleukin 4, which act as a pro-tumor cell. T helper 1 cells will produce interferon gamma, which act directly on the cytotoxic T cells. It can also have a direct effect on the tumor cells by inhibiting the proliferation, angiogenesis, and promotion of apoptosis. The T helper 2 cells produce interleukin 4, which has direct immunosuppressive action on CD8 positive cells. Macrophages are the cells of mononuclear phagocytic system and are the final differentiating cells from circulating monocytes. They enter into the tumor microenvironment by chemotaxis as well as hypoxia. In the tumor microenvironment, they are called as the tumor-associated macrophages, and supposed to have anti-tumor activity by acting as antigen-presenting cells as well as cell-mediated cytotoxicity. They are also supposed to activate the navy and memory B cells. The tumor-associated macrophages in the tumor microenvironment can differentiate into M1 cells in presence of interferon gamma, which acts as antigen-presenting cells and anti-tumor effect. The M2 cells are polarized because of interleukin 4. They produce inflammatory cytokines as well as activate the immunosuppressive cells. The next are the natural killer cells.
You have 1 more minute left.
Which act by non-classical member of major histocompatibility complexes and have act against cancer cells. Coming to the immunosuppressive cells, the regulatory T cells are CD4 positive and have an immune suppressive mechanism by directly acting on dendritic cells by release consumption of interleukin 2, acting on cytotoxic T cells by enzymes, activating immune checkpoints, and involvement of suppressive metabolites. The myeloid-derived stem cells are arising from hematopoietic stem cells, either a polymorphonuclear or monocytic lineage. Their immunosuppressive action is by activation of TREG and Th2 cells, competing with antigen-presenting cells, release of arginine, which release nitric oxide at reactive oxygen species, activation of immune checkpoints, as well as suppressing natural killer cells. The other cells, like mesenchymal cells, hypoxia in the environment, as well as reactive.
Ma'am, your time is up.
Activate these.
No, ma'am, your time is up.
That's it, madam. Last slide. This is a chart showing the immunoediting process. To conclude, the status of immune system dictates the prognosis of the cancer. The balance between lymphocytes as well as the combined effect of tumor microenvironment will dictate the T cells to be either pro-tumor or anti-tumor effect. Thank you.
Thank you, ma'am. Now over to you, Dr. Pramod sir.
Thank you, doctor. I think that was too much of information that you have provided us within these few minutes. And I congratulate you on, trying to make sense of it all. So I was trying to make sense of it, and I think I've got some idea, but not the complete sense of it. But I think it's a good topic that you've taken. And yes, whether it is anti-tumor or pro-tumor will depend on a variety of factors, I think. Questions as such, I don't have. I think I'll pass it on to Dr. Maya.
Yeah, it was a good presentation. Are you planning any study on this?
Yes, ma'am. I want to study the TREG cells.
Okay, what is this immunoediting? You told about immunoediting, no?
Ma'am, whatever immunity is present initially is for removing the tumor, eliminating the tumor. But the cancer cell as well as the stromal cells produce certain chemokines which will modify the effect of immunity from being anti-tumor to pro-tumor.
So the chemokines are actually editing the process from anti-tumor to protein, which will later help in profession. Yes.
Is it something like a therapy which can be used? Something like that?
Not inhibition of checkpoints plus preventing this immunoediting is the line of treatment that is being tried now.
Yeah.
Other than the radiotherapy, chemotherapy, and surgery of carcinoma.
Yes. Thank you. Thank you, Doctor.
Thank you. Thank you.
Thank you, ma'am. Next is faculty paper 07. Faculty paper 07?
Yes, doctor.
Okay.
Is it visible?
Yes, ma'am.
Yeah.
Please stop sharing this, the lymphocytes. Yeah, visible.
Okay, ma'am. Good evening to all. Right. We have seen severe acute respiratory syndrome, coronavirus, SARS-CoV-2. None of us can forget the pandemic caused by this virus, which had resulted in a serious global healthcare crisis and also strained the health resources. Due to this, some of us lost our own and some have fought the infection in the hospital and returned home. So following this COVID-19 infection, various systemic and oral complications have been reported recently. However, there is still a dilemma about the oral manifestations, whether they occur directly due to the coronavirus infection or due to some secondary factors resulting from the patient's systemic condition. And most of these oral infections are diagnosed only after the discharge of the patient. So like my topic or the report is basically related to COVID infection and the opportunistic infections following a COVID infection. The title is A Deceptive Infection of the Jaws. Like a 47-year-old male reported to a dental OP with a complaint of pain in the right lower posterior region, which he had for the past 1 month. And clinically, he had a limited mouth opening and a bony heart swelling was evident in the lingual cortex, extending from 4.4 to 4.6 region. And on palpation, there was no pain. It was not tender or anything. When the history was asked, he revealed that he had undergone a hemimandibulectomy 10 years ago for osteopetrosis in the left mandible. And he is a chronic diabetes for the past 7 years and is under medication for the same. And around 8 months ago, he had been affected with COVID-19 infection and was hospitalized and treated with high doses of IV steroids. Recently, around 2 months ago, he had undergone a root canal treatment for 4.6, after which he had placed a ceramic crown in that particular tooth. And like 1 month ago, he started developing the pain and he had gone back to the same dentist, thinking it could be because of the root canal treatment, and the dentist thought it could be a residual infection following root canal treatment, just put him on antibiotics. But still he was having the pain, so he came to us. On taking the orthopatogram of the OPG, we were able to elicit an erosive pattern of lysis in the marginal sclerosis at the roots of the 4.4, 4.5 and 4.6 region. You will be able to visualize, it's not very clear, but this was the radiograph we were able to collect from the patient. So based on the history, the clinical and the radiological findings, clinical differential diagnosis of osteopetrosis and peripheral infection was considered. Following routine blood investigation, the patient had underwent surgical intervention, that was biopsy was done, the entire tissue was removed and curated, the area was curated and sent for histopathological evaluation. So we had done a routine hematoxin use in staining. So at 4x view, we were able to appreciate tabacally of necrotic bone with empty lacunae, and the granulation tissue was also evident. At the resorption bony sequestra, we were able to elicit some microorganisms, filamentous microorganisms. Under 10x view, these resorption bays exhibited deeply stained basophilic actinomycotic granules in the form of radiating filaments with prominent peripheral eosinophilic club ends. Between the necrotic bony sequestra, granulation tissue was exhibiting with non-specific inflammatory cell infiltrate and extra-ulcerated RBCs were also evident. At 40x view, we were able to appreciate more of these deeply stained basophilic radiating filaments with a prominent peripheral eosinophilic clubs, like resembling like a typical sundry appearance. Right. Following your routine hematoxylin eosin, we had done special stains. Periodic acid shift was done. In that, we were able to appreciate a strongly PAS positive filamentous structures at the resorption bay area of the necrotic bone. Again, another special stain, gram stain was also done. Here also we were able to appreciate a gram-positive filamentous branching bacteria at the resorption bay area. So based on these history, the clinical, the radiographic, and the histopathological and the special stains, final diagnosis of actinomycotic osteomyelitis was established. After which we had the remaining tissue which was there because the entire tissue was curated. Still, we wanted.
You have 1 more minute left.
Okay, so some more surgical, the remaining tissue was curated and the patient was put on antibiotic therapy, that is amoxiclav 625 milligrams for period of 6 weeks duration. I don't have time, right? Can I go to the conclusion part?
Yes, ma'am.
Okay, sorry. So like, right. So we know that COVID-19 is usually with its treatment, and if the patient has diabetes, there's an increased possibility of opportunistic infections like your actinomycosis. The usual presenting symptom will be related, we think, in terms of tooth-related pathologies only, and we'll treat it for the same, to which the patient might lose precious time in it. So it is really necessary for every dentist to follow a few steps so that they can accelerate the diagnosis in such patients so that antibiotic treatment can be initiated at the earliest. So the steps which can be done are a thorough history of COVID-19 with medications used for treatment, obtaining a history of systemic illness like diabetes mellitus, any taking IOPA, OPG, CBCT if required. It usually helps in assessing the...
Ma'am, your time is up.
Okay, sorry.
Thank you, ma'am.
Yeah, thank you.
Now over to you, Dr. Maya, ma'am.
Yeah, it was a good case. Actinomycosis along with COVID. And how many cases are reported? I just want to know the review of it. You couldn't present anything.
Right, I was not able to do that. Usually it occurs in the maxilla, the commonly it's very associated in the maxillary region. Of late till now, we had seen around if we go back to the reviews, we had seen around 10 cases. Mandible was 5 cases only. Because we are writing the literature part right now, so I was able to tell now.
All these are COVID related only, or previously also this kind of osteomyelitis was reported, or actinomycotic? Bacterial osteomyelitis is very common, but actinomycotic.
In relation to COVID, we are talking about in relation to COVID. After following a COVID treatment because of the systemic illness and due to the corticosteroid therapies, some of them have developed these actinomycotic osteomyelitis, similar like mucormycosis. So the cases which I had told is related COVID following actinomycosis after COVID.
Okay, thank you.
Thank you, ma'am. Now over to you, Dr. Pramod.
Doctor, I think that this was a very interesting case. I was just listening keenly. Why did you, link it with COVID regarding this osteopetrosis?
Osteomyelitis is very commonly seen, right? I know that because that initially Otto, when he had a history, right? He had a history of osteopetrosis. That time he had osteomyelitis. The left side mandible was heavy mandibulectomy was done. So based on that only, we thought it could be a clinical diagnosis of osteopetrosis. So we were like histopathology, we are trying to put it as osteopetrosis. Then we were able to find these organisms in only few specific areas, not in all the areas of the sections. So like after that only we did all the special stains, and finally we confirmed. When we did the second surgical procedure, we had given it for culture also. That time it came as a positive, as actinomyces israeli. So based on that only, we thought it is an actinomycotic osteomyelitis, not because of osteopetrosis. Could be a predisposing factor. Osteopetrosis could be a predisposing factor also in this condition.
Interesting. Thank you, doctor, for a very interesting case. I think this was very enlightening, actually. But I think we have so many oral manifestation coming up that is directly or indirectly linked to COVID. I think further studies need to be done on this, and I think studies are still coming up regarding which are the lesions that can be directly implicated with COVID, isn't it?
Yes.
Thank you very much, doctor.
Thank you.
Thank you, sir. So next is faculty paper 08. Faculty paper 08.
Yes, ma'am.
Okay, you will be given 30 seconds for screen sharing.
Sure. Is my screen visible, ma'am?
Yes, ma'am. Please make it full screen, ma'am.